truly like SARS 2.0 has re-arrived. And so something that we've been preparing from yearly drills since 2003. And so this then escalated all the way to the medical officers. And then, of course, we start flight inspections the very next day, the first day of 2020. And so this, in addition to the toll-free number 1922 and many other collective intelligence systems, including the chatbots, 机管家, and so on, allowed the entire Chinese society to crowdsource, as you are doing now on Slido, the best responses in real time, responding to the actual situation at hand, instead of just a handful of experts who may be like very professional, but certainly is not everywhere in Taiwan, right? And so this is, I think, at the core of our digital social innovation system, which is fast, fair, and fun. Okay, and now we have some questions. So I'll just move to the question for the next 15 minutes. Okay. The 5 people would like to ask me, whom do I think will win the election, Trump or Biden, right? So my answer to that is that if we think about this, deliberate about this, and gather all the information about it, and think very closely for 2 weeks, then we will arrive at a result. And so, and someone will win, Trump or Biden will win. And that's, I think, what everybody with a scientific training can say nowadays. Is a probability thing, and I do not know who will win for sure. But if you're interested in that, there's like Nathan Silver's website and so on, many other posters websites that you can consult. 2 people would like to know, how was it that decided to utilize the information technology to address the threat of COVID? Very good question. Interestingly, when SARS 1.0 gets to Taiwan, that was around the time when we in Penghu, in the Pescador Islands, started rolling out the IC card of our national health insurance card. And it actually made a really good case of the use of the IC card, especially in the time of pandemic, because first it reduced the chore of the handwritten national insurance card, and also it allowed the IC card to automatically dispatch into the system of early responses without having to wait for people to tally the statistics at the end of the day. So the pilot test in the Pescador Island in Penghu was quite successful, and SARS 1.0 is actually one of the digital transformation impetus that convinced the people in mainland Taiwan, the main island, that we also want something like an IC card in the Penghu Island. I bring this up because in this time, people instinctively think about the national health insurance card because it covers not only 99.99% of citizens, but residents too. Because in the time of the coronavirus or any other pandemic, if we do not protect the people who may not have a citizenship status, may not have the voting rights or whatever, then they actually are the most vulnerable people when it comes to the pandemic. And so people think of the national health insurance cards as something that's maximally inclusive, which is good because people who are born, I think, just takes 3 days or 4 days to get a national health insurance card. And so it's on everybody's mind. And also for the past 4 years, we've been adjusting our procurement strategy. Instead of a siloed applications that works toward each agency's goals, when procuring information technology services from system integrators, we have nationalized the standard, the open API standard from the Linux Foundation. So if you have used a website before in Taiwan, the government website, you may notice 3 columns in the top left corner, and it's like 6 dots, looks like a braille display. And if you see that, it means that it's accessible. It's universally accessible for people with blindness, for people who do not see well, and so on. They can use all sorts of assistive technologies to read aloud the website and interact normally as people with sight. And this same procurement principle that convinced all the, forced all the system integrators to work with accessibility standards, we extended 4 years ago to work with machine-to-machine protocols. So if they build a website, build an information system, and say it's only good for humans to use, but not good for other machines to use, then we can disqualify them the same way that we disqualify the information vendors that are not accessible, saying that they discriminate against robots or something. Well, we don't quite say that, but the procurement rule says that in effect. And so because of that, when we built those systems, for example, the newer system of text filing software and so on, all of them have this kind of plug and play Lego block-like modularity in it through the APIs, the application programming interfaces. And that's what enabled all of this to be hooked into the National Health Insurance card system so that we can, for example, ration out the mask, reusing the same user interface of refilling a chronic prescription from the pharmacies because that's what people are already familiar with. And that's how we can then use the NHI card like filing a local tax and a local convenience store. And all in all, the 6,000 or more pharmacists and the 12,000 or more convenience stores altogether enable the mask rationing system. There's many other examples because for the interest of time, I'll just use this one example. But the API over KPI is very important when it comes to procurement. All right. What and how do you do with ICT technology to help the reopening of the border for traveling? Excellent question. One of the most important border control measure in Taiwan is the digital fence. And in digital fence, again, we do not collect new data that we didn't collect before the pandemic, because if we do that, then the privacy implications, the cybersecurity implications will be not as well understood. If we make a new technology during the pandemic, then of course people can be reasonably wary of this new technology. And the digital fence uses tried and true technology, which is the same technology that people receive a SMS when there's an earthquake, advanced earthquake warning, or an evacuation warning when there is a sudden flood, both of which happens quite often in Taiwan, well, except typhoon, which doesn't happen this year. But anyway, so people understand that the SMS, of course, doesn't read your email. It doesn't infringe any of your application layer security. It works regardless of whether you have Bluetooth or GPS or even Wi-Fi or any of the other connectivity technology. It doesn't know where you are. It just knows roughly where you are in the vicinity. And so based on this design principle, we make sure that when people who choose to home quarantine instead of going to a physical quarantine hotel, in those 14 days, we make sure that the digital fence works in a way that's minimally privacy invasive. And by the time that they finish the quarantine, then they're okay with that. Because the telecoms never really share the data to other companies and so on, there's minimal chance of the leak of the privacy information. And so after, of course, we explained how the system works in a parliamentary interpellation and public hearing session, the approval rate of the CECC measures grow from 91% to 94%. But we still thank the other 6% for keeping us honest and accountable. And when we're now gradually opening up the borders and providing for example, like important diplomatic bubbles and things like that, it turns out that we can actually repurpose this triangulation so that it's not a static bubble, but rather a moving bubble, so that the bubble can travel with the person if they have a prefixed like schedule of travel to make sure that they do not, for example, suddenly take public transportation or things like that. And all of this, of course, are still within the constitutional limit because we never declare a state of emergency, and that enable a more flexible way of working with the digital quarantine measures. So now I'm supposed to translate the Mandarin questions to English. Okay, let's see how I work as an interpreter. So 8 people would like to know, because of the good record when countering the pandemic with no lockdowns, then the international status of Taiwan has risen, or at least people talk about Taiwan more. From my perspective, such a good performance, is there something that's still missing from it? And which are the missing angles? And how can we convert those good performances into a slogan that will enable more meaningful participation of Taiwan into the World Health Organization or the United Nations, and how to enable this kind of functions? This is an excellent question. So we already have a really good slogan, and I believe that the Ministry of Foreign Affairs worked with the Ministry of Health and Welfare on that slogan a couple of years ago, and it's called Health for All, Taiwan Can Help, and this is our main message. Before, people think of Taiwan and WHO or UN and think Taiwan needs help. But after that slogan rose out, we flipped the narrative, saying that actually, you know, we don't really need the help. We're doing quite well. But if you want to counter the pandemic, or if you want to counter the infodemic that's associated with the pandemic without resorting to authoritarian measures, if you want to keep your democracy and your economy while fighting the pandemic, then really there really is nothing that prevents you from looking at the Taiwan model, learning from the Taiwan model, because we're a country with good open innovation records. We will co-create this model with you. And so this is, I think, a really good angle, a really good narrative. And when you just spread it out, the idea that it's not a zero-sum game between public health on one side and human right and privacy on the other. Or when it comes to an infodemic, it's not a forced choice between the freedom of the press, of the speech, and so on one side, and the public awareness and resilience against cognitive warfare, right? And this is what Taiwan have time and time again proven and just published in, for example, taiwancanhelp.us, which is a great website, and it's not even sponsored by the government. It's crowdfunded, maybe by you, right? It's crowdfunded and crowdsourced by some very young YouTubers and sharing the Taiwan model to the all the audiences across the world. So I think that answers the narrative question. And so, are there anything missing from it? Well, I think it's often kind of overlooked how important the trust from the government to the citizen is. So I often tell the story of how the CECC, the Central Epidemic Command Center, decided not to impose any penalty or to force closure of the intimate drinking bars and dancing clubs when it occurs that the contact tracing and their professional respect of privacy may be at odds. Instead of the CECC just said, we trust the business owners to do the right thing. We explain the scientific crux of physical distancing, and then they co-created this real contact system, or 实联制, instead of the real name system, 实名制, that says as long as we can contact the people there within the last 2 weeks in any business, they don't have to give this data to the Central Epidemic Command Center. They can shred it after a few weeks, and then they come up with single-use emails, prepaid SIM cards, or things like that to both keep the contact and also keep their professional respect of their privacy. And once they did that, the municipal governments gradually just allowed the intimate drinking bars and dancing clubs to reopen. I use this example to talk with many other CECC equivalents in other countries because first, it's not intuitive at all. When something like that happens, the CECs in other jurisdictions tend to choose the other way, which is to just force them underground, essentially. But also, it shows the Pygmalion effect in work. If the government trusts the citizens, then citizens become trustworthy and become co-creators. But if you start by saying, okay, these are others, these are people who deserve to be underground, then, of course, you create vulnerabilities within your own population. I think this is an angle that we need to emphasize more, because I think this more truly explains why the Taiwan model works so well without any top-down, shutdown, lockdown mechanisms. 10 people would like to know. So there's many information and communication technology being applied in Taiwan. However, many official agencies develop their own systems. Every municipal systems, every city-wide systems may work very well within that area, but they do not work horizontally. And so for each clinic or hospital, for they to join various projects, the same data needs to be entered many times. So can we interact through those systems instead of forcing the clinics or hospital or people responsible for data entry to enter repeatedly the same data to various different systems? This is an excellent question. And the answer is yes. We are now testing a technology called the T-Road technology that would enable any two agencies within the government service network who has, of course, that's the legal authorization to exchange this data in the first place. It's basically the same as the previous arrangement of shipping CD-ROMs or shipping SFTP or whatever around, which is a very unmanageable topology, and it makes like building new connections horizontally harder than just requiring the person to enter multiple entries. So because of it's harder, so people don't bother doing it. But now with T-Road, each and every agency have to only install one adapter that converts their legacy software entry points into the API endpoints for the T-Road to hook into. And then there's a API management mechanism in each and every ministry, there are 32 of them, that will then enable this kind of agency-to-agency exchange of information, so you can query these data as if they are stored locally, because there's a way to exchange this data. But we can both trace it's very auditable, we can trace the flow of the information, and as a person, as an individual, you can go to the My Data portal at mydata.natgovtw, or just search for My Data, and then use your, well, National Health Insurance card or other digital certificates, and then you can see which agencies hold your data, and you can also audit their use of your data if you saw that your data has been entered incorrectly and so on. Previously, there you have to call like 5 different agencies to get it updated, but eventually through the combination of the My Data portal and hopefully by next year, our Data Protection Authority, our independent authority for data protection, then you can do this in a much more streamlined fashion. So it's actually easy to remember. The T-Row is the horizontal connection between agencies, and My Data is this vertical download of each and every individual and the exercise of their data rights. I think we only have time for one last question. So the question is, so after 5G or during the 5G deployment, how will Taiwan change and how will it impact the medical profession? I think what 5G brings is that the kind of real-time response that whenever you post your Slido question, we're watching this live stream, you can see me nodding and so on, but there is a perceptible delay if we're using live stream platforms. Even with the state-of-the-art televideo conferencing platforms, it requires both sides to have good fiber optic connection and then an Ethernet connection so that we can feel that we are actually in the same room, which is what we have invested a lot because we have broadband as a human right. But there's a limitation in 4G technology, not about the bandwidth, but about the latency. So when you're outdoors, when you're using 4G technology, it never feels quite the same as being in the same room or in a high-speed connection through the fiber optic lines. So what 5G does to me already, because I've been using 5G for the past 3 months now. Anyway, so the experience that I had through 5G to video conference with people is that I can feel the same low latency feeling of co-presence that we're actually in the same room. I actually work a lot with, say, the XR space virtual reality headset, which is not just a VR headset that is controller free. I can just control using my hand, but it's by itself a 5G phone. And so it can work anywhere outdoors, and it has a pair of camera, so I can scan anywhere I'm in, for example, this room, and then I just scan the VR room and send a share link to anyone with another XR Space device, and they can then join me in the same room. And if we're both using 5G, once they nod, once they smile, and so on, I can get the signal immediately in my eyes, so that there's a lot of empty seats here, so I can put on the VR and still seeing you folks, but then the empty chairs, suddenly all the live stream participants appear in the virtual chairs here. And so this will make a true co-presence feeling that will enable a lot of the care work that was previously inaccessible through this very cold and laggy two-dimensional piece of glass to join more of the, not just the medical, but also the healthcare industry. So I really look forward to the day where we're not restrained by the fiber optic lines, but could in any rural places, any indigenous lands, any high mountains and so on, enjoy the same level of person-to-person care through 5G technology. Thank you for the questions. Thank you.
So thank you very much, Minister Tang. And so there's a lot of questions unanswered, but we can certainly carry on the discussions in the end of our panel discussions. I just wonder how many people in the audience who are for the first time listen to Minister Tang's speech. How many people you are the first time? Okay, then congratulations, welcome, because you are seeing, this is really the future communications. You will get used to it. I mean, this is my second time, and I feel really enjoyed it. Anyway, we will talk about the topic later on. Our second speaker is Dr. Long. Dr. Long will talk about how to use the smart technology in combining open data from the weathers and the health and help and create a personalized preventive health service. Let's welcome Professor Long. Dr. Long is actually a senior research fellow in Academia Sinica. Please.
Thank you, and Mr. Tang and all the distinguished guests. Good morning. And the theme of this forum is actually achieving SDG in the post-COVID-19 era, innovation, inclusion, and partnership. Today, I'm honored to represent our team to showcase a great partnership, weather and health for all. This is a partnership of governmental agency, academics, and also private partners. The major partners are Health Promotion Administration, HPA, Central Weather Bureau, CWB, and Academia Sinica. And I will introduce other public and private partners later. And our team just won the 2020 Presidential Hackathon this year. And our team is one of the top 5 team of excellence. And I want to acknowledge our team member first. Here is a photo of Minister Tang and also our team in a review meeting of this hackathon. And also here is a photo of President Tsai and our team member in the award ceremony. And I also want to acknowledge actually the Presidential Hackathon. Presidential Hackathon is actually a wonderful platform to inspire our team to really combine technology and multidisciplinary knowledge in order to reduce health risk in the post-COVID-19 era. The aim of this, the goal of this Weather and Health for All is actually to reduce health risk under climate change by establishing science-based weather health warning system to protect our people, especially the vulnerable populations. And I think climate change has affected all nations. And this year, Taipei has 5 new records, okay? The highest temperature has reached 39.7 degrees Celsius, and we had 12 days above 38 degrees Celsius in the first 7 months. Okay, not only we have hot summer, but we also have warm winter. Shockingly, the warming intensity of urban area in Taiwan is twice of the global mean. And also, worst of it all, the severe heat stroke cases have increased by 3.5 times in the past decade. Based on 5-year record, the heat stroke emergency patient had more males than females, with a difference of 3/4. And nearly 80% of them were at age of 19 to 64. That means that they were probably the major income source of the family. So we have to prevent this situation happen again. And according to the projection of World Health Organization, the additional deaths attributable to climate change due to heat is actually more than those due to other causes, such as malnutrition and other infectious disease. For most of the Asian and Pacific countries, for both the year of 2030 and the year of 2050. So we have to do something in order to reduce the health risk due to heat. In order to reduce the vulnerability due to heat, we have to reduce the exposure of the general public and also enhance their response capacity, especially for the susceptible populations. And an effective warning system is long been recognized as the most important adaptation strategy to minimize health risk. Then what is an effective warning system? That is actually to providing the right information to the right people at the right time to motivate the right action. That is to trigger the responsive actions of a governmental agency and also to trigger the self-protection actions of the general public to reduce exposure and reduce vulnerability. So before this collaboration, and CWB already have daily weather forecasts. They have a weather app downloaded by millions of users and used every day. And with this collaboration, CWB is modifying the weather app with more user-friendly design and also connecting to channels provided by HPA to reach susceptible population with pre-existing diseases. HPA also provide easy understood self-protection messages and infographics. And my group in Academia Sinica provide science-based thresholds for warning system based on data analysis of the historical weather and health data. And IT people, IT experts actually help in design user-friendly platforms and also big data analysis. With this collaboration, okay, we not only want to reach vulnerable population, but also those high exposure population under sun, at work, during exercise, and in class. And Presidential Hackathon actually is a wonderful platform to actually to allow us to form a tri-party collaboration in the beginning. And in the first half of the hackathon, we actually brainstorm in the multidisciplinary discussion and try to focus our human-centered strategy to reach consensus. And in the second half of the hackathon, we actually got inputs from our reviewers and the end users. We reach out for more public and private partners and also win the competition in the end. So in this Weather and Health for All, we actually select science-based thresholds for the warning systems based on historical data, based on big data analysis for historical data. And every day, according to the actual weather condition, on top of the routine weather forecast, we actually push those health warning messages through different channels, including social media and others, so we can reach different target populations. And we also expand our partnership to other ministries. Ministry of Labor, Education, Interior, and also Council of Education, Council of Agriculture. So those partners provide assistance in 3 aspects. First, they actually revise their laws, regulation, and training material within their own jurisdiction with heat protection strategies. Secondly, they provide their communication channel, so they actually, the weather health message can reach workers, supervisor, school principals, athletes, and farmers, and also emergency emergency medical technicians. So the worker supervisor and school principals may decide to switch, to change work schedule or a class schedule to minimize health risk. And thirdly, those partners, they also provide resources to purchase risk reduction equipment for those vulnerable populations. So with this multi-agency collaboration, we are actually reach different target populations, also providing risk reduction equipment and strategies. And we also extend our collaboration to private sector to reach other business and consumers to protect health of all citizens. And for example, we collaborate with convenience store and drug stores in health promotion marketing. So thousands of stores, they provide resting areas and water dispensers for outdoor workers and also people in need. We also, with our data information service and also public-private partnership, we are able to reach more target populations and also trigger practical responsive actions of those public and private sectors, including hospitals, for advanced preparations. And moreover, with open data, we actually create an ecosystem to enable development of customized service of other private companies to reach different subpopulations. With all this, so we will meet our goal to provide the right information to the right people and at the right time to motivate the right action. Currently, CW is modifying the app to have personalized warning. So according to your health status, time of the day and location, it will provide you health warning in real time. For those elderly who don't know how to use app or the busy worker who don't have time to use app, this app has a friendly interface switch for caretakers. So you may switch to caretaker interface to send message to your grandpa, your spouse, to remind them for action. And we also connect to commercial apps to reach COPD patients and asthmatic patients. Those commercial apps already collaborate with other hospitals, so the doctor can give advice to patients right away. And this is an example for elderly COPD farmers who may get personalized notifications throughout the day and also get active push alerts from his wife, his grandson, his doctors, or other commercial apps to to remind him to take actions to reduce his own health risk. So before, we have weather app downloaded by 1/10 of Taiwanese. And with this partnership, we may reach more than half of the population and in real time. So this is truly weather and health for all these populations. And this is just the beginning. We start from heat, and later we are going to focus on health risk due to cold. So we are going to identify susceptible population with our national health insurance database under different extreme weather events. And with this valuable information can help our healthcare system to further minimize our health risk under climate change. So in the post-COVID-19 era, we are going to facing different health challenges. And today I'm demonstrating a great partnership with innovative thinking and also inclusive strategies. We believe that with multidisciplinary and multi-agency collaboration, human-centered perspectives, innovative thinking and technology, and science-based policy, we can tackle all the challenges ahead and meet those SDGs and leaving no one behind. Thank you very much. That's my presentation.
Thank you very much, Professor Long. the excellent talk, and also congratulations for winning the presidential hackathons. I think this is a wonderful example of how to apply the smart technologies into our daily life, and also examples of how to bring different agency working together, so building a partnership. Now let's move on to our next speakers online. Dr. Robert Smith, the Senior Vice President, Cancer Screening, American Cancer Society's Atlanta of USA. Bob, are you online?
I am. Can you hear me?
Yes, very well. Okay. And so Dr. Smith is going to talk on how to minimize the health cost of suspending cancer screening during a pandemic and other disruptions in the delivery of preventive care. Please, Dr. Smith.
All right. Now, I hope this is showing up well. Yes? Good.
Hold on. We are getting there. Yes, I think we got it. Yeah. Okay. All right. Dr. Smith, I think we can get the slides and see you all right. So please.
All right. Thank you very much. I'm a long way away, as you know, but I'd like to thank the organizers. I'm very grateful for the invitation to return to the Global Health Forum. I also would like to send greetings to my long-standing colleagues in Taiwan. It's very nice to be with you all again. I'm going to be talking about minimizing the health costs of suspending cancer screening during pandemics. This actually applies to other chronic disease care. And as you'll see, there have been some costs to meeting the needs of those infected with the virus, but neglecting the needs of those with other health conditions. We all saw around the globe, health services were overwhelmed with COVID-19 cases very suddenly. In fact, in my state in Georgia in the United States, where you might have expected the pandemic to take off in the larger cities, we had our first outbreak in a small town in southwest Georgia that arose as a result of one person attending a funeral. As the virus spread, the hospitals were compelled to devote all available resources to patients infected with COVID-19, and that meant that other kinds of care, which was described as non-urgent care, non-essential care, was suspended, principally to the need to divert resources and the uncertainty about the level of resources that would be needed day to day, and also the need to not put healthy people at risk for contagion if they were coming to the hospital for services. As of today, what was certainly described in my country over and over again as something that would end very quickly, the pandemic is still with us. We have had globally over 1 million COVID-19 deaths. We anticipate in the what known 41 million and more global cases, and we know there's many more than those, that there will be long-term lasting effects that we're just now beginning to learn of. And we also saw that medical separation, not only medical separation that was imposed on the population, but the degree to which people did not seek health care for symptoms, also from COVID cases themselves, has led to an increasing number of deaths. And again, as I noted earlier, the suspension of preventive and diagnostic care is going to result, has already, in an increase in advanced cancer rates and deaths. We also have seen that there has been a slow return to routine care. In fact, this has been seen all over the world, that even once you reopen services, the public is wary of the risk of exposure and have actually continued medical separation. Because this pandemic has now into its second and in some places third wave, this rolling series of outcomes is likely to be repeated again and again. Now, it's not entirely new. There is a growing literature and a growing awareness of older literature that have measured the effects of disasters on healthcare outcomes. This was a recent study that was published looking at the effect of a sort of a disruption of services in the cities affected by hurricanes compared to cities that were not, in looking at the mean survival time and the 5-year survival of lung cancer patients undergoing radiation therapy. And what we saw that in the exposed group, those were patients that were in disaster areas with relatively long durations of the declaration of a disaster, that the mean survival time was lower and that the 5-year survival was lower. And this is principally as a result of the disruption of therapy, post-surgical therapy, radiation therapy for people diagnosed with lung cancer. Now, in the U.S., and I'll give you examples from several countries, the U.S. declared a national emergency in March. The Centers for Disease Control recommended that healthcare systems prioritize urgent visits over what they described as non-elective care. Many of our professional societies and the American Cancer Society, where I work, recommended that no one should go to a healthcare facility for routine cancer screening until further notification, and others said essentially the same thing, that elective care could be postponed. There wasn't, however, any real understanding or expectation as to how long this delay would be. And I think in general, the assumption is that it would be short-lived, that it would be a brief interruption in care, and then services would reopen and they would undergo a period of catching up. Once services shut down, and it was really rather abruptly, we don't have the greatest data in the US, and it takes us a while for these data to accumulate. But these are data from electronic health records from almost 3 million patients from 39 organizations representing 190 hospitals in 23 states. And I just draw your attention to what looks like a little waterfall in every one of these trends. And that's literally when the line for 2020 compared to 2017 and 2018 that showed, for example, that breast cancer screening declined from about 10,000 examinations each month to a little over 550. So we saw a rather abrupt drops, rather rapid drops in cancer screening, colorectal cancer screening, breast cancer screening, and cervical cancer screening of between 86 and 94%. From another data source, we saw similar decreases, mammograms down 87%, pap smears down 83%, colonoscopies down 90%, and so on. Literally, people were staying away from these tests, and they weren't even available. A decline in colonoscopies, this is data from a large national lab, was associated, an 89% decline in colonoscopies was associated with a sharp decline in the diagnoses of colorectal cancer. And other data from lab, literally from all cancer types. And this also is an indication of people not seeking care for symptomatic disease. In other words, this is not cancer detected by screening, although these include cancers detected by screening, but also those cancers that are diagnosed as a result of a patient who is symptomatic, finally reporting these symptoms to their physician and seeking care, and it turns out to be cancer. Rather dramatic declines in colorectal cancer diagnoses, lung diagnoses, gastric cancer diagnoses, breast cancer diagnoses and others. Surveys of breast cancer patients also showed the extent of associated care that also had shut down. There were fewer genetic testing, less oral therapy, surgery was delayed, radiation therapy was delayed, diagnostic imaging and testing was significantly delayed, as well as surgeries for breast reconstruction and follow-up appointments. Now, in contrast, and I can like to take just a second to congratulate the Taiwan, its leaders, and its population for the very successful way that it handled the virus. It's an example for the whole world to follow. Taiwan quickly implemented quarantine and early case identification, contact tracing, and has experienced a very low impact of COVID-19 on its healthcare system. It still has to be vigilant. I've been keeping up with this in the news, but unlike many other countries in the world, breast cancer screening was not suspended. And yet, it's very clear that the public was wary of going to the hospital where they might get a mammogram in the hospital. And then as additional news reports came out of, continued infections, there were declines in mammography screening in the primary care setting and mobile units, again, likely due to women's consideration of risk in different settings, and also indicating a very clear need to have really strong communication programs with the public and reassuring communication programs that it is safe to return to screening and that all necessary steps are being taking place to protect people coming in for these examinations. This is a very, very nice study that was just recently published in Cancer by the colleagues in Taiwan, and it's, I think, very informative for all of us to see that there are some common experiences in every country in the world. In the UK, in response to the COVID-19 pandemic, there was a national lockdown that was introduced in March 2020. Cancer screening was suspended, routine diagnostic work was deferred, and the only urgent symptomatic cases were prioritized for diagnostic intervention, but they also experienced a dramatic delay in being worked up for these people who actually presented with symptoms. And in the UK, there is a model program where you have these symptoms and there's a 2-week wait to see if these symptoms persist before you can pursue to get this additional care. So in this particular study, the authors modeled the estimated impact of these delays in diagnosis on cancer survival and outcomes using historical data going back 10 years for 4 major tumor types. And what they did essentially was model these different routes to diagnoses where, in effect, they would take all the expected diagnoses of cancer that would occur as a result of screening and move them into the reallocated urgent and emergency pathways since screening was suspended. And it was expected that these cases that were diagnosed by screening would then be diagnosed symptomatically. The reallocation scenarios then modeled different degrees of delay in having these symptoms worked up, not only immediately, but over time. In other words, where you could not really anticipate how long services would be shut down. And this is just a diagram of the patterns of delay and wait, and a little discussion off to the right. But the main point is under these 3 different scenarios, one where you would get worked up within a 2-week period, and the others where you would actually experience a substantial delay in being worked up for symptomatic disease. And a third scenario where those delays were prolonged, they have projected between almost 3,300 to 3,600 avoidable deaths. And I think it's important to highlight this, that close to 60,000 years of life lost attributable to delays in cancer diagnoses alone. There would be an increase in deaths also projected due to cancer up to 5 years after diagnosis, ranging from about 5% for lung cancer and about 17% for colorectal cancer. In the US, we also modeled the effect of the delay using the reported by the National Cancer Institute, estimating a sizable increase in colorectal and breast cancer deaths over the next decade. So given all these examples, we can ask these questions, essentially, what have we learned? Clearly, in most national local health systems around the globe, we do not have comprehensive plans for healthcare disruptions. And when I say comprehensive, I mean plans that would affect all the population, that it will be affected by this disruption. The reaction to the pandemic was to prioritize care for those who would be infected and set aside non-urgent care. But it's quickly become apparent that much of the suspended health care is neither elective nor non-essential. It might be for a short duration of time for some people, but not for many others. And it's important to keep in mind that when we think of elective care, for example, a knee surgery that could really be postponed indefinitely, cancer is really not elective or non-essential. It's a leading cause of death. It is a leading cause of pre-mortality, and projections have revealed that we will pay a fairly heavy cost associated with delays in diagnosis that will be measured in higher rates of advanced disease and higher cancer deaths. It is not as if we don't have emergency plans. Now, people have, sort of joked that any hospital's emergency plan is often covered with dust because people don't even know where it is or look at it very carefully. But these emergency plans are quite common, but they principally focus on disease outbreaks and the resource needs needed to meet them, but more typically disasters. And here the plans focus on victim needs, acute and emergency care, where the hospital itself is in the path of this disaster. There is how the inpatient care should be handled and how patients who need evacuation should be handled, how to cope with damage to the health infrastructure, and particular loss of power and flooding, and how they can plan to return to usual services. A review of these plans also showed that the common assumption is that these disruptions and reallocations of resources will be short-term. There's little evidence of long-term planning for these disruptions and the effect on health outside the hospital setting. There's oftentimes a call to ensure that there's an ability to transfer medical records if patients are moved to other hospitals. But there's also no clear definition of non-essential care, and there's no consideration of when non-essential care being postponed actually begins to become urgent care because you need to start seeing these patients for the care that has been set aside. In every one of them that I reviewed, there is no mention of cancer. So what would a future approach to cancer screening, diagnosis, and treatment during healthcare disruptions look like? Delivering acute and emergency care during pandemics does require a reallocation of resources. There's no question about that. But that does not mean that we should regard cancer screening, diagnosis, or treatment as elective or non-essential. I think these are really the wrong words to use. And what this experience has shown us is that we need a plan in place to triage adults based on risk and current diagnosis and treatment needs. And each cancer should have a specific triage model based on disease characteristics. And the first thing that would likely come to mind to all of you is that cervical cancer and colorectal cancer are slow-growing cancers, whereas breast and lung cancer are faster-growing cancers. Electronic health records could be adapted to prioritize care and divide the population, the target group, into several distinct groups. The information in electronic health record that we need is almost certainly there. Age, risk factors, screening history, and outcome status for adults with positive screening tests. An algorithm could be written that prioritizes the target population into higher and lower priority groups. This would have to be based upon evidence, and it would even allow for delays in service where we could feel confident that those delays were not going to put the patient at risks. But we do need new guidelines to achieve this objective because the evidence on delays is remarkably thin. And let me also stress that this algorithm could be used anytime. So throughout a year when the disaster is not occurring, when there's not a pandemic, people fall out of cancer screening. You could use this algorithm to identify people for whom rescreening, follow-up care, treatment, whatever, was urgent and reach out to them. Now, I've divided these cancers, these not the cancers so much as, but the characteristics of the cancers into three fundamental groups. The group one would be those individuals who have positive findings. They're in a diagnostic pathway at the time of the suspension of services. There are people who have been scheduled for treatment. There are individuals who have new symptoms. They're presenting with symptoms. Group two individuals are at high risk, but they're asymptomatic. These would be people who have an inherited predisposition to cancer. They're at higher risk based on known risk factors. And they are individuals who have not had recent cancer screening, because work that we've done recently has shown that when you miss a cancer screening test, you're at higher risk of being diagnosed with advanced cancer. The third group would be individuals at average risk. And these are individuals who have not had recent screening, individuals who are due for screening within the period of suspended services, or individuals who are not due for screening in the near future. So these group one individuals, these very high-risk individuals, would likely have only minimal care delays due to either having cancer or having a high probability of cancer. Now, as we've seen, there's some recent data, these two papers are just from 2020, that does shed some light on how long you could delay hysterectomy in women with early stage cervical cancer, and how long you can actually delay colonoscopy in individuals who have had a positive FIT test. The latter, in fact, having an association with a higher risk of being diagnosed with invasive cancer, if that positive FIT test was due to a bleeding adenoma, or actually having a more advanced cancer if it was a function of detecting cancer. The authors here clearly say that you should not delay more than 9 months, and preferably these colonoscopies should take place much sooner than that. These group two individuals would be in the second tier for access to care, and some would be prioritized for the same routine care with minimal delay, while others could have a somewhat longer, but again, limited delay in access to care that does not put them at greater risk from an adverse outcome. Finally, the group three individuals would be prioritized mostly based on age and screening history, and some delays in services would be similar to group two, others would be longer again, based upon the likely safety that they would have based on their screening history, their age, and other criteria. They could go longer without screening. But it's also important to keep in mind that for some of our cancers, we have alternative screening tests that could be used. Now, most countries in the world actually are not screening with colonoscopy like the United States is. So FIT tests can be done at home and they can be mailed back into a laboratory. But self-sampling HPV tests for cervical cancer, I think, are going to be increasingly common and provide also a very safe alternative to having the cervical cancer screening done by the gynecologist. As I'm getting close to the end here, the critical need we also need is enhanced communication with the public about screening, and not only the importance of regular screening, because these challenges become much less complicated if people are current with screening recommendations, but also the importance of understanding that cancer screening is not non-essential and that there are plans in place to assure the fullest benefits from cancer care based upon risk that the system will have in place to take care of the target group. And very critically, there needs to be repeated reassurance of safety of screening in health services and when personnel protection is still required. So my final thoughts is overall the world was not prepared to respond swiftly to the COVID-19 pandemic. Some nations were prepared. Taiwan is outstanding, but most were not. Decisions were made to prioritize health services to combat the virus with little appreciation for the potential long-term costs. These decisions were well-intentioned, but there have been unintended consequences, as we have seen. And we can forgive this if we act now to put plans in place for more comprehensive disaster and pandemic response plans that not only focus on victims, but maintain important health services that are also essential to avoid premature deaths from cancer and other chronic disease. And the final thought that I would leave you with is that in the last presentation we heard about climate change, we know it's having an effect on weather. We should anticipate that future disruptions in the delivery care are not going to occur as single events. Pandemics, storms, floods, other disasters are going to overlap. And these challenges to continue to deliver essential health care mean we have to have new strategies and new ways to triage patients and communicate with them. And with that, I thank you very much for your attention and again for the invitation to present at this meeting.
Well, thank you very much, Dr. Smith. I mean, especially during these late hours in your location, we really appreciate. You are absolutely correct that there's a significant damage or impacts on the screening and all other health, preventive service, even in Taiwan, you know, because of the fear of the pandemic. So we will talk about, and also I think it's very important that you share with us the ideas for a future approach. How do we can build a more resilient systems in the times when healthcare can be disrupted or people are feared to go to the hospital and the screening sites, and that's very important. I hope you can stay and we can have the discussion also later on. And now let's welcome the fourth and the last but not the least, a presentation by Vice President of Planetary International, Miss Karin J, and she will talk about the person-centered care, a stabilizing force during times of turmoil and beyond. Let's welcome VP Karin J.
Greetings, good morning. It's a pleasure to be here. It looks like I'm having a little bit of a technical challenge in trying to share my screen, so please bear with me here. Okay, wonderful. Are you able to see my screen?
Yes, yeah, it's okay.
Okay, wonderful.
Very well. Okay.
Thank you. Thank you so much to the organizers for the opportunity to be a part of the esteemed Global Health Forum today, and also to be a part of a panel including the esteemed presenters, Minister Tang, Professor Long, and Dr. Smith. I am here to talk a little bit about person-centered care and how person-centered care can be a stabilizing force during times of turmoil and beyond, especially during the pandemic. I'll start with a little bit of information about the organization that I represent called Planetary, and then move into the importance of person-centered care and really introduce some key practices.
My name is Karin J, and I serve as Senior Vice President for Global Services
to partnering with patients and improving outcomes. Should I continue? Should I continue, or are you playing the recording?
Actually, so we can hear you all right. And so please continue, but we need to see your slides. So could you kind of share your slides online, PowerPoint?
Yes, I'm sorry. I thought I was sharing my screen. So here we go again. Yes. Can you see the slide yet?
Hold on. I think it's running. Yes. No,
oh,
okay.
Wonderful.
Yeah.
Okay.
Okay, please.
All right. So the technology from Chicago to Taipei. Here we go. So a little bit about the organization I represent. I represent an organization called Planetary. We're a not-for-profit organization that was founded by a patient approximately 40 years ago. And this is a picture of our wonderful founder, Angie Chariot. And Angie, unfortunately, in the late 1970s, had a very concerning and severe hospitalization. She was in the hospital for several weeks with a condition that was very difficult to diagnose at that time. And she was gravely ill and in an academic medical center in Northern California. And while she did recover from her illness, she did feel that the experience that she had while in hospital was really significantly lacking in terms of treating her as a human and not a condition. So she was struggling to find a way to change the way healthcare is delivered, not only in the United States, but throughout the world, in terms of making sure that people are respected, that they take an active part in their healing, and that it is a very interactive process between the patient, families, and the care team. So the organization's name, called Planetary, is a little bit of a question most times. And the organization is named because plane tree is the type of sycamore tree that supposedly Hippocrates had taught his first medical students under, and teaching his medical students the importance of listening to the patient, but also treating the patient in a holistic way and not just as a condition. So right now, as we stated, we were begun by a patient. We do a lot of our work around focus groups. So listening to patients, former patients, family members, and staff members as well. We've now listened to millions of people and also are working currently in 30 different countries across the continuum of care. And our real goal is to drive quality. So how do we go about focusing on this? Really, in a simplistic way, we think of this as PhD. We want to personalize and link what the patient wants with how we deliver our care, listen to them, think outside of the box, and listen to their preferences. Humanize, again, looking at the patient in a holistic way and looking at them as a human being with different thoughts, concerns, worries, not just their condition, and also creating a reassuring environment for the care process and demystifying. So providing as much information as we can to our patients about their condition. So today's reality, as Dr. Smith had given such a wonderful presentation about, is such a challenge. In the United States, we're doing not the job that Taiwan is in terms of combating the virus. So we do see people who are afraid to go to the hospital, even with cardiac events. And as Dr. Smith had told us about, several kinds of cancers. People are delaying elective surgeries, their appropriate screenings, and we're also seeing families delay even vaccinations for their children for fear of seeking care. We see about half of the public in the United States that has skipped some type of healthcare event because of fear through the coronavirus, particularly routine care. And we're also seeing that there are mixed messages with what we're sending out. We're telling people to stay at home. Here in Chicago, we are just on our second, what we refer to as lockdown during the pandemic that started in my county just this evening. So many restaurants and other types of places are closed for 2 weeks because we're seeing a resurgence in cases. So we do have that messaging to stay home, stay safe, but also messaging from our healthcare providers that you shouldn't be putting off routine care, you shouldn't be putting off those very important screenings, and you should go seek healthcare, rightfully so, when you need it. Our aim remains the same even during the time of the pandemic. So before COVID, we were all aiming for better care, better quality, better health, and of course, lower costs and a better culture. And this will remain the same after COVID as well. So how do we work in the current time? We need to consider what the current dimensions are of consumer confidence with our patients. They are worrying about, are they safe? If I go to hospital, am I going to be putting my loved ones, my family, my friends that I see in my bubble that I've kept contained, am I going to be putting them at risk? And what is the impact on my own health? Am I going to catch the coronavirus by going to seek care? And what will be the impact on my health if I delay care, putting off those screenings, putting off those surgeries, putting off those things that need to be done? Also, we have a great impact on our emotional well-being, all the different types of fears and concerns that we have. And then also the practical. Is telemedicine effective if I engage in this? Am I going to be able to use the technology? And also a real situation here in the US, if I am unemployed, how can I afford this care? So for considerations, we really want to investigate which dimensions matter most to our community members in this particular point in time. What can we do to make our patients feel safe and secure? And are we communicating our intentions clearly, not sending those mixed messages that we had talked about earlier? And most importantly, perhaps, are our messages reaching the most vulnerable in our community with elders, our community where health literacy may not be able to understand the messaging that we are providing. If we're answering any of these questions without the perspectives of the members of our community, of our patients and families, we're missing an opportunity to build up that trust and confidence and really learn what is important to them at this very difficult time. So how do we build trust and confidence by partnering with patients and families? First, the why. We want to hear firsthand what concerns are and what experiences are for our patients and families. We want to learn from them about assumptions we're making and internal dialogues that we're having within our organization, and do that reality check by listening to our patients, our community members, and our family members. We want to make sure we go back to that PhD to personalize, humanize, and demystify care. And we also want to make sure that our messaging is personalized. We have a wonderful publication that was put out by the National Academy of Medicine a few years ago. And this really provides not only the guiding framework for patient and family engaged care, but also the rationale for engaging patients and family members. We have over 100 resources within this document that make the case for patient and family engaged care. This is actually easy to download, and I will provide you a resource link at the end of the presentation, so you'll be able to have this document if you would like. Some highlights of the document include better clinical indicators and health outcomes by engaging patients and family members. We also see improvement in the quality of interactions, better adherence to treatment recommendations, care plans, and modalities, increased job satisfaction and reduced burnout for our clinical care providers, better well-being for our physicians, and then also, of course, increased patient and staff satisfaction as well. So our framework points to the different elements of organizational foundation, and the evidence is clear. Involving patients in their care is a systematic approach. We want to emphasize empathy as a core competency for all caregivers and focus on personhood beyond patienthood, as we talked about earlier with our founder, Angie Terriot. So how are we going to go about doing this? We want to make sure that we're honoring patient preferences, that we're involving families and friends, providing access to information for our patients, and co-designing with our patients as well. In terms of honoring patient preferences, there are many tools to do this. We want to make sure that our patients know as early as upon admission that we are looking at them in a holistic way. So we really want to learn about what is their preference, not only for their care plan directly related to their diagnosis or their condition, but other types of information. What are they concerned about? What have they left at home? Perhaps it's children. They have a situation with care for their young children, or pets, worries, concerns that impact their ability to heal. but also simple things like what are their sleeping patterns? What are their eating patterns? What are my questions about my conditions and other things that are impacting their well-being, their comfort level, and their security while in the hospital? We want to make sure we're bridging the gap between the communications, between what we think is the care provider and what we learn by actively engaging our patients and family members and listening to them. We want to move towards more informed and respectful discourse in our interactions with our patients and family members. Move to faster but deeper engagement. So ask those questions about what they're concerned about at home. Are they concerned about missing work? All the other things that are beyond just the clinical conversation. Better quest for solutions and outcomes, and a greater understanding of that whole person and not just the patient. Next, we'll talk a little bit about empowering family members. And one of the best ways to do this is structure in your organizations a care partner program. This would be a program where a loved one, a family member, and family being an individual that is identified as family by the patient. So this is a close friend, a loved one, a spouse, someone they identify as a trusted confidant that will help them with their care. Care partners can be invaluable to the clinical care team and really need to be considered a part of the clinical care team when providing care. Care partners can do everything from changing dressings on wounds, taking some vitals, helping with bathing and hair care, helping with meal selection and feeding, a whole host of things. And some of this is activity that will continue on once the patient is discharged and returns home. And the wonderful thing about that formalized care partner program, as is illustrated, this is a care partner program outlined by one of our gold certified sites in Saudi Arabia, Al Musa Hospital. Care partners typically feel very anxious about starting to engage in some of these activities with the loved one. But if they're doing it while they're under the supervision of the clinical team, they build their confidence and they're able to carry on these activities after the patient is discharged and then they return home. Now, because of our difficult time, we have seen in the United States and many other parts of the world that there have been significant restrictions in allowing visitors in hospitals and long-term care facilities and across the continuum of care. One of Planetary's main advocacy goals during this very difficult time has been to address the challenge of these very, very restrictive situations and the impact they've had not only on patients and families, but also on care providers. Those clinical teams that are the only ones at times who are with the patients for weeks on end, and also the ones that are preventing them, having to prevent them based on organizational policy from being able to have their family members be with them, present with them. So we really have worked very hard to create person-centered guidelines for preserving family presence in very challenging times. And this link, you can download these guidelines. This work was really the result of a pop-up coalition of over 60 organizations from around the world that really did recognize the impact that this restriction was having on patients, families, and care providers. So we're very pleased to report that we've had many, many organizations formally endorse these guidelines. And again, they can be downloaded, and we're very proud to say that the International Network of Health Promoting Hospitals, many Taiwan organizations are a part of this WHO wonderful network, have also formally endorsed these guidelines. So please do take a look. They provide great guidance and information on how to allow that presence in a very responsible way. The third element we're going to discuss is allowing patients more access to information about their condition. And one of the main ways we can do this is through the medical record. So we have oftentimes had clinicians be a little hesitant to allow the patient to have access to their own medical record for fear that there wouldn't be enough time. The patient's health literacy was perhaps in question. There was a fear that this would take too much time to explain, or there was just a challenge in terms of maybe what information was contained within the record. But in reality, less than 5% of doctors reported longer visits when they did open up the patient's own chart to them to review with them. And patients who reviewed their doctor's notes reported feeling more in control of their care 77% of the time. So this is really an important key point to allow that patient to have access to their own medical record. It is their own information, so it's not a privacy concern because it is that information that is about them. We also want to encourage information sharing in many other ways. One of these is a shift change that actually takes place at the bedside. So instead of the nursing station, we see the nurse going off shift and the nurse going on shift, having a conversation with the patient, with family members, right at the bedside, and introducing each other, not only limited to that, but also discussing information for the day. So looking at what's on the whiteboard, being able to check IVs, talk about testing or goals for the day, and make sure all of this is interactive with the patient. And then finally, we want to talk about how we can really listen to our patients in a more structured way on a routine, ongoing basis. And this would be having patient and family advisory councils, or rather partnership councils, be a part of our organizations. So during this difficult time, it is challenging to gather our patient and family advisory councils together, but we want to still make sure that they're engaged within the organization. And we can gather them together virtually, as we are here today, have WhatsApp chat groups, Facebook polls, and other types of technology employed to be able to hear the voice of the patient, even when we can't perhaps have face-to-face meetings. We want to make sure that we still have these types of virtual focus groups with patients and families, and really have them influence how care is being provided during this really challenging time. We want to make sure we encourage that co-design with the patients and families, hearing their voice on everything from menu selections at the restaurant, in the cafe, in the hospital, artwork that's in the building, parking restrictions that are at the organization, to also being the eyes and the ears of the organization and reporting what can be done better from a clinical perspective as well. So again, getting these folks together in a virtual way and continuing to hear the voice of your patients, family members, and communities. Also checking in about information we're providing during this very difficult time. Is messaging clear? Is it culturally informed? Are we getting the messages out to our most vulnerable populations and the least empowered also? The use of technology, as I mentioned, is really the modality to do this during this challenging time. And the creativity that we've seen within our own sites has been absolutely amazing in terms of how people can keep connected. And then finally, the key ingredient to success for your person-centered care culture. We see our patients, of course, as partners, as we have already talked about. We also really want to promote the notion that everyone in the organization is a caregiver, be it somebody in housekeeping, information technology, finance, or the clinical care team. But the key here is to be person-centered, you must be staff-centered. So we want to make sure that during this tremendously challenging time that our staff are well cared for, that their voices are amplified and heard, that there is visible leadership rounding. The leaders are there shoulder to shoulder with the clinical team during these very difficult situations. That really a community is built at work in the organization, and that we're honoring staff's realities in terms of all the worries that they have in their home life during this challenging time and what they're facing with their patients. So there will be times when they need a break. They need somebody else to take over, and they need to be tapped out and put to the side and say it's okay to take a break. And also make sure that they have the time and space and support to share the emotional toll of caregiving, and that health is promoted within the organizations. I know Taiwan does a great job with this with the hospitals, that there are healthy workspaces and activities that promote healthy behaviors. And then finally, we want to make sure we're reconnecting our staff to purpose. Why did you become a caregiver in the first place? And making sure that we provide that training and the reminder of what it's like to be the patient and be able to see through the patient's eyes by providing experiential learning and reconnecting the staff back to purpose and allowing innovation exchanges of activities and ideas. The time is now. Person-centered care doesn't stop just because of the pandemic. Perhaps it becomes even more important during this very challenging time. We want to make sure we're honoring patients' needs for inclusion, preferences, access to information, and involvement. The care for the caregiver is of the greatest importance. And we also want to make sure that we are continuing to plan beyond this difficult time for a person-centered future that is engaging patients and families, communicating, and reaching out to the community. As I promised, there are some tools and resources for you. Here is a link, and thank you very much for the opportunity to be here with you today.
Thank you very much, Vice President Jay. And so let's move on to the last sections for the panel discussion. Let me invite Professor Long, and also as a bonus, Professor Wang, Jason Wang, to come on stage for the panel discussion. And I'm sure Vice President Jay and Dr. Smith are still with us. Yeah, although we have a very short times before the coffee break, I was told that we have probably only 5 or 10 minutes. Otherwise, you have to sacrifice your coffee. Yeah. Well, I think a lot of people knows Professor Wang already. I mean, he's a Harvard MD and now currently the associate professor in Stanford University. And he is actually probably the first one to publish an articles about what we did in Taiwan in JAMA. And so let a lot of people know the situation in Taiwan and how we cope with COVID-19. But back in the central theme of our planning sections, the challenge of the healthcare system. Would you like to share with your thoughts on how do we move on and prepare a better system for a difficult time like this? Please, Professor Wang, Jason.
Well, I think so far Taiwan has done a great job in stopping virus at the border, right? So it's a containment strategy. And in the United States, for example, we didn't do that quite well, and so we have to use more of a mitigation strategy, shelter in place. But I think going forward, you could only do containment strategy for so long. And at some point, people get tired of closing borders, people get tired of staying at home. And so the next step will be, how do you reopen? And there are some strategies, and for example, we're all looking forward to vaccines that might be made available at the end of this year, early next year. However, when the vaccines are available, it's not going to be immediately available to everyone or to every country. And so as we recently analyzed some data about vaccines, we realized, for example, COVAX is a good idea, but the commitments are low for vaccines from manufacturers to COVAX. And so there could be a supply and demand problem within the 165 countries that all want to use COVAX. And so there's going to be an undersupply and an overdemand for COVAX. we also realized that the United States already has ordered enough vaccines to give everybody at least 2 shots. And you know, and that's including given the failure rate of 66%, right? So only 33% success rate for vaccines development in the history of the world. So if you look at the number of vaccines, the number in phase 3 clinical trials, you quickly realize that you have to make multiple bets. And so when we think about vaccine strategy, we have to think about what do we do for low-income countries? What do we do for middle-income countries? What are the strategies for higher-income countries? And I'm afraid that, to say that I think in next year we're going to see vaccine as a foreign policy tool, for sure, because right now the biggest manufacturers of vaccines, such as the United States, Germany, Russia, have not really made strong commitments. UK has to COVAX, and China promised to give some to COVAX, but the data from China is not quite transparent. So it's going to be a long way to go before we are able to reopen. So in the meantime, I think Taiwan has to work out a strategy to open up safely. Not right now, because we're heading into the winter, but at least work on the science of reopening safely, that are safer than the current strategy, but allow people to move around. And as we saw yesterday and today, we're seeing people getting more depressed, staying at home, getting locked down, increase in domestic violence against women. We're also seeing, for example, as Professor Long has stated earlier, global warming, which is going to be harder to keep people at home. And so all these, you know, sort of additive to the current troubles that we have. So we have to think globally, we have to act locally, we have to think strategically towards reopening.
Thank you, Jason. Yes, we have to think globally. Now I'd like to open the floor for 1 or 2 questions if you have. Well, if that is the case, because the time, and so I would like to give each one of our panelists 1 minute to have some final thoughts on these challenges, issues. Why not let's start from Dr. Smith?
Yes, thank you. I just want to say again, I admire how Taiwan has handled the pandemic, and the sort of the impatience and the fatigue with the lockdown is, I think, a problem all over the world. As you've probably seen, it's a very serious problem in the U.S., and in fact, it's unfortunately mixed with politics. But for those of us, for example, you know, all my coworkers, we're doing a very good job of sheltering in place and wearing masks and things like that. But after a while, you know, you really do get weary. It is my hope that we will, with vaccines, have an equitable distribution based on prioritization around the world. I fear you're right that it will become a political tool, but I think we have to do everything we can to work against that.
Okay, thank you very much, Dr. Smith. I mean, especially during these late hours. And I hope we can see you here next year in our Global Health Forum. Thank you, Dr. Smith. And
thank you very much.
Vice President Jay, your final thought?
Thank you again for the opportunity to be here, and you know, the previous comments are, I feel, spot on, very, very important. And I guess my closing comment would be just again reinforcing that focus on the holistic person and not pausing any efforts to advance person-centered care in the organization despite these very challenging times. Thanks again.
Thank you, Vice President. Now, Professor Long, I think you have been working with Minister Tang for a long time, so you probably can say something for you and also for Minister Tang.
Well, actually, I just want to emphasize that we have to work together to form partnership, not only domestically, but also internationally. and with innovative thinking, technology, and also inclusive strategy. That's very important to win this battle and win the war. Thank you.
Thank you. Jason, you still have 30 seconds to have anything you want to say. I know you have been here since yesterday, right? Yeah.
I was here yesterday. Yes.
Yesterday, yeah. Okay.
Well, I learned a lot in the last couple of days. I would say that while we're waiting for vaccines and therapeutics, we have to figure out a better way to engage patients and families remotely, or a combination of a hybrid system, remote plus, physical visits if necessary, and the you have to figure out a way of say, if I see you remotely and if it doesn't work out, there's a way to bring you back in. So that brings assurance to patients and families. And how do we establish that linkage seamlessly, carefully, I think is our next challenge as healthcare providers.
Okay, with that, I'd like to close this plenary sections. So I thank you again, our distinguished panelists and all of your participations. Thank you again. Bye. See you next year.
Thank you very much once again to our panel speakers. Thank you once again to Dr. Smith and also Ms. J. Thank you so much. Have a good night. Thank you. And thank you once again to our moderator and also panel speakers. Thank you very much for your participation. And everyone, let's have a short break right now. And when we come back at 10:50, here it will be for parallel session number 6, Healthcare System in the Post-COVID-19 Era Implementation of Person-Centered Care。各位现场贵宾，接下来呢，我们短暂休息哦。那等一下10点50分呢，我们回到原会场，是我们的平行场次6，后疫情时代的健康照护体系如何落实以人为中心的照护模式。And if you are joining parallel session 5, please go to the first floor, focusing on development and promotion of creative age-friendly services. 那如果您参加的是第5场的平行场次，创意高龄服务发展与推动的话呢，要请您移驾到1楼的前瞻厅。And we'll be back in 5 minutes. Thank you.
一刻，大家都屏气凝。
Welcome back, ladies and gentlemen. We now move on to parallel session 6, and we're going to focus on the person-centered care. 各位现场贵宾，接下来呢是我们平行场次第6场以人为中心的照护服务。For this session, we have 2 moderators. We have Professor Ran-Chou Chen, Commissioner of Department of Health, New Taipei City Government, and also Dr. Jason Wang, Director of Center for Policy, Outcomes and Prevention, Stanford University. 那首先呢，我们就有请第一位主持人来为我们介绍讲师。Let's welcome Commissioner Chen. 掌声欢迎。
Good morning, ladies and gentlemen. Welcome to the parallel section 6. In this session, we were talking about something from the healthcare system. I'm Ran-Chou Chen and Professor Jason Wang. 2 of us will co-moderate this section. We all know that Taiwan is doing very good during this pandemic. It's a collaboration from central and local government. And one is very important, is our strong and very enthusiastic healthcare system. So let me introduce the first speaker, Dr. Hou-Chen Chen, Chen Hou-Chen. He is the Deputy Superintendent of Taoyuan General Hospital, Minister of Health and Welfare, Taiwan. He is orthopedics, but very good in informatics, medical informatics, and international cooperation. Why we invite him here to speak about the people-centered care and AI technology in the during the COVID pandemic. You know, Taoyuan General Hospital is not only one of the major pandemic strand hospital in Taiwan, but they are very busy during this pandemic because they are very close to the major international airport. So they have a lot of patients during this time. So let's welcome Professor Dr. Chen to giving us this topic. Let's welcome Dr. Chen.
Thank you, Chair. Yes. Ladies and gentlemen, I am Chen, Dr. Chen from the Taoyuan General Hospital. Today, I'm so happy to share my experience with you. During the past almost 10 months, we're fighting against the COVID-19 virus. Although the war is still going on. But we hope to share some experience with our friends here. It's a tough work. It's a heavy task, but we are so happy to take this task. I think everyone has seen these pictures. These pictures are plague doctors. We can see the right one. This looks like the green reapers, as he said. It means when we face the virus, it also means you have to face the death. But we see the other pictures. This is a very special dress for the nurses, for the doctors in mid-age, to help the medical professional to prevent getting infected by the virus. But I think not just only high pressure to the people suffer the virus, but also heavy pressures to the doctors, nurses, medical professionals. So when you face the war to the COVID-19, it means that we have to fight against the green reapers. Now I want to introduce Taoyuan General Hospital. Taoyuan General Hospital is near to the Taoyuan International Airport. It's around 10 kilometers. We usually say it's a triage of disease control. The first part is by the Central Disease Control. They have the quarantine tests there. But the other two parts, one is our hospital, Taoyuan General Hospital, in the central region of the Taoyuan city. It's just around 10 kilometers. By ambulance, it's just around 10 minutes. And then we also have the Xinwu branch, the south part of the Taoyuan International Airport is around 8 kilometers away. So this three parts is a gatekeeper of the international airport. I believe everyone knows that border control, they use technology. Even in the COVID-19 eras, the border control is much more serious than ever because everyone faces the virus. We take a very serious attitude. In the past 10 months, around 20% of the cases by the Taoyuan General Hospital. We have a medical team to against the virus. We have the quarantine wards, around 12 wards to cure the patients. The first cases is around Chinese New Year's, just a few days before the Chinese New Year's. We have a morning meeting to discuss every cases just before the Chinese New Year's. So the superintendent leading our teams, every day we have discussed every situations. So we will modify our policies, modify our strategies, modify our care procedures to face the virus, to hope we can have the best quality to the patient, to the infection controls. But if we have to ask one question, because most of the people just know in isolated wards, we put the patient into the wards. We put the patient in the quarantine condition. But how can we have a high quality of medical care there? Because when patient put into the isolated wards, it means severe infected situation. And our medical staffs also have dressed the very special dress to prevent the diseases. So the first issue is how can we have the high quality to against the virus, but also to take care of the patient. And in our experience, when patient in the isolated world always ask, I will die by virus or die by isolation. Okay, I believe most of our friends here, maybe you never in quarantine condition, but you have to stay there over 2 weeks. I think it will be a big problem. In our hospital, the longest one for the quarantine is almost 2 months. It means almost 2 months you have to stay in the isolated wards. And everyone think you are very terrible. They don't want to touch you, don't want to talk to you. I think it's high pressure to everyone in the quarantine wards. So who will kill me? Is virus or solitary or loneliness? This is our medical teams, the backbone of the isolated wards. Our beautiful girls, but they have to face not just only for the virus, but also for very worried, very anxiety patients. Totally, we have almost 300 cases in our ward, in isolated ward, however, converted cases or suspected cases. Now there is a video to show what we are doing during this piece. Sorry, I'm waiting for the
之外
music.
还有的是自我的健康管理。能够做的就是医疗资源合理的分配，降低医护人员的负担。
病毒是兵分2路啊，一个呢是生理，一个是心理。那我们要团结，面对挑战来超前部署。
AIoT 与 COVID-19 防治，在隔离措施之下，对于疾病的监控及预测 COVID-19 疾病未来的发展变得极为重要。
所以你看，像在这个情境之下，你可以看到可能是一个医生，然后跟一个护士，他可以同时监控3个使用者。
那对于我们手表来说，它原先就可以收集所谓的像血压、心跳，或是像连续性的所谓的心率变异这样的资料。那再透过我们所谓1对多的蓝牙的一个软体，那搭配我们的本来就发展非常完整的云端。那藉由跟 API 串接到医院的系统里面的时候，那所有即时的资讯就可以让医院做一个比较紧密、比较及时的掌握。
它在基本资料的回馈的部分，他们直接上传了之后，那其实对我们帮助是蛮大的，因为不会说在口语上面就是有一些错误，我们书写上、登记上面就会有错误这样子，那其实就一目了然。
透过手表自动量测生理资料，再经过手机端的蓝牙上传，在医院端结合病人的资讯，并且保护病人的个资。
除了围堵病毒之外呢，更是要疏导人心。那透过我们整个科技的应用呢，也达到了领导、沟通跟协调的一个作用。那透过这个科技呢，更是要我们彼此信任，那么自律、利他，回到正常的一个生活。
借由资料分析，建立 AI 分析的模型，提供给医师作为判断病情发展的参考，尤其是筛检出有 COVID-19 重症的高风险病患，及早给予重症治疗，挽救病人的性命。
那我们其实可以利用这个大数据的分析，也知道说，哪一些病人他可能是持续有发烧的一个状况，好，那他可能是属于比较高度危险性的一个情形，哈，那所以在防疫的帮助里面呢，哈，这都可以减少我们人员就是持续的进出去暴露病人。
我们始终相信科技来自于人性，在团队的合作之下，能让疫情归零。早在武。
Okay. This video shows what we are doing. We use technology to take care of patients. I believe a lot of people have a smartwatch, but in the past we use a smartwatch just for the exercise, for the self-health monitor. But now we try to use it. Why we use it? Because it's cheap. Cheaper enough, we can use it to take care of our patients. So when we work with the famous technology companies, R.O.C and FET. This is a package. This is a package for the smartwatch. When patient admitted to our wards, isolated wards, we give him a package like this one, a cell phone and a smartwatch. And we can, when patient come to the hospital, they just turn on the cell phone and everything will be connected. When patient come to the hospital, they, the first one is calibrations by the smartwatch. And also, all the data will compare with vital signs taken by the nurses. So we can calculate the difference between the smartwatch and the vital signs taken by the nurses. So we can use this difference to predict the trends of the vital signs. And we also have the instruction for the patient first come to the hospital. They just scan the QR code and there are the Chinese information to introduce how to use it. And our head of nurse, they will show how to use it by video. So make the patient feel like home because they can use a cell phone, can use a smartwatch. And everything they can contact with our medical staffs and the nurse staff very quickly. And in our cell phone, we also have the Line apps. So they have any information, they just use the Line to contact with our staffs to ask any question, and we also reply question to him or her. This is a system structures. We also consider the safety of the data. So the information collected by the smartwatch and through the R.O.C company, they have a high-tech technology in the AI, and they send back to the hospital. But when the data sent back to the hospital, we combine with the information from our hospital information system. So it could be the useful information system, information for the care. And we also can provide the services to the other hospital. So we not just only do it in our Taoyuan General Hospital, but also for our Hsinchu branch. This is for the data security. We collect the data to the R.O.C cloud and combine all the information in our hospital to prevent the leakage of the data. This is a dashboard of our system. So everyone inside the hospital, they through the password can approach our information system. They will show us how many cases in our wards, And right now, how many cases in the wards. And this one is a list of wards. I think everyone were very interested in why someone is green and someone is red. We through another algorithm, we will predict the risk for the patients to predict the risk for the next 24 hours. If a patient is in high temperature condition or in high pressure conditions, it will show the red alert, red flag. So our staff will approach the patient to take care of it or to find another way to for further management. This one is the detailed information. For example, this patient is under quarantine conditions. This is a ward and then the name, and then in the hospitals, and admitted to our hospital in May, and already stay here for 17 days. And this one is the body temperature and the highest body temperatures. And this is for heart rate. This is right now heart rate, but this is the highest heart rate. And this is blood pressures. And very interesting, we also measure the stress index because for the mood, okay. And there is the steps. We also encourage our patients, they can take some exercise in the wards. This is a sleep. Because a lot of studies shows if a patient is in better condition, the sleep or stress will increase, and the sleep will be in not good conditions. So in by the smartwatch, okay, get the information as a reference. So someone will ask, this one is passed through the FDA, because in our process regulations, the smartwatch is not under FDA regulation. But right now I know FDA already asked them to pass through the FDA. We hope that in the future, this system also will pass through the FDA. There will be more application to our health care. And we also visualize the data information to help the doctors and the nurses will easy to approach all the history of the patient. And for the body temperatures, patient have to report his body temperature and all the cases, all the physical condition. I think someone will be very interested in why we do not do it automatically. Why? Because when something do by themselves, it means it's still in life condition. It means I still can figure out something and report his condition to the system. So we not just only everything by the computer, by the watch, by the cell phone, but we also hope patients can engage the health care by themselves. And we also have the social media apps in the system. I think someone also will be interested in why we do not use live by themselves. We found that most of the patients, they do not use the private lines to communicate with the hospital. They would like to use the public one because they don't want to keep the bad memory about getting infection. So, but we use it. They will ask every kind of the Christians, the medicines, even the bathrooms. By it, we found that we can release a lot of tension of the patients. So for Taoyuan General Hospital, we not just only work with our staffs, our friends in the hospital. We also try to work with the patient together because fighting against the virus, against the illness is not just only one side responsibility. We have to work together and pass through the very, very tough times. In the future, we hope to apply the technology to the long-term care, the in-ward care. I believe by the technology, we can provide a better service. But we never forget the patient engagement, participate the medical teams to be the people-centered care is the key issues of the health care in the future. We're still very proud health care in Taiwan in the top part of the world. So I believe everyone here will work together and still want to be the best healthcare system in the world. Thank you very much.
Thank you, Dr. Chen, for your wonderful presentation. In Taiwan, we are shortage of medical personnel, especially the physician and nurses. I believe it is especially the shortage is especially worst during the pandemic. So smart care is the key. Actually, I know one patient. She stayed in the hospital for 86 days. So you know the medical staff, the stress of the medical staff, and the patient is very big. So we believe that in the future, and actually it's now from now the smart care will help us. Now we are moving to the next speaker. Our next speaker is Dr. Karin Luxford from Australia. Dr. Karin Luxford is already on the line. She's the CEO of Australia Council of Health Care Standards, the ACHS, and also the HCHS International. She will give us the talk about the person-centered care and especially how the accreditation for the hospital, for the healthcare systems can improve the safe and quality of our care. Karin, can we hear each other?
Hello, yes. Can you hear me?
Yes, very good. So let's welcome Dr. Luxford.
Thank you everybody, and thank you very much for the invitation to speak with you today. And I certainly want to acknowledge my colleagues in Taiwan, and particularly the fellow panelists for this session. I'm very sorry I can't be there with you in person, and I hope that you have a successful forum. I wanted to really start by reflecting on the situation that we all find ourselves in the world at the moment with this pandemic, and really to acknowledge the healthcare workers and the healthcare managers who are doing an amazing job everywhere throughout the world in looking after our patients. So just a minute to think about the incredible work that is being done. I certainly enjoyed listening to Dr. Chen. That was a fantastic presentation, and to hear some of the things that are happening in Taiwan. I wanted to share a little bit with you about how we are progressing within the Australian context. So firstly, for those of you who don't know ACHS International, we have been around for a number of years, and we are in about 17 different countries across the world. We're Australia's longest established health and quality improvement organisation involved in the accreditation of healthcare services. And we have members, as I said, everywhere across the world, mostly focused in the Asia Pacific and the Middle East. And we are, in Australia, we don't often beat our own drum, but I think it is important to reflect that we do have a very high performing health care service, just as you do in Taiwan. And we are consistently ranked quite highly in the top 5 in terms of outcomes and performance internationally. ACHS International, we're an independent, non-for-profit group in ACHS, and we were established indeed by the clinicians, by the healthcare organisations, by the hospital managers groups, and consumers are all represented on our council. Just thinking about the situation with the COVID pandemic, I know in Taiwan you have performed exceptionally well. I believe you only have to date about 7 deaths, which is absolutely incredible. And in Australia, I think our response similarly has been very good. We've had a strong response by our government quite early on at a national level, doing an amazing job. And we had our first peak around the end of March. A number of things closed on about the 24th, 25th of March, and most people moved to working from home. At that point, our healthcare services started to ensure that they were fully prepared for the pandemic. Our borders closed, so unfortunately we can't travel anywhere. Australians are all staying within our national borders, and many Australians who live throughout the world started to come back to Australia and had to go into quarantine. We were doing an incredible job, and I think you can see from the graph for many months we had extremely low numbers of community transmission. And then, unfortunately, we did have a cluster emerge in one of our states in Victoria. And that state saw increasing numbers, which started in a hotel quarantine and then moved out into, unfortunately, aged care facilities. And so you'll see the number of cases start to peak again in July and August. And we, prior to that point, had under 100 deaths, but we are now up to 900, just over 900 deaths across the country. And so the state of Victoria went into virtually complete lockdown at that point, and we still have a number of our borders closed between different states within Australia. So movement between states is quite restricted in a number of places. We do have very low numbers within hospital setting, however. As of today, only about 20 cases in hospital and low numbers in most states for community transmission. I think one of the things that we've done very well in the Australian environment, and particularly in the state of New South Wales, is contact tracing. And that has been the key to the success in some of the states that have the very low numbers. As I mentioned, our government response was very strong. The government had a committee established called the Australian Health Protection Principal Committee, and this committee advises the Prime Minister directly and the Minister for Health. They're our key peak body for making decisions for the country on health emergencies. And I'm very pleased to say that the chair of our board, Professor Len Notaris, who heads up a trauma and critical care response centre in Darwin, is actually a member of that Prime Minister's committee. So we're very connected with what is happening in the national scene for the pandemic. And all of the chief health officers throughout the country are also on that committee. So I wanted to reflect on where we're heading in healthcare, and I don't think that the pandemic has necessarily changed any of this. In fact, it's really just accelerated our changes. And so what we're really seeing in terms of the future directions is a greater focus on chronic care. Certainly a focus on well-being and preventing people from being in hospitals, keeping healthy, patient-centred care, as Dr. Chen mentioned, and also integration across primary and acute and preventative health strategies, as well as an increasing reliance on digital and data analytics, and a move in our funding models away from fee-for-service and towards outcome-based funding, and certainly personalised medicine, which we've seen in a number of different diseases. I'm going to focus on some themes internationally, and we certainly see in the quality improvement space that safety is starting to be looked at across that continuum of the patient journey, and not just in the hospital setting, but certainly right through to self-management and home care, which has increased during the pandemic. And thinking about safety and quality, not as a standalone, but how is that integrated into the models of care? And increasingly a focus on mental health, which was happening before the pandemic, but has been an increasing focus, certainly for many governments and healthcare services across the world during the pandemic. So drivers that we are seeing in this space are in governance, so the leadership to really make that change happen, public reporting, increasingly being transparent about safety indicators, and moving from compliance and regulation towards a shared accountability, and the role of accreditation in that process of driving safety and quality, as well as pay for performance, and IT and technology, as Dr. Chen so very well pointed out, helping us to make healthcare safer. Global trends that we are seeing are in new models of care, and definitely during the pandemic we've seen a move towards further telehealth and telemedicine techniques and remote care. We had some of those systems established in Australia because we are a large country with rural communities that live hundreds of kilometres from healthcare facilities. So we did have some of that established already, but it has increased enormously. AI is certainly big in the international scene, and data analytics and how we use that to support compliance with standards, and population health management is increasingly a focus due to the pandemic. In the area of external assessment and accreditation, we're seeing changes to new technologies being able to assist with remote assessment, and I'll talk a little bit more about that, and tailored approaches to quality improvement. So not necessarily thinking about a one-size-fits-all, but perhaps supporting services in the areas that they need that extra support. So in safety and quality, some of the key areas of focus are present: infection control, obviously even more important during COVID-19, medication safety, increasing look at how we stem antimicrobial resistance, and partnerships with patients and patient engagement, and how you do that throughout your organisation. Thinking about diagnostic error, which is still a big issue internationally, and how we use those emerging technologies to make healthcare safer. So what is the value of accreditation? And we get asked this question as we go around the world in different environments. This is some evidence that was published last year showing a positive association between accreditation and the quality, patient experience and outcomes for a healthcare service. And thinking about the effectiveness of that accreditation is really only as good as the standards that are used in the accreditation process, and that it is not a standalone guarantee of safety. I think we all know that. The approach to safety and quality has to be comprehensive, and accreditation is an important part of that. And having the right sort of culture and leadership is positively associated with accreditation. So that's some of the evidence that we're seeing supporting accreditation. And certainly when we look at our data within Australia, what we've seen with the introduction of those safety and quality standards for accrediting healthcare services is significant improvements in areas like decrease in Staphylococcus aureus, decrease in central line-associated bloodstream infections, improved antimicrobial stewardship, and a significant decrease in cardiac arrests within hospitals. So these are the sorts of improvements that standards can make, and we've seen that also in the drop in sentinel events that we have witnessed within healthcare services across the nation. But we need to make sure that we are focused on safety and quality every day. And at ACHS, we developed a system of short notice assessment. We piloted that. It was very successful. It's now used across Australia, and we also offer that as a service through ACHS International. So making sure that on a short notice, the facility is only given 48 hours notice that the assessment is going to take place, because you should be safe and providing quality care every day. Increasingly, we're seeing the use of data analytics to be able to look at the performance of healthcare services. So not just retrospectively looking at incidents, but looking forward in terms of performance of safety and quality, and being able to hone in on areas for improvement. So during the pandemic, we put a hold on our assessments internationally, but in June, our board gave us the approval to recommence those assessments. Our international team has been working on policies for remote and virtual assessments and hybrid assessments, where we have lead assessors in Australia are coming in remotely and local assessors within the country on the ground. And I'm pleased to say that we are now introducing those assessments. Excuse me. I just wanted to share with you some data, excuse me, from an international study that has been looking at how services that are accredited have been faring during COVID-19. So this study looked at hospitals that were accredited versus those that were not, and their ability to cope and be resilient during the pandemic. And they certainly found that these facilities that were accredited had much higher levels of collaboration and cooperation, and that they had, excuse me, policies and programs that were in place to be able to cope. So there were positive effects for hospitals that had been on that accreditation journey, and this was supported through their data being available, having well-structured infection prevention and control programs, being disaster management ready, having responsive committees, having staff that were well trained on infection prevention and control, and a culture that supported quality monitoring. And what this study showed, and this research evidence, was that accredited hospitals were actually the go-to hospitals that were being sought after for guidance and advice by non-accredited hospitals. So where we see things heading in the future is a shift from an episodic look at quality and moving much more towards the right-hand end of this diagram with a culture of continuous quality improvement, ongoing assessment, and really that drive happening from a culture within the organisation. And a shift from quality to value. So looking at quality, at the patient experience, at patient outcome measures, and thinking about obviously the costs to give us a good look at what is value. Safety is absolutely personal and needs to be done in partnership with patients and families. And there are many techniques for engaging with patients, families and carers and leading high-performing organisations that we accredit across the world. And there are also some very challenging times that we have been facing. I think the points made by Dr. Chen about how to be patient-centred in a challenging environment were very, very key points. And there are a number of groups working on this. Our standards that we accredit to in our EQUIP program are focused on patient-centred care. And there are new resources available internationally. This is an example from Planetary in the US, of a resource that came out quite recently about guidelines for preserving family presence in these challenging times of the pandemic and how to do that to ensure patient-centred care. So on that note, we are committed to safety every day, and we know that you are too in Taiwan. And I wanted to say thank you again for involving me in this forum and to wish you all the best for your Global Health Forum.
Dr. Luxford sharing with us from Australia how to ensure the safe and quality and in the new world. We are right now living in this new normal life everywhere. So now we are moving to the third speaker. The third speaker is Wang Sheu, Huey-Herng. He is the superintendent of Taichung Virtual General Hospital. From the previous two speakers, we all know that mental is very important. That's the one of the biggest issue when either you're doing the new normal or you're in the hospital or you're inpatient. And Dr. Xu is a very famous physician in the new non-communicable disease, especially the diabetes. He is not only the superintendent of one of the biggest hospitals, he is also the executive committee of the Western Pacific region of the International Diabetes Federation. And now he will sharing with us the the stressor related to increased risk of mental, emotional distress and the psychiatric illness associated with COVID-19. I would like to apologize that I had to move to the other conference. So after his talk, using video, recorder. Professor Jason Wang will host the panel discussion. Let's welcome Dr. Xu.
Recall this speech because I have the major meetings in the hospitals and cannot attend this meeting on site. The unprecedented nature of COVID-19 has affected nearly every aspect of our daily life. It has infected more than 35 million people globally, with more than 1 million deaths recorded by WHO as of October 12, 2020. There has been so many discussions of how to provide effective measures that suppress and control transmissions. Today, I will focus on one important issue associated with this pandemic, that is mental health and leadership in facing this challenge. The pandemic of COVID-19 has caused tremendous impact on medical communities all over the world. Healthcare staff are facing important emotional stress during the COVID-19 pandemic, including grief from seeing so many patients die, fears of contracting the virus and infecting their families, and anger over healthcare disparity and other systems failures. For some, this stress has caused of exacerbate burnout, depression, or post-traumatic stress disorders, and even they have been implicated in suicide. So even before the pandemic, there was an acceptable high rate of burnout and suicide among them. So here is the face of one of the doctors in Taiwan who had a mark in their face after a long time wearing the face covering. In the US, a recent report from CDC indicates that more than 150 hospitals and nursing home staffs infected by COVID-19 during work, and more than 700 have died. Those numbers are actually underestimated since inadequate data collection systems. Beginning in the pandemic, there are so many articles addressing the issues of mental stress over healthcare providers, because they are in the front line taking care of the infected patients and are particularly vulnerable to emotion, given their risk of exposure to the virus, concern about the infections, and caring for their loved ones, shortage of the PPE, and longer hour workings, facing so many life losses, and involvement in emotionally resources allocation decision. So burnout are just one of the epiphenomena. Medical staff suffer from loss of personal freedom, large and growing financial losses. One recent survey conducted in the United States, over 5,000 adults reported that 41% of respondents reported at least one adverse mental or behavioral health condition, including depression, anxiety, post-traumatic stress, and substance abuse, with rate that was 3 to 4 times the rate 1 year earlier. So the mental condition of healthcare provider covered but not limited to anxiety, depression, post-traumatic disorders, loneliness, and isolation. It also increases the chance of substance use, alcohol abuse, child abuse, or even family violence and suicide attack. The recent publication from the editor of NEJM also indicate this COVID-19 crisis has produced a test of leadership, not only at the country levels, but also at all the healthcare organization levels. Healthcare organizations and leaders have a responsibility to help address those stresses and challenges. In addition to this traditional form of support for acute care, there may be potential for accelerated personal and organizational adoptions. In fact, research has found that organizational approach to improve clinician well-being are more effective than strategy focusing on personal resilience. Accountability among organizational leaders to support all the initiatives are vital and should include sufficient investment of resources, elimination of access barrier, articulation of this accountability among executive and development of measures to track progress. As a result, the NAM, the National Academy of Medicine, had recently issued a report published in NEJM to call the attention and address the critical issue of physician well-being in order to maintain safe and high quality of patient care. At organization level, create a position of CWO to integrate all the works. In addition to sustain and supplement existing well-being programs, but also to ensure psychological safety of clinicians through anonymous reporting mechanism. Some would suggest that institutions provide funding for peer support groups. In addition, clinicians are more likely to accept support from colleagues who understand their specific stress. Those peer support programs should involve adequate training, marketing, and personnel, including program leaders. The strategy for healthcare leader and management should involve in value clinicians, communication with best practice, care monitoring, and providing clinician well-being. Provide a supportive, blame-free environment that fosters cooperation and collaboration. Provide transparent information delivery in case of the dire situation. Clinicians are not required to return to work. Provide all help needed once clinicians and their family get infected with COVID-19. Institutions can prioritize reaching out to employees who may benefit from receiving help by developing systems for offering support to clinicians rather than relying on self-referral. Strategy for physicians are meeting their need, have regular break, stay connected, respect differences, stay updated for all the information, do self-check-ins, and always honor their service. There is a strong consensus that immediate action is needed to bolster the emotional health of all the clinicians involved in the front line of patient care. So resilience should be at the level not only national organization, but also at the level of all individuals, all of which are equal importance. Resilience involves build up strength, confidence, and establishment. Motivate from bottom of mind, bring effort, which lead to the behavior changes and keep agility. So in this regard, Department of Health and Welfare of Taiwan government actually had provided several stress scales and measurement systems that allow our community to use. However, several hospitals did utilize the 24-hour call line for specific psychiatry clinic for their staff and general populations. It has to point out that psychological support measure must be confidential, affordable, and accessible at any time. On behalf of our hospitals, actually, I would like to present what we have done in the central Taiwan. We had successfully managed dozens of COVID-19 infected patients, and all of them been discharged in safe. None of our staffs get infected so far. We are fortunate enough to have clear and useful strategies from government and efficient medical communities. But given that, we have made best preparations and carefully cope with pandemic to ensure we provide a safe hospital, patients were taken good care, and citizens being protected. I would like to share our experience, how we had done in all the major steps, and how did we go together to protect our staff, not only physically, but mentally. There are 4 major strategies running in our hospital. Number 1 is try to our best to avoid any potential infections. Number 2, repeat drills to make sure every staff not only understand but familiar with all the SOP of infection controls. Dress up PPE and take off PPE. Number 3, to ensure optimal work shift, arrange and provide adequate rest. Number 4, of course, to ensure supply sufficient PPE. So to make sure all the information are clear and transparent, we created an area of up-to-date pandemic information, both from domestic and international. All the update message and news from Taiwan CDC and all the meeting minutes were posted and easily be accessed by all our hospital staff, which could greatly reduce fears, uncertainty, and anxiety. Repeat training of how to use PPE by following the SOP are also critical. Before entering the room of infected patients to conduct all the medical procedures, the senior staffs have to check all the protection equipment work well to make sure it is safe and seamless. We provided face-to-face training program as well as video and online training program. Training are not only limited to healthcare providers, but also to all the workers who are responsible for cleaning, ambulance drivers, delivery workers, and so on, in order to ensure everyone should be get well trained. Trainees have to pass post-training tests before they were allowed to go to the front line to work. We had shown our particular care to frontline healthcare staffs. For example, we have found a very useful local produced cream with herb ingredients that can avoid skin irritation when staff have to wear face masks for long hours. The products are particularly welcome by our nurses. We have designed the infected zone in inpatient wards based on the rule of infection control and arrange work shift in a reasonable way in order to ensure fair and good rest for those who work in the front line. To comfort emotional stress for those infected patients and reduce frequency of going in and out to infected inpatient wards, we had widely utilized new technology of telemedicine, such as iPad, for our patient staff at very well responses. We provided 24-hour on-call line to all our employees who might need help and regular counseling by our senior psychiatrists. Before the government deliver financial support, hospital it provide bonus as an appreciation in advance, since we have to consider the possibility of some employee who might suffer from personal freedom, as well as large and growing financial losses. We have encouraged all the frontline staffs, providing their new ideas on how to combat the pandemic and load down all the touch stories they encounter, which share further light and build good culture of our team works. Nowadays, we have collected 28 touch stories that we posted in hospital and FB, and also 18 solutions. We extensively utilize social media, such as Facebook, to deliver timely message and educational material to public to reduce anxiety and fears. And we did receive very good feedback. Finally, continuous and frequent support from the leader, both the verbal or physical, to the frontline care provider are also important. So keep remember, always to honor the frontline staff. Those encouragement and appreciation letters from outside and inside should all award to our staffs. So here's the summary of what the Taichung Veterans General Hospital had done. We call RDCS. Reduce anxiety and fear by providing transparency and update all the information. Diminish uncomfortable, provide on-time care and 24 hours help online call for all the support. Honor and award to support all the frontline, our staff, to ensure they were comfortable and build a good teamwork culture. I believe are importance and are the major mission from the leaders. So in conclusion, a strong leadership and commitment are key factors to overcome these battles. We have to consider all the way to reduce the employee burnout and ensure adequate supply for personal needs. Good communication and transparency of all the message and news with sufficient adequate educational training are necessary. We have to repeat and ensure psychological support to all our care teams and also provide those anonymous reporting systems. to sustain and supplement existing well-being programs are one of the key measures to overcome these battles. So with that, I would like to thank you for your listening.
Thank you very much to Superintendent Sheu. And now for the panel discussion, we'd like to invite our moderator, Dr. Jason Wang, to join us on the stage, and also our speaker in this session, Dr. Hou-Chaung Chen. Please also have a seat on the stage, and also online, we have Dr. Karin Luxford joining us as well, all right? Okay, over to our moderator, Dr. Jason Wang.
How's everybody? Hungry? Yeah? Looks like 15 minutes between this panel and lunch, so I hope you could stay with us. Is Dr. Luxford online? Can you hear us?
Yes, yes, I'm here. Hello.
And then is Dr. Sheu going to join us or not? From Taipei Veteran General, he's not going to join us. Okay, so there'll be the four of us, actually the three of us. Okay, so I was very impressed, Dr. Chen, with your presentation where you show that you're monitoring sort of stress, well-being levels, sleep, and whether the folks under quarantine are actively exercising. And I think the health and well-being of those under quarantine are particularly important. In Taiwan, there has been 7 deaths from COVID, but 5 deaths during quarantine. So, and 3 of them were suicides. And so I think this issue ought to be brought to the forefront of concerns as we deal with continued lockdowns and quarantines. And I was wondering, Karin, if you have any thoughts on developing measures, for example, to assess health and well-being both for providers and for people under treatment or quarantine.
Yes, thank you. Can you hear me?
Yes.
Hello, can you?
Yes, we
can
hear
you hear me? Yes, thank you. Yes, look, I think that is an excellent question, and we certainly have, as I mentioned, seen significant increases in mental health issues during the pandemic within Australia. We have seen data on the increased use of mental health services. In Australia, that increase has been a 30% increase in service uses, so telephone lines and government services to support people who are trying to cope with mental health issues. I think we do need to start to think about how we are tracking this. We've been running programs around resilience, just even within my own organisation, thinking about our employee welfare and making sure that we provide people with the sorts of skills that you need to be resilient in this ever-changing and unusual environment. But looking at how we track people, I think, is important, making sure that we're staying across both our health workforce as well as our general community. So I think there will be an increasing focus on that sort of monitoring.
Thank you, Karin. And I was wondering if Dr. Chen, if you have anything to comment from sort of your experience in Taiwan and where you think sort of, you know, the ministry is going with further monitoring of people under quarantine and under treatment, if you will.
Yeah. Actually, during our first period, we are taking the quarantine people in the isolated wards, and we found not so happy to our staffs, not so happy to our patients. We are so proud of our healthcare technology technique. We think everything, even the medicine, everything seems, everything is right. But we found so high pressure to the everyone involved in these wars. So that's why we have to reconsider everything from the beginnings. For example, besides the virus, how can we design our healthcare programs to the patients? How to design a workflow for our staffs? Because the virus, we cannot see the virus. Where is the virus? And everything seems to be contaminated. So we have to redesign our procedures, redesign our workflows, and we also have to design the new procedures for our patients when they're admitted to the isolated wards. So that's why we have to use a different way to think about how to provide our service. In the past, we always say people-centered. How can we approach it? It's not so easy. But I think that we are lucky because we have help from the technology, from the electronic companies. They help us to deal with these problems. But I have to say it's just the beginning, not the best resolution. I think it's a beginning. We need more efforts from our friends here, our friends in the healthcare professional to work together. Yeah.
Are there questions from the audience? Please state your name and also your question.
Hi, my name is Tara. I wanted to ask you, because systems are becoming more person-centered, and we are using digital technology, but there is still a gap, not between digital access in Taiwan, but perhaps digital skill. So how can hospitals and healthcare systems address this issue? And also particularly in the aspects of, if you think about GP consultation time. In Australia, I think it's around average of 15 minutes, USA 20, but in Taiwan, it's around 2 to 3 minutes. How can we address this without burdening physicians in a very heavy health system that's already at capacity?
Can you hear me? Yeah. So is the question addressed to our panelists or to me?
It can be addressed to anyone.
Okay. Well, why don't you go first, Dr. Chen?
Okay, yeah, I think the very short fit to the doctors is always a problem. Not just problem, it's I think it's like a negotiation between the doctors and peoples. You have to see so many people in very limited time, so everyone almost just a few minutes. I think in the other ways, for example, we shift to the non-commutable chronic diseases to get the 3 months medications. And we also can help the patient to develop the self-care technique. And we also can shift some, or I have to say, empower the patients to let them to have more technique. And when they feed the doctors, they can touch the points, hit the points, to make the communication between the patient and the doctors very efficiency. So even we cannot change the show time for the medical visit, but we can make these things more efficiency and well communications. So that's why Ministry of Health, they also develop a lot of tools and even a shared decision making. I think is some way to make this situation better.
Dr. Luxford, do you want to comment on the question?
Yeah, yes, I would. Thank you. I think it's a very, very good question. And I think one of the key issues is how we really match our approaches to not only the health literacy, but the IT literacy of our patients. And so the most important thing about the use of technology is to use it where it is best suited. Technology is a tool. And so you need to think about where is the best situation, the best way in which to use that tool. I think one of the great things that we've seen around the world is patients as the drivers of change. And in many ways, as consumers, patients are sometimes more innovative than healthcare professionals. So what we're really seeing is the advent of exciting things like remote monitoring, being able to support people to receive care in an environment in which they prefer to receive that care, and being able to connect them to their healthcare professionals so that we can support new models of care.
Thank you very much, and I'll answer your question briefly in two ways. My understanding is that at the peak of the COVID cases here in Taiwan, there's a drop in hospital clinic visits because people were afraid to go to the doctors. And I think, as we have seen in the last couple of days, not going to the doctor's office when you need to is actually a bad thing. For example, if you have cancer or if you have other chronic disease that you need to take care of. And so the alternative strategy is for example, telehealth. And telehealth has two components. One is video conferencing and consultation. In some cases, you could do it with telephone. And the other aspect of telehealth is remote patient monitoring or remote physiologic monitoring, which Dr. Chen has demonstrated in his hospital, that you could even do it even in the hospital. It doesn't have to be with home. The real issue is integrating the data that you capture either during telehealth or remote patient monitoring, so that this becomes part of the patient's records for continued management of the patient. And so a lot of people, very smart people, are thinking about this right now. We do have a paper published this week at the British Medical Journal, medical consultations during COVID and beyond. So if you could just Google my name, the paper was published this week. Any other questions for Dr. Chen or Dr. Luxford? Please.
Thank you, Jason. And it's me again. Dr. Shuti Cho, consultant physician in Zhengxin General Hospital. I have one question for Karin and one question for Hou-Chen. Both are about transparency of information and trust. And Karin, you mentioned the public reporting of patient safety information. I wonder exactly what it is, because I'm wondering, I worry whether that will cause the fear for healthcare organizations to fully report all the patient safety, all the adverse events data. Okay, that's the question for Karin. And the question for Hou-Chen is, I know you have taken care of many COVID-19 patients. And during SARS outbreak, healthcare staff would like to know whether their hospital is receiving the patient. And Superintendent Xu also mentioned, he said that they did very good transparency of information. So this time, does your hospital tell your staff that we are receiving one more COVID-19 patient? And our central commander, Mr. Chen, he is reluctant to disclose the information regarding where the patients are hospitalized. He has his concern. So it's a, you have double-sided concern. So what's your experiences. How does your hospital do regarding transparency of information to your staff? And would you like the central commander to tell the people, the public, release of information that your hospital or which in the specific hospital is taking care of the patients? What's your point of view? Thank you.
Thank you, Professor. Thank you, Professor Chen. I think it's a dilemma questions because according to the experience in SARS, a lot of hospitals get the SARS patients and pandemic terror in the peoples, they will be very, very afraid to come to the hospital. So we face the same problems. I remember the first Sunday and first Sunday, our staff cannot get the lunch because no one would like to send the lunch to our hospital for our staffs. Even that late, the community leaders come to our hospital to protest, to say they don't want any patient to the hospital. But our strategy, we tell them because this is our responsibility of our public hospital. And inside the hospital, we also very tell our staffs how many patients in our hospital. Every day, we have the report system. Everyone have to report their body temperature to a system inside hospital because we will monitor everyone, our staffs in hospital. But in the website, we also show how many patients in our hospital. So our staffs, they do not, they know every details, and they do not fear the patient anymore because the hospital, because of the information is transparency, and they know the hospital take care of the patient very, very careful. They know they stay in the isolated ward or in the intensive care wards. So they know the patients where they are. So because our staffs also are our neighbors, because in Taoyuan, a lot of staffs just live around the hospital. But through it, the community knows our responsibility and also support us. But even now, we still have the very high standard gatekeepers. Everyone pass through the gate of the hospital, they have to TLCC to check. Even now, when you come to a hospital, still a long queue in our gate. But we tell our neighbors, say we are in high standard in disease control. So that's why we do it.
That and I was wondering if I think we only have 1 minute left. I was wondering if Karin, you could comment on the disclosure for to the community and also to the hospital staff. So they're internal and also external communication piece in Australia.
Absolutely. I think what we see is that high-performing organisations have a learning culture, and we know that the only way to improve is to measure and to be able to look at benchmarks so that you can make that improvement. So we've seen an increasing focus on reporting of hospital-acquired complications, of falls, of infections, and really making sure that that information is available, including things like near misses. So not just incidents, but things that have been avoided. And that's the way that we learn how to improve. And so partly simply to ensure that there aren't any unintended consequences of that reporting, there is an education piece that needs to be conducted as well. So, for example, if you're publicly reporting incidents, you need to make it clear that if the figures are going up, it's not necessarily that the incidents are going up, but whereas in the past they may not have been reported, people are now actually reporting them. And that is an important thing, because that's how we improve.
For that, and I think increasing transparency is what we strive for all conditions, and I think you know, I want to thank our panelists, Dr. Karin Luxford and also Dr. Chen, for your wonderful presentations, and I want to thank the audience for staying with us, and let's go to lunch. Thank you.
Yes, give it up once again for Jason, for Karin, and also for Dr. Chen. Thank you once again for your wonderful discussion, and thank you all for your questions. Ladies and gentlemen, that's it for the morning, and it's time for lunch. So we have lunch boxes ready outside. Please help yourselves, and we'll be back by 1:20 this afternoon. Thank you again. 各位现场贵宾，接下来呢是午餐休息的时间，我们休息到1点20分，休息到1点20分，我们午餐餐盒呢已经备好在我们场外了，请各位贵宾自行取用，可以回到会场内来享用。谢谢您的参与，谢谢。 Ladies and gentlemen, in 2 minutes, we're going to begin parallel session 8. Please take your seats. Thank you very much. 有请各位现场贵宾准备就座，我们第8场的平行场次呢，等一下就会正式开始了。谢谢。Welcome back, ladies and gentlemen. Hope you all have enjoyed your lunch. When right now in parallel session 8, post-COVID-19 era, the future of health promoting hospital. Let me firstly introduce to you your moderator for this session, Dr. Huang, President of Taiwan Society of Health Promoting Hospitals and Taiwan's Network of Health Promoting Hospitals and Health Services. 各位现场贵宾，让我们掌声欢迎我们平行场次第8场的主持人，台湾健康医院学会黄辉庭理事长上台。我们掌声欢迎主持人。Let's welcome Dr. Huang to the stage.
Good afternoon, our honorable speakers and distinguished guests and ladies and gentlemen. It's my pleasure to chair this section, and it's also our honor to invite 4 very renowned professionals to attend this section. They have dedicated themselves to the health promotion for many years, and they have been building a great experience in the health promotion. So I think it's a lifetime opportunity to share experience from the Europe and from the Taiwan experience. As we know, and COVID-19 is a pandemic has devastated the world and changed the world. It's a difficult time for us to face the pandemic. And only together we collaborate, we can prevail over the virus. And the meeting, the purpose of the meeting aims to share experience, as I mentioned about, and our experience from the Europe and from Taiwan network. And on the other hand, the meeting is to explore what measures we have taken to support and empower our healthcare institution during this difficult time. I think we have so many interesting topics in this section. We will talk about the health hospital certification, talk about the environmental health, and the future of the health promoting hospital. So I hope all of you will gain a lot of rich harvest in this meeting. Thank you very much. Yeah. Okay, I will introduce our first speaker, Professor Wang. He is currently serving as the Director General of Health Promotion Administration, and he graduated from School of Medicine, National Taiwan University, and he attended a PhD from School of Public Health and Tropical Medicine, Tulane University, USA. And he has a very stunning working experience and on the health promotion and family medicine, palliative care, and health promotion. So please, Professor Wang. Yeah.
So I'm going to share some the Healthy Hospital Certification 2.0. This is a new program, and we just doing some pilot study on this program. For the starting of this program, I just mentioned some, the development of the health promoting hospital or healthy hospital in Taiwan. We start from year 2006 until 2016. There is a health promoting hospitals program related with the international network. So from the health promoting hospital network standards, there are 5 standards, including the management policies, patient assessment, patient information, and interventions, promoting healthy workplace and continuity and cooperation. From the year of 2017 and 2020, we think that there are a lot of task force started in the first 10 years, and then we hope that we can incorporate all these task force into a new program called Healthy Hospital Program. We put age-friendly and eco-friendly in addition to the 5 standards. And this year, in Healthy Hospital 2.0, we added another one and put person-centered care as one of the major issues as the standard for healthy hospitals, and also change eco-friendly to climate action. In the past, we started 2006, and then we noticed that there are a lot of awards from HPH and also the Intersector Corporation and Supplemental Fund in 2012. And then there is a gradual increase in the number of the hospitals joining this project. As I just mentioned that we have a lot of task force or so-called, for example, baby-friendly hospitals, green hospitals, health literary hospitals, tobacco-free hospitals. There are quite a lot of issues to get working together. So we try to integrate into one healthy hospital basic level, and then there's also change to advanced level. And the difference that we decrease the number of items for accreditation, make it more simple, and simplifies the items. And also that we are doing different methods for assessment. In the past, we just visit doing the visits of the hospitals and to checks of the checkpoint, checklist. But now we change to PSM, patient-focused method. We hope that we understand the true process of the caring of the patient, starting with the concept of the patient-centered care since 2017. By that time, even the health promoting hospital continues to grow. We start with the healthy hospitals, and it makes it much easier for the hospital to accommodate this process. And there is 7 standards by 2017. As I just mentioned about the patient assessment and policy information. And by that time, there are some changes of the standard. We embed the idea of patient-centered care, shared decision-making, health literacy into the patient information intervention. And by that time, for the medical center, 100% of the medical centers apply for this accreditation, and 97% of the regional hospitals, but we only have 25% of the district hospital apply for this process. And this is the distribution of that the hospitals around Taiwan and different county. What's the next step? And then we noticed that COVID-19 is one thing. The care of the elderly population, e-cigarettes, health literacy, and value-based. All these are new issues emerged in these 2 years. So we think that this is time for us to make some change of our accreditation or our healthy hospital content. So we also maintain this basic and advanced level. So not only for the hospitals, but we think that health service, including the primary care, also including the long-term care. For primary care, including the clinic and so-called the public health center. So we hope that in the HPH 2.0, it include not only the hospitals, but also the different kind of health service in this system. So there is a total of 8 standards. Based on the 5 basic standards that developed on the international level of health promoting hospitals, we increase one of the age-friendly, and the standard 7 is the person-centered care. In the past, in the 1.0 version, we put SDM health literacy into the patient information, but now we hope that this will be more clarified about this important issue. Patient-centered should be the future of the healthy hospitals. And also the climate change, climate action, including more and more, not only for the carbon usage, but also including the weather change. And there are a lot of things that in the new world that we have to facing. And there's totally, in 2.0, there are 8 standards, 27 articles, and 80 items. And totally, we decreased 32%. And then this is for medical center, and this is for district hospitals, because the size of the hospital is different. So it cannot use the standard for a medical center. It did not apply for the district hospital. So we doing some modify of the required articles and items. And also we not only pass and fail, but we also including 3 levels. One is the pass, and the silver medals and gold medals. And depends how you get the items. In the past, we had those site visits, but now we think that if you fulfill all these requirements, you should be get a gold medal for awarding system. And this is the medical center, regional hospital, and the other is about the district hospital. The number of achievement is different from these 2 different levels of service. So there is number 6, 7, and 8. So I want to use a little bit more time and discuss about 6 and 7 and 8, these 3 new standards. Why we have these 3 standards? So first we discuss about the age-friendly. We noticed the change of the population. This is 1996, 1960, year 2020 this year, and then in the future. Almost every 60 years difference, we noticed the change of the distribution of the population. The elderly populations become more and more. So we have to facing this rapid change of the aging population. In the year 2025, there are about 20% of population over 65. This is a very major issue that we have to face. And also our accreditation hospital should be target on these elderly people. We noticed that change very fast, and we noticed that there change different countries, especially in Japan and Germany, and also that in Taiwan, the curves are slightly lag behind Germany and Japan. So we learn a lot from these 2 countries, and also that there are some problems that they are facing that we are going to facing in the future. So we have to learn not only how they do it, and we also how they face this problem and how to solve it. This is the problem, age-friendly healthcare. We start with 2011. We know that aging population is a major issue that should be concerned. So we start with 2011. But these few years, there are a lot of different changes. So we have, by that time, in the beginning, that we have age-friendly institution, including all the medical centers, regional hospital, district hospital. And now there are public health centers. Almost 100%, is 90% of the public health centers become accredited for the elderly-friendly service. And also we have some long-term care facilities. We hope that the residents in the long-term care unit should also have some certain kind of level for improvement and health promotion. In year 2015, the WHO report on aging and healthcare, we noticed that this curve's very impressive, because we know that this is the senior outpatient strategy to delay the disabilities. But most of the people, they are quite stable, quite healthy, but once they get sick, they get admitted to the hospitals, and then there are three after that strategies. One is that they're progressing downhill. The other is getting better, but not in the original level. The best is that once they get sick and they recover to the original level, that is the best thing that we try to improve our elderly when they get sick. So in the past, we only focus on the blue line. They hope that they keep healthy in their communities. But once they get sick, what can we do during when they get admitted to the hospital? This is a program that we learned from many reference. We learned from Canada's Mount Sinai. They have a program called acute care for elderly. During the acute admissions, how we can improve very fast for those people, elderly, that get sick, and then going back to the communities, become the original levels. Also, there's originally we have some age-friendly health centers more than almost 15 years. They have published in the primary care. And ICOP, last year, they developed from WHO, they developed a very solid handbook that guide us how to do for the elderly assessment. And also we learned from the age-friendly health system from the United States, and they progress very fast. And just about 2 or 3 years, more than thousands of hospitals, they joined this program, including age-friendly health system, the 4 M's. So let's talk about the ACE program for the Mount Sinai. They including inpatients, including ambulatories, including the communities, and including emergency program. And there are, in each model, there are different strategies since last year, the government support 50 programs, including 36 hospitals. Some of the hospitals have engaged in two programs. For example, inpatient, emergency, or outpatient. So we have that pilot studies since last year, and we learned a lot from this process. During this year, so we have a lot of changing education program. For example, last year for the Global Health Forum, we invited Dr. Samuel from Canada and share. And this lady, I forget her name, and she is an emergency specialist for elderly care. So they shared experience in Canada, how to do the ACE in Canada, in inpatient, outpatients, and in emergency department. And in this year, even though we are under the COVID-19, but still working very hard on age-friendly healthcare in the hospitals. So we're doing regularly workshop. And actually, we have a case discussion every month across the different hospitals. They share their experience, how they face the problem, and how they solve it. For the four M's, I like this framework because he emphasized that the 4M means the what matters, morbidities, mentation, and medication. And the 4M including for the caring process for the elderly. The one thing that in Taiwan we do not in the past is medication, mentation, and mobility. But how about the what matters? When I ask my colleagues to write down the name on the whiteboard, they say, what is the matter? What is the matter, and it's different from what matters. So it is very important that we care of the caring of the elderly. So what matters is one thing that we have to emphasize. Under various studies, they're showing that if we do this is just released in July. There is a different version. The most updated version is July 2020. And also they have a handbook about the what matters, how to deliver the what matters information or communication with the people elderly when they admit to the hospitals or in the OPD clinic. And how, what's the benefit of this? Is actually they use it as a business cases. It means that we have to analyze the cost benefit. And it means that the fewer hospital readmission, better outcomes, and also more satisfied with patient and family and lower overall cost. Individual pattern, including the unwanted ICU care, if we ask about what matters, and also the days in the hospitals. The morbidities would decrease about the fall, decrease about the pressure shocks, and augmentations decrease the number of delirium, and medications, the adverse drug effects decrease. So it seems that there are quite a lot of benefit when we promote this program. Actually, in Taiwan, we are very successful in using about the polypharmacy program, and also with some of the, I think it's the medical pharmacy from the National Health Insurance. They have so-called pharmacy cloud, and then we can check it, and then the electronic medical record can retrieve all this information immediately in Taiwan. That's so very convenient for that one. For the ICOP, including this is the for including the nutrition, including the visual and depression mode, and also the morbidity. So there's a lot of guidelines for using, not only for examples, for the local locomotor capacity. If you find some problem during the morbidity, so what is the next step? In the past, we just doing so-called geriatric CGA, comprehensive geriatric assessment. But sometimes we find the problem, but we do not solve the problem. We don't have the guideline follow-up. But this is a very good pathway that once you find that if there's some problem with these issues, you can follow the next step. For example, for the locomotors, the so-called VV-Thrill the program. VV-Thrill is the component developed from the European country network. So we ask them to permit for translation into Chinese, and then we make it as a very useful handbook that once you find some problem with the morbidity of the elderly, you can follow to. I know that there are 7 passports, different level, and you follow the passport, you can just do it, exercise at home or under the guidance of some of the exercise trainer. And so it's much easier for you to follow up of the morbidities. And also, if I want the patient, after admitted to the hospital, they are prepared for going home, going back to the communities. They need to reach the support system from the communities. So we developed more than 90 so-called community senior service hub. This hub is a resources center in the communities. So when the patient, during the discharge planning, they can access to the resources in the community and refer back to the activity centers or the long-term care centers. There are a lot of resources they can develop, the local resources. And there are a lot of different hospitals they are using. This is the hospital that they apply for this program, and they are required to use the hub to discharge of the patient for the resources integration. Let me talk about the person-centered care. We notice person-centered care means that you have very important is the patient engagement. And patient engagement including the health literacy. This individual factors, also interpersonal, organization, community, and macro policy. This is including different levels about the patient engagement and health literacy. And we noticed that the health literate individuals and also the health literate organization that should be put together that we can make the patient-centered care more workable. In the Healthy Hospital, the first version that we have putting patient and family engagement and sense in the items. So this is, for that time we have 7 standards, and including the standard 3, we put shared decision making and health literacy into the accreditation. But now we are going to put it into the Healthy Hospital 2.0. We put it as an independent standard and more emphasis on the patient's engagement, the shared decision-making process, and also the training of the staff and the health information communication package. All these things should be encouraged and emphasized in the hospitals. And also it means about the shared decision-making. The previous slides about the health literacy and this slides showing about the shared decision-makings. We noticed that provider training is very important. So we developed some of the online training courses, including, and also the patient health literacy. And we hope that after this process, patient-family engagement. Engagement means the patient can have the abilities to participate, and also the provider allow the patients to engage. This is two processes. So including that we developed some of the certification, including the tools and also applications. And this year we developed many tools for health literacy, especially in the hospital, especially for the health providers. And this is one that the so-called the practical guide for health literate organization. This is originated by Professor Pelican. There is the health literate organization in Europe. And it's almost 150 modern articles, items in its original version. We asked for the permissions to translate into Chinese, and then we put a lot of different examples and change it into the guidebook instead of the checklist. And so this is why that the health literacy, including the medicine ethical. For health literacy and also SDM, you should have evidence-based and ethical-based and also experience-based, including SDM. So the patient's healthcare quality will improve. And not only for the, so SDM, very important, is about the patient decision aid. There should be health literate materials and also including evidence-based content. For the training materials, teaching back is one thing. Teaching back method is one very important, helpful method for teaching of the health literacy. So we developed online training program for teaching back materials. And there's evidence showing that after training, the health literate knowledge and applied teach back and communication improve for the health providers. Not only for the health provider, we also do it online simultaneous team-based learning. It is a kind of the flipped classroom team-based learning online that is more feasible for the training for individuals, for the health public health clinics, for the BC physicians and nurses. They can apply for this program. This is online training. They can stay at the working site and then join the program at the same time. And the other thing that we developed is a QPL, question prompt list, not only for the shared decision making, for the material that we discuss with the health provider, discuss with the patient, but also that how to educate the patients to ask more questions. Ask the correct question is very important. So there's a study from our team that for the low literate patient, once they provide with the QPL question prompt list, more engaged and more decision made for especially for those with the low literate population. And the number 8 is the climate action. I think that in section 3, Dr. Lin will explain more about this action. We noticed climate change the health, and there are a lot of, not only the cold but hot, but also for the air pollution. There's a lot of things that are changing in the climate. And hospital is one of the major energy consumption entities. So in the past few years, we emphasize on the energy consumption, how to less the energy consumption in the hospitals. And actually, we have some campaign. So in the past, we have environmental friendly healthcare institution movement for many years. And then we developed a guidebook for the promotion of the climate smart hospitals and already finished. And we have a conference in November. And also that develop a lot of climate smart technologies to decrease about the usage of the energies in the hospitals. And also we have some international cooperation. We have MOU with the Griffith University, the Department for Environmental Health. So this is from 3 people, the future. The person-centered care, the practice-oriented, it should be integrated multi-morbidities, and the personal digital health, this is in the aging and also personal health record, is in the future of the 3P. And also there's take-home message. I think that I like to use this, the lead purpose. We have used on both sides, top-down and bottom-up working together. This is why that the successful is that the government and health service working together and NGO working together is very important. And the second is the decreased health inequalities. Help little organization remove the barrier for communication is very important. And we develop our 4M model also. One, the M is money, the carrot is the money. They said that you have to give them money, the incentive. So we have given the hospital some incentive. Also, we have developed a method. So we are doing the pilot study. What is the appropriate method, the pattern? And also we have the monitor, or the evaluation accreditation. The most important is the changing of the mindset, 4M model for us. Because I've noticed that a lot of people think hospital is just for disease or for curing, but how to improve the health, how to change all the people caring of the health, and the health literate, engagement peoples, all these are the changing of the mindset. So I call it the 4M model in Taiwan. Okay, this is ours, person-centered care. In the past, HPA emphasized on the promotion, prevention, and protection. Dr. Chiu at participation at the partnership. But later, I think that person-centered care needs engagement and empowerment for the people and also for the health provider. Okay, this is my presentation. Thank you.
Thank you, Professor Wang's wonderful presentation. In order to facilitate the program, so we will refer all the questions from the audience to the panel discussion after we finish all the presentation. And the second topic, we are so honored to invite Dr. Oliver Gröene from the Europe. Good morning, Dr. Oliver Gröene. Do you hear me?
Yes, I can hear you. Can you hear me and can you see me?
Yeah. Good morning. I think it's early in the morning in Europe. Yeah.
It's still early in the morning, yes.
Okay.
Glad to be here.
Yeah. And before your presentation, it's my honor to introduce Dr. Oliver Gröene. He is currently serving as the CEO of International Network of Health Promoting Hospital and Health Services and Vice Chair of the Board at Optimatis AG. And he also published widely on quality of care topics. And from 2015 to 2019, act as a deputy editor of the International Journal for Quality in Healthcare. So today he will talk about the future of health promoting hospital. We give Dr. Oliver Gröene a big hand. Yeah. Oh, please. Yeah. Dr. Oliver Gröene.
Thank you. Thank you. So I will start sharing my screen. If you could just confirm, please, that you can see my slides in a moment. Can you see my slides?
Yes.
Excellent. So I will start then. Thank you very much for the opportunity to be with you virtually. I would have very much preferred to be there in person, but these times don't allow this at current. I'm delighted to speak on behalf of the International Network on the topic of health promotion in hospitals and health services, with a subtitle From Clinical Encounter to Strategic Responsibility. And as the title suggests, I want to make the point that health promotion in hospitals and healthcare is much more than what happens in the interaction between professionals and patients. It is clearly an organizational and strategic responsibility, and I think that very much builds on the previous speaker as well. Thank you very much for that. So the talk is structured as follows. I will briefly introduce the international network that many of you know. I want to reflect briefly also on how the HPH movement addresses current health system challenges. So that's reflecting on the title HPH in the Future. I want to outline some of the key activities that the Secretariat is involved in, the finalization of the global strategy, the new standards that we've just heard a lot about the work that has been done with the standards in Taiwan. We are releasing a new set of standards next month for the international network, and also our plans to establish a global e-learning community. So just for you to know who is behind the Secretariat, well, I'm Oliver. I'm here on this slide, but there are some other persons that you should have seen, at least on a photo, and you should have heard about. The person that many of you might have had contact with is Karin. Karin is our project coordinator, and she's coordinating all activities for the Secretariat. There's also Indra and Annika, who work a lot in the background to ensure that we have a good communication website and that all the numbers make sense in terms of membership administration, and my colleague Helmut Hildebrand, who is advising on policy. So this is a team at the Secretariat. We have other team members that support us when it comes to database development or the establishment of online polling or Delphi studies, as we're doing at the moment. And we have, of course, a much larger team in the organization, but this is a core team working for the Secretariat. We have, at the international level, currently about 560 members. That changes constantly because every month we've got some new members joining or some others leaving for various reasons. We have 20 national and regional networks, and together with the individual members we have in some countries, we represent over 33 countries. You can see here on the pie chart, the majority of members are still hospitals, but increasingly we also have other health services joining. And that's very important in line with the new strategy and the new standards to reflect on the whole continuum of care and not just hospitals. We're also very delighted with Taiwan being our strongest member, 138 members, and you can see the map of Taiwan on the right-hand side with the members located. If you haven't tried it out, we have established on our website an interactive map where with the Google analytics tool, the locations of all our member hospitals are embedded. So please feel free to use that and let us know if there are any inaccuracies. What is the network really doing? So we have four main functions. First, communications, that's developing and updating the websites. We have established and launched a completely new website early this year in February, which you probably have seen. We have established social media channels to communicate more widely on our work. And we work very strong on the second point here, advocacy in partnership with some of the key organizations that support our work or that work towards the same goals, particularly the International Hospital Federation, with whom we have a very strong link, also with the new CEO of the International Hospital Federation, with the World Health Organization, where we've just recently had various discussions with the Regional Office for Europe. but also other international organizations such as Healthcare Without Harm or Planetary. With Planetary, we collaborated on a document to address patient-centered care in times of COVID, but also local organizations here in France or in Finland that support local conferences or otherwise the work of the network. The key work of the network, of the international network, is, however, the strong collaboration with our governance board in order to support the development of new guidelines, standards, and e-learning opportunities. And I'm going to describe that in a moment. But before I do that, I just want to reflect on the question, well, why HPH in the context of future health systems? If we take some of the key points from a recent OECD report, the Health at a Glance series, it's quite striking to reflect on the performance of health systems. Over many years, we have been taking for granted that in high-income countries, longevity is increasing ever. People are getting older and healthier so continuously. But recent data shows that this is starting to reverse. Certainly in the US and in the UK, there's very strong data suggesting that longevity has actually decreased in the last years. Various reasons for that. There might be austerity, there might be broader societal changes, but one of the key areas is that the health systems as we see them today still reflect investments of probably 30 years ago. Hospitals in particular are built to last not just 5 years, obviously, but 30 years, often much longer. So the health system has, it's a bit like a super tanker. It's very solid and very straight on its direction, but it's very difficult to change direction. And in the last decades, chronic disease and mental health in particular affect more and more people, and health systems are not yet responsive enough to that. So we need new tools, new methods, new health system structures to respond to chronic disease and mental health. And this is why health promotion is becoming more important than ever. Also, smoking, drinking, and obesity continue to cause people to die prematurely and worsen quality of life. That is not a surprising find. However, yet the responsibility of many health service organizations do not address these risk factors sufficiently. So again, it's a clear area where HPH can make a big difference and where there's strong evidence to support our interventions. Thirdly, barriers to access to care still persist. That's an overarching theme also of the universal coverage discussion at WHO. And it not only addresses the less well-off, and it's not only an issue in middle or low income countries. Even in high income countries, barriers exist for disadvantaged population, and even for the wealthy. There might be different barriers. There might be simple physical barriers for people with disability that affect everyone. There might be information barriers. We've heard earlier about the topic of health literacy. That is a barrier that addresses or impacts on many. And then again, this is the presentations seem perfectly aligned, although we didn't even discuss them. Quality of care is improving in terms of safety and effectiveness, but more attention should be placed on patient-reported outcomes and experience. So what we've just heard about the importance of involving standards on patient-centeredness and shared decision-making in order to ensure that patients are treated with respect, that their experience is satisfactory, and that they have good outcomes is important. And I always like to give the example of a hospital conducting a surgery on a hip replacement where mortality rate is 0, where complication rates are 0. But if you look at aggregate data, and you can see that in one hospital, patients discharged after 3 months are able to exercise and they're physically active and mobile and without pain. and in another hospital they are still in pain and still not activated, then it shows there's so much more the health service can do to mobilize people after they leave the institution. So that's, again, a key reason to involve not just hospitals, but hospitals and subsequent care providers, be it primary care, rehabilitation, nursing, or other organizations. And lastly, countries spend a lot of money on health, but they do not always spend it as well as they could. Now, I don't want to go into detail of that, but it's true that a lot of the investment addresses treating people with a disease rather than trying to prevent that disease to manifest itself. And I think if we just reflect on these key challenges of health system performance based on a large analysis of the OECD, then I see there are a lot of different entry points for health promoting hospitals and health service to help improve health system performance. And just one note to add to that, you will have probably seen the global burden of disease data on the right-hand side for Germany. Blue are all the disease of non-communicable disease nature. Green are communicable disease, and red are communicable disease and green are injuries or accidents. I think with COVID that might change a little bit, that we have a stronger representation of communicable disease across the board. But the key point really, if we look at the global movement of HPH, we haven't been very strong or very successful even to encourage countries or member organizations in low-income countries to participate in our network. But if you look at the shift in the disease burden just in 10 years' time from low-income countries, they have a substantial burden of disease from chronic conditions now compared to 10 years ago, and that is changing and unfolding rapidly. So even for low-income countries, HPH becomes a more and more important area of action. So I just want to highlight now some of the areas that we've been working on, and sometimes small changes make a big difference. One of the changes is that we have been invited to present a new definition to the WHO Health Promotion Glossary, together with Professor Pelikan, Kristenson and Fox. We've worked on a new definition, and that introduces a number of changes to the existing definition. First, and that has been a lived experience already, the older definition didn't include other health services than hospitals. So we've included health services now in our definition. We've then put more emphasis on governance models. We want to build on the excellent work done to improve health promotion from the professional standpoint, from the health professional, but we want to have a much stronger organizational and leadership commitment. So we want to look at governance models. We also want to look at not just outcomes or counting procedures, like how many procedures a hospital has done, but the aim should really be to optimize health gain of patients, staff, and populations. That's the example I've given earlier on the hip replacement and the ability to move freely after 3 months. So that's an example of a health gain rather than a hospital or clinical focused or surgical focused outcome on complications and mortality. And very importantly, we've added that we're not talking about health care, we're talking about societies. And we see a responsibility and role of HPH to support sustainable societies. And that links in to the environmental theme and the climate action theme that we've heard earlier as well. We are currently updating a lot of our governance documents. You know that we have our annual General Assembly next month, and we'll present a lot of new documents. We have adapted our constitutions to reflect on the new challenges and the new strategy. We are finalizing an action plan for the global strategy, which is currently being discussed with the governance board. We are finalizing also our new set of standards, which build on existing standards developed in the network, and we are working on developing a global e-learning platform. You've seen this slide to some extent earlier. These standards have been translated into so many languages, I think more than 15 languages. You can see here Japanese and Persian, and of course they're available in many European countries, and Chinese, and a lot of work has been done in translating this work to national and local context. And some countries have taken it much further, as the case of Taiwan, where you have developed a accreditation certification program and added content to the standards. The revision of these standards, which are quite old, the original standards, 15 years old, has been going on for a number of years. And this is to give you an idea that based on the original standards document, various working groups in the network have developed specific standard set for older people, for children, adolescents, for health literate organizations, for mental health, environmental aspects, for migrants, and of course for behavioral interventions. We discussed in the network that we should try to integrate a lot of the key items from these different standard sets in a new set of umbrella standards, and that work is currently being finalized. We have been able to build on the mapping exercise conducted by Dr. Chiarenza from Italy, who presented this work, I think, 2 years ago at the General Assembly of the International Network. And based on that mapping, when we took over the Secretariat, we have been given the responsibility by the Governance Board to work together with Antonio Chiarenza to develop this mapping into a new overarching standard set. And to that extent, we have had various discussions with expert groups. We have conducted the first Delphi round to see whether there is support to the overall domains and its subdomains, and that Delphi round has been completed and led to a number of changes and adaptations. We have also started a second Delphi round after we have added standards for each of these domains and subdomains. So that is now being finalized, and we're very much looking forward to the feedback from our experts. And as you can see, the new international standards map on the same items that were highlighted just half an hour ago, on patient and person-centered care, on the healthcare environment, and promoting health in the wider society. So I think while the international network might have been lagging to some extent behind the work done in Taiwan, we're now glad that at the international level we'll be able to produce a new complete and comprehensive standard set, which hopefully will be as fruitful and constructive in supporting our members in implementing health promotion in their health service settings. Also, we are developing our global e-learning platform. So that's a platform that will be based on the key outputs of the network. I think to some extent the international network needs to take into consideration much better what is being done in the different regional and national networks. For example, the work you're doing in Taiwan, not a lot of that is being shared at the international level, beyond, of course, the presentations of the representatives at the international meetings, but it doesn't find an easy way into the strategies of other national and regional networks. So we really want to build on the tools developed nationally and regionally and help that others can reflect on them. And to that extent, we will build an e-learning community. We will use existing material and with your help identify individuals that can help produce audiovisuals and testimonials And our key aim is really that through this work, we want to support local implementation to have a much stronger input from the international network level on our membership than we did in the past. And this learning platform will be based on 3 principles. First, for any given topic, we want to clarify the concept and look at the scientific evidence and methods. And that's a typical learning objective of knowledge acquisition. But we also want to help individuals to identify aims for implementation and help them attract senior level support. And the platform will give implementation tasks so that local teams can get together and work on implementation tasks and share them back with the international level. And I think this will really accelerate implementation, accelerate knowledge sharing at the international level. And I'm very excited about this work going forward. So to finalize the future of health promoting hospitals, after so many years of work on health promotion, the network has more than 2 decades of experience. Is there still a role for the network? And I hope that I've been clear in answering that question with a very strong yes. I think the network has a better and more important responsibility than ever. The patterns of disease are so clearly requiring further action in the health promotion field. So seizing these opportunities is more important than ever. We've also had a lot of work done in the last year on new definitions, new constitutions, new global strategy and action plan, new standards, and the online platform that we're developing. And I think this again will move forward our work with the countries, with our networks and members much better. And to some extent, I'm jumping to the last point here, the e-learning that we're developing, I think we started thinking about that last year, but with COVID, I think there are many more opportunities now to engage partners across the globe than before. Just this month, I've been able to speak at 4 different national events, now to you in Taiwan, earlier this month, to colleagues in France, to colleagues in the Baltic states, and also in Sweden. So I think the web communication tools that we have now should really be exploited also to support HPH. We have a growing network, particularly in Asia, and I think one of the discussions that we also need to reflect on is how we can support our members in Asia, as well as, of course, continue supporting those that we have in Europe, while also encouraging new membership in new world regions. As I said, the low-income countries are shifting in their burden of disease quickly to chronic disease, and I would be excited if we were able to encourage memberships in South America or on the African continent. And finally, in the last couple of months, we have been able to realign the network very strongly with partners at international level, the International Hospital Federation, WHO, and others. And I think with that, I believe we are very well positioned to support HPH in the future. If you've got any questions or suggestions, this is our email. Please do write us. We're happy to be in contact with you. And again, I very much would have liked to be there personally. Perhaps that's possible at a later stage. Thank you very much for your attention.
Thank you, Dr. Oliver Grant, for your wonderful presentation. And we are looking forward to a solid relationship with international HPH under your leadership. And we hope the brand new umbrella standards can bring out the best practice for all the healthcare institutions. So, Dr. Oliver Grant, you need to wait a moment, and we will invite you to join our panel discussion. Yeah. So we will move to the 3rd topic. And the third topic will be presented by Dr. Ming-Nan. He graduated from National Taiwan University College of Medicine, and he attended MPH from the National Taiwan University College of Public Health. He is currently serving as the Vice Superintendent of the Dalian Tzu Chi Hospital, and he also the chair of Task Force of Health Promoting Hospital and Environment, HPH, in the national network. And he also the coordinator of the Taiwan HPH network. And today we'll talk about the personal health to the planetary health. Please, Dr. Lim, please. Let's give him a big hand. Yeah.
Thank you. Thank you, Dr. Huang. Good afternoon, ladies and gentlemen. It is really my honor to share with you the topic from personal health to planetary health, the role of health promoting hospital in post-COVID-19 era. I'm now currently the chair of the HPH and Environment Task Force. And then this is my outline. I think that Director General Wang and Dr. Oliver has already talked about the HPH. It has been more than 27 years, and now we are going to have some revision of the standards, and there's some different challenge we face. So especially in the era of climate change. So as an important role in healthcare, so hospitals and health services need to do some different modification. First of all, I want to talk about, this is the spectrum of human health. I think that most of us know very clearly that there is a spectrum of health. Prevention and promotion is better, but harder than treatment. Most of the healthcare professionals are disease treatment professionals, and then we need to focus more on health promotion. I read a book this year, Spill Over, Animal Infection and the Next Human Pandemic. I was quite astonished that the scenery depicted in this book is just like what happened in the year 2020. In the year 2013, David Quammen already talked about that the next big human pandemic is likely to be caused by a new virus coming to human from wildlife. As we know that the new emergent and re-emergent infections, disease and the possible host, actually since 1970s for this infectious disease, more than 70% is zoonotic disease. That is common infection between human and animals or livestock. And why we have this kind of disease? Because they're probably due to the intimate contact between animals, livestock, especially wild animal. As you can see, there are 3 bats here. Ebola 1976 and 2002 SARS-CoV, and now possibly SARS-CoV-2 in the year 2019. And now, I don't know you know it or not, that there are more than 1,400 species of bats. And I just know that because I Google on the internet. And today is the Bat Week, October 24 to 31, 2020. Bat is a quite good animal. The only animal that can, the only mammals that can fly. And then, there are around 200 coronavirus in bat. And there are 7 coronavirus in human. The first 4 strains has been isolated, and they are common cold virus. But they have been coexist with people for like more than hundreds of years. And the 5th and 6th and 7th, that is quite lethal, recently identified in the year 2010 SARS-CoV virus. And MERS, in the Middle East Respiratory Syndrome COVID virus, and last year, SARS-CoV-2. These are the 3 viruses isolated who cause a lot of casualties, especially now we face the COVID-19. Besides zoonotic infectious disease, vector-borne diseases are also emerging these years, such as dengue fever, malaria, Zika virus, chikungunya, and yellow fever. From the year 1960 to 2010, dengue fever increases 30-fold around the world, and then expanded from tropical area to subtropical area. And all these problems made due to climate change, and it will increase the burden of healthcare system. You may remember in the year 2015, the photo depicted a picture in an ER in the hospital in Taiwan. In the ER, they're all mosquito tents, because in that year, there are more than 20,000 new dengue fever cases. It caused a lot of burden of the healthcare professionals. So as you can see here, is that 老娘不干了, work too hard. And in that year, more than 200 casualties caused by, totally in Taiwan, there are more than 40,000 new dengue fever cases, and then caused about 218 casualties due to dengue fever. So facing the pandemic, treatment always isn't enough. We need to reorient the health services to health promotion. And then this is the Ottawa Charter for Health Promotion. Create supportive environment, setting approach, health promoting school, health promoting hospital, healthy cities. All these create supportive environment. I think that our Director General, Dr. Wang, he's an expert in doing all these programs. In Ottawa Charter, the setting approach for health promotion said health is created and lived by people within the setting of their everyday life, where they learn, work, play, and love. And then human behavior is determined by the physical and social forces which are present and interacting in any setting. So the physical environment and social environment is very important for our health. And then it involves the target population as a whole in the context of their everyday life and in their unique environment. And we need to do it with a holistic and comprehensive approach. Dr. Oliver just showed us the manual and self-assessment form. It is developed by him and released in the year 2006. We use it like for 20 years. And this is the HPS self-assessment form. There are 5 standards, and then 13 substandards, and 40 measurable elements, and 18 indicators. But as you can see, the targets for health promotion hospital staff, we all know that if the staff has the concept, the mindset of health promotion, then the patient may be benefit from that. And then second target is patient and their family, and outreach to community member. And also the target for HPH should see the hospital as a healthy organization. Dr. Oliver told us that the new standard is coming soon. If you go on the website of HPH International Network, you can see that the umbrella in the GA meeting next time there will be a beta version that will come out. And then we have to know that the impact of COVID-19, the impact on patients, impact on healthcare workers, and impact on healthcare system. And these days, we know a lot of evidence that the COVID-19 had many, many impacts on all the healthcare sectors. Just like Morris Zhang, TSMC Zhang Zhongmo, he said that just like another world war, this pandemic may change our life forever. Not only the healthcare sector, but the economic, the environment, and then for World War, we are now more than 150 countries involved in the world. As for patient, this is the statistics released, meta-analysis, talked about the patients. Risk factor for critical and mortality in COVID-19 cases. Like for male is 1.76 times critical and mortal cases. And if it is age patients or more than 6 times, it will be critical or mortality. Smoker, diabetes, hypertension, cardiovascular disease, and respiratory diseases. Yeah, especially for elder. Now in Taiwan, we are facing an age society. So we know that this is an infectious disease, but if the patient is old and with NCDs, and the mortality or severe, the severity of the patient infected with COVID-19 will increase like more than 5-fold. And if you check online with COVID-19 to PubMed, you can find all the healthcare professional and publish more than around 67,000 articles these days. And then this is our global forum. This is also the first time that we have these web conferences. It is also due to the COVID-19. So COVID-19 changed a lot of our daily life. Healthcare, we have to speed up the telemedicine, and then the patient, we have to focus on their immunity, their risk factors. Besides the infectious condition, we have to promote their health. And then what can we healthcare sector do? This is the Lancet Commission on Health and Climate Change. It stated that the health community has a vital role to play in accelerating progress to tackle climate change, because the zoonotic diseases and new and re-emerging infectious diseases, they're mostly due to climate change. And healthcare community, we are quite trusted. So we have to communicating about health and climate risk, and then ensuring mitigation, strengthen public health, and adapting to face new and emerging health risk. And also, we have to reduce emission from health services. By moving toward low carbon health system, we have to mitigate our own climate impact and become more climate resilient, and we have to lead by example. This is also from Lancet. It talked about the voice of public health and medicine. We have to be an independent consciousness of planetary health. and we to play in achieving this vision. This is healthcare sector and climate change, because healthcare sector use a lot of natural resources, and we are the knowledge center for health, and there is a large number of people pass through our healthcare sectors. And then for healthcare sector and SDG, the World Health Organization has identified climate change as a global threat, together with health and well-being, this goal 3. And sustainable energy, goal 7, sustainable product and consumption, goal 12, as well as life between water and on land, goal 14 and goal 15. The global framework for addressing climate change, healthcare, and sustainable development is incorporated with United Nations SDG. As you can see, 10% in Brazil, 10% of the total country energy is on healthcare sector. And in England, in UK, NHS in England, 25% of the total public sector emission are due to the healthcare sector. And then it will cause climate change. Like this is States, this is in Europe. And then it will all increase the burden of the healthcare sector. And then this is a vicious cycle, because the burden of healthcare sector, and then the energy and also greenhouse gas emission were also increased. There's some evidence in Taiwan. This is in Taiwan. Relationship between heat index and mortality of 6 major cities in Taiwan. As you can see, daily mean heat index are associated with increased mortality at low latitude in the northern hemisphere. And then daily mortality are evident when heat indexes are extremely high, like a 95% percentile compare different regions. And then heat index is a potential predictor of heat-related mortality. And this is also published under Taiwan's data about temperature effect on hospital administration for kidney morbidity in Taiwan. And if the temperature is deviated from 25 degrees Celsius, higher temperature has more profound influence on hospital admission on kidney diseases. And then especially for both less than 65 years old and over 65 years old. And the high temperature influence more on the morbidity of kidney disease. So for climate change and health, it has been told for a couple of years. Climate change now is a health emergency. In the year 2015, this is in COP, the UN Climate Summit. And this is the first special report on health and climate change. The item 5, it talked about mobilizing the health community for climate action. And then it said, facilitate and promote the engagement of the health community as trusted, connected, and committed advocates for climate action. I think that maybe you know that our healthcare professionals are the most trustworthy profession in the world. But not actually, firefighter is the #1. But in the first professions, trusted, nurses for a consecutive 18 years. I read the article as better than doctors. We have to think about why is that. And then, but for the first 7 trusted professions, healthcare professionals, there are 4 including nurses, doctors, pharmacists, and also some paramedics. So we are the most trusted professionals. So we need to do something. And this is the sustainable quality improvement framework in healthcare. Reduce carbon, improve health. We can do it by reduce activity or reduce carbon intensity. Reduce activities, if we focus on prevention, primary prevention or secondary prevention, it can decrease the burden of healthcare. And then if we empower the patients, they don't need to come to the healthcare facility to do treatment. So it also reduces the activities. And then for the hospitals, we need to do some lean healthcare. So there are lean pathways, try to reduce unnecessary activities in the hospitals. And also we can reduce carbon intensities. Like low carbon alternative. Now there's some survey on anesthesia gas, because the gas, some of the gas is very, the global warming effect is very intense, very high. So they are now doing some research to replace some of the anesthesia gas. Or we can reduce carbon intensity through operational resource use, like electricity using renewable energy. This is the new website of the HPH International Network. As you can see, the website talked about improving the health of patient, staff, community, and also the environment. In COVID-19, there are resources, support during the crisis. If you can check on the website, there's some information about as for health promoting hospitals, how can we do during the COVID-19? Actually, there are a lot of resources, but for health promoting hospitals, the website has some information, some data in that website. And then there are 5 task forces in HPH, and task force of HPH and environment is one of the 5 task force. And the task force firstly established in the year 2010 by Dr. Sudi Cho, and now currently I serve as a chair. I hope that many of the member hospitals can register and come here to see some, share some experience of their hospitals. And they are also task force website. So you can go on the internet and link to our task force apps website to see some information. And then since the establishment, since the start of the task force, we held symposium to advocate climate change and health. This is just like last year in Warsaw. We invite 3 young speakers to share their experiences of climate change and health. And they're from, this is MD doctors, this is medical students, and this is a public health PhD candidate. I think that we should involve the younger generations and then share the experience. Even we can add some curriculum on medical and medical curriculum, climate change medical curriculum. Okay. This pandemic is a very big impact on not only the healthcare sector, but also the whole globe. And during this kind of impact, although we cannot change the direction of the wind, but we need to adjust ourselves. Hopefully that we can pass through this pandemic, and due to the action of our healthcare professionals, then we can combat the coming pandemic in the near future. Thank you.
Thank you, Dr. Lin. As we know, and the CG group has been made a great contribution on climate change, such as the waste recycling and the carbon mitigation. And Dr. Lin is the frontline fighter against climate change. So we will move to the fourth topic. The fourth topic will be presented by Dr. Margareta Kristenson. Dr. Kristenson, yeah, can you hear me? Yes? I see you here. Okay. And I'd like to introduce Dr. Margareta and Kristenson. He is currently serving the chair of health promotion in hospital and health care governance board. And she is a specialist in family medicine and in school medicine and public health. And she was the national coordinator for the Swedish HPH network for many years, and is presented as senior advisor for the Swedish HPH and chair of the governance board of the International HPH network. So today he will give us a topic of the role of health promoting hospital in the post-COVID-19 era. Okay, Dr. Kristenson, please. Let's give her a hand.
Thank you. If I can share the screen, I shall just open my up. Can you help me share the screen? So, can you see my slide now?
No, we cannot see your presentation, your slide. Yeah, but we can hear your voice.
Yes, but the slide is here. It should be there.
Oh, okay.
You're sharing my no?
Yes. Oh, yeah. So you need to put it on display and.
Yes, a month. So.
Oh, okay. Yeah. That's a full screen.
Thank you very much. So again, thank you for your kind invitation to participate in this conference. And just as Oliver said, I would have wanted to be with you, but as you know, this is not possible this time. So I send my greetings from Sweden, and also we have morning here. I have the possibility to speak about the role of HPH in the post-COVID area. Actually, my title was the role of health promoting hospitals, but I wanted to add health promoting hospitals and health services because just as Oliver talked about, it is important that we speak about the full system. What I wanted to share with you is some thoughts about how the COVID pandemic did demonstrate how societal crises tend always to hit hardest on people who have the poorest resources. Also for the COVID-19, the direct effects, which means those who had the serious illness from COVID-19 or had the highest risk to become diseased, and also the highest indirect effect on unemployment, poverty and social isolation was highest among people with low socioeconomic status. And as described before, the prevalence of chronic diseases which increased and lifestyle matters which increased the risk of COVID-19 is very much higher among people with the low socioeconomic status. This may therefore lead to increased inequalities in health. Just as Oliver said that in the, so to say, rich world, life expectancy is not always rising. And also, just in Sweden, which has been seen as a very equity country, inequities in health is rising. This is life expectancy at birth, at 30. And you can see that while we in the start of the 1980s had rather small differences in life expectancy, these have risen. And today, the difference in life expectancy, both for women and men, are about 6 years. And you can see that for low-educated people, life expectancy is actually decreasing. And combined with the effect of the COVID-19, we can expect that these discrepancies will increase even more. And what are the main causes then for these differences in health? Well, I know that you had listened to Michael Marmot on the first day, and I had the honor of being a chair for a commission on equity in health in our local community, in our county. And there we developed this model where you can see that in the outer part, I have just some problem with a thing which comes here. So, how's that? In the orange circles, you see the sustainable society, which is necessary for also equity in health. And the balance of economic, environmental, and social dimensions, social, economic, and ecological sustainability. In the next circle, we have the different arenas where Michael Marmot used to say where people live, love, work, and die, and housing, neighborhoods, culture, education, environment, provision, health services, care, and social work, which affect our possibilities to have education, occupation, income, and employment for which we can live, which affects our lifestyle habits, social environments, and the inner circle, which we included in this, which is about confidence, trust, and hope for the future. These together are the causes for and the determinants for inequities in health. And the red heart in the middle of the man, I shall come back to, but this is about the medical and psychoneuroendocrinological mechanism for vulnerability, because this is about vulnerability. It's about equal human rights and proportional universalism. But the COVID-19 pandemic has also put a major effort on health services. We have a big care debt, a lot of canceled surgeries. We have a health debt. We have cancer rehabilitation and cancer prevention. We have a very strained personnel. They have, for now half a year, had a very heavy work stress, but also ethical stress of many difficult decisions. And we have an increasingly strained economy beyond effects already by a changed demography, as described earlier, with increasing part of elderly and disease pattern with increased part of chronic disease. The outer circle you saw, the societal economy is strained, which affects the health systems. And this increases what Oliver just said. It increases the demands to develop a more effective and a more proactive healthcare. Sometimes I have, in the work of equity in care, got the argument that we shouldn't include health services here because they are only, so to say, treating the symptoms. But treating symptoms is also important. But we are also very important for prevention, promotion, and protection. And what I wanted to lift up here in the discussion, the crisis also gave us opportunities. There is today an increased awareness of the need of health promotion and prevention, and of building resilience, both of people and of organizations. New innovative working models have developed. Collaboration both within and between organizations and mutual trust have developed during the crisis. The interest of and the pride of and interest of work in health services is also rising. And the compassion and helpfulness among people has increased. I think you have seen the in Italy where people were singing on the balconies to support one another. And I mean that if we have carefully taken advantage of this development, health promoting hospitals and health services can be responsive and responding to and meet these urgent needs. If we fulfill the holistic and health-oriented vision of HPH. As Audrey said, this is actually old. It started after the Ottawa conference in the middle of the 80s, where the vision of a more effective health service by reorienting towards health gain for patients, co-workers, and the public served was launched as one part of the necessary actions to promote in a more effective way the public health. And you have already seen this new HPH definition, which now describes that this is not only because a risk with HPH has been that it is about health promotion activities on top of an ordinary health service. And the important thing is that this is the center core, a way to optimize health services. And that means that we need to orient the whole governance model, the structures of the process, and the culture, as described earlier. It's about the mindset. Thank you for that. To optimize health gains of patients, staff, and populations served, and support sustainable societies. So the international network of health promoting hospitals and health services, this was initiated by WHO in the 1990s, as I think you remember, and it's now widespread over the world. I wanted to give some examples from Sweden, how we are working, just to be a bit more concrete on some things. And in Sweden, as you can see, the regions, the squares here describe the regions, and our members are regions, and this includes health services, hospitals, primary care, but also dentistries. and also the purchases. And we work for patients, co-workers, the society and population, and the management, reorientation once more, to better meet the needs of society. And this was the original idea again. Halfdan Mahler, who jumped through the wall of the hospital to say that we must be more responsive to the needs of the society. And this is even more important today. I wanted to give some glimpse down in the four. In Sweden, to simplify, we describe the four perspectives. And important to me is that in the patient's perspective, again, integrating health promotion and disease prevention in the care chain. This is not, and you have heard it before, but there are some colleagues who believe that this is because people shall not have a disease in the future. And this is also important, but this is primary to optimize the health gain at the service. The co-worker's perspective is more important today than ever. As you know, people, and as described, the personnel is very strange, and it's also difficult sometimes to have people staying in health services because the working situation has been so hard. And I always meant that we need to be a model for the best health promoting workplace. If we are experts on health promotion, our workplaces should be the best one. We know this. The population perspective, this is the part where we have been working too little and must support much more. And not only by sending out information, but actively supporting public health interventions for the population served and in the local communities. And to do so, use health orientation. When it comes to patient perspectives, again, I wanted to point to two things. It's these two parts, developing a person-centered care, empowerment and health literacy, and giving support for health behavior change. And the patient-centered care, empowerment, to me, the essence of this is to help patients to feel trust in their ability and hope for the future, because this is essential for not only well-being, but also survival, also in the most intensive part. And this is from intensive care registry, where we made a study and could demonstrate that hopelessness is as more important than presence of disease for survival after being treated at intensive care, and also for health-related quality of life. And we know today there is so rich research, and this is my favorite area. I shall not speak in hours, but I can only promise you, if you doubt, that there is today so rich information and research on the power of our emotional systems and our trust and coping ability or hopelessness on our major protective systems, resistance systems, the cortisol release, the inflammatory markers, etc. So this has effect on our vulnerability or resilience. The second part in the patient perspective is the giving professional support for patients for health behavior change. And just to remind that this has effect immediately. Already the week after the surgery, smoking cessation reduces complications dramatically, and this is very, very cost effective. The population perspective, one example which we work much in Sweden now is health dialogues for primary prevention of non-communicable diseases, where we invite age groups 40, 50, 60 and 70 years old for a health examination
and a health dialogue from their individual curve. So this is a motivational interview based on their individual risk curve, including the lifestyles, but also body mass index, blood pressure, cholesterol, etc. And in combination with the structural interventions in the local communities. And a very, very big follow-up study has demonstrated how this has dramatically decreased mortality, and also that it has the strongest effect for people with low socioeconomic status, that is decreasing inequalities in health. Finally, the management perspective. What we have seen is so extremely important is that disease prevention and promotion are explicitly described in assignments and also followed up. And to cite Oliver, we have not prepared this, but we have the same song, that in following up quality measures that they have to include patient-reported outcomes. And they also have to include behavioral interventions effects. And also we need to work more with health economy analysis, I think, to really put forward our arguments. When it comes to the co-worker perspective, for me, the important thing is not to have a new stress relaxation room where people can go when they are exhausted, but to have and working on an organization where we include the personnel in the development work, that we increase the professional pride, participation, and effort balance at work, so that the ordinary working situation is inspiring, is learning, is attractive, and powerful and prideful. Just a brief picture on an instrument which I can talk to you much more later. This is a health calculator where you, if you can calculate the possible health economic gains for a public health intervention, where you, for example, reduce the prevalence of each of body mass index, smoking, physical inactivity, and hazardous alcohol drinking with, for example, 1% unit. And the example here shows that by effects on ischemic heart disease, lung cancer, colon cancer, etc., the reduction of costs for this county is almost 4 million Swedish crowns, and that is $400. So, and this is only for health service. The effects on societal costs is even better. In Sweden, we had a new national goal for public health in 2002, and then for the first time, one of the target areas for the population health was a more health-promoting health service, and this has been a great value for the work in Sweden. Actually, in June 2018, this was upgraded to equity in health-promoting health services. And to finalize, because the idea of this was that the health service can and must be more active, not only for health promotion and prevention, but also adapt our services so that we not even increase inequities in health, which sometimes happen because we deliver unequal service. But by instead being careful about including promotion, prevention in the way the HPH concepts described, this is most important actually for people who have the most difficult situation. And by orienting governance models, structures, processes, and culture, and optimize health gains of patient, staff, and population, we can reduce inequalities and inequities in health, and we can develop a resilient health service and support sustainable societies. So, in the post-COVID era, health promoting hospitals and health services, networking for change. Thank you very much.
Okay, thank you very much to Dr. Kristenson. Thank you so much. And now we'd like to move on to the panel discussion. And for that, we'd like to welcome our moderator and also speakers to have a seat on the stage. We'd like to welcome once again Dr. Hui-Ting Huang, Director General Ying-Wei Wang, Dr. Ming-Nan Lin, and also online we have Dr. Oliver Gröene and also Dr. Margareta Kristenson joining us. And now over to our moderator, Dr. Huang.
Okay, now we start the panel discussion. And this section comprises 4 topics, and now is open for discussion. And we can broach the subject. So we have 2 speakers on site and 2 speakers online. So you can raise your question from our audience. Any question for these speakers? I think it's a very lifetime opportunity to raise the question for them. Yeah.
Do you have any questions from the crowd?
Okay, yeah, please. Yeah. The lady sitting on this row.
Thank you for the wonderful
Professor
talk.
Chu.
Yeah, it's me again. Yeah, I'm waiting to see whether there is anyone raising the hand, but they are so, they do not want to raise their hand. So I shall behave as a person in the audience, okay? Yeah. I have 2 questions. One question is that I'm excited to see the new definition, including sustainable society into the definition. However, and also I'm very happy to see Margareta mentioned equity in her talk, but I haven't seen that aspect integrated into the new standards. In the draft, I saw patient-centered, this terminology, and in Taiwan's standards, we saw person-centered as a new standing alone standard. But I haven't seen people-centered or people-oriented or equity-oriented element in the new standards. This is the first question. And the second one is, in Taiwan's new framework of the standards, age-friendly aspect is an independent one. But are we going to add another one for children or another one for adolescents, etc.? To me, it seems like older persons or the patient-centered approach should be already there in the existing standard 2 and the standard 3. So why are we going to get age-friendly perspective as a standalone new standard? Yeah. Or should it be integrated into standard 2 and standard 3? That's my 2 questions. Thank you.
Okay, Professor Wang. Yeah,
in the HH version 1, we integrate age-friendly independently, but also But for person-centered care, we put into the standard 2 or 3 patient information. But now there are a lot of workable criteria. Actually, in the first 5 standards, I think that there are a lot of, including the new standard for HPH, I believe that there are a lot of the philosophy in the definition. But we hope that we can get some workable criteria or workable standards that we can put into action. So this is why I put it into the standard 3, 4, 6, and 7, and 8, because there are a lot of in the detail that you notice that there will be some workable or applicable in the real world standard situation. Sometimes the standard is quite philosophy or guiding principle, but if we want to use it in the real world, we need some solid and detail how to work on it. So this is why we put it into the 6, 7, and 8. And also, last year we have things the children and adolescent friendly hospitals pilot study. We are doing that, but probably in the future, but not in the present moment that we put in the standard. But there should be one part of it for the adolescent and children, but we're still on working on that issue.
Can I also comment from the international perspective on this question? So thank you very much for the question. I think it's very important. First, if that is a question on the international standards as well, then of course any feedback at current is still appreciated and can be incorporated. As you know, we have the Delphi phase 2 running until Monday next week. So any comments we receive can be reflected on in the refinement of the international standards. However, I do believe that we have addressed many of these issues already in the draft that is currently for consultation. Equity issues are addressed throughout various standard sets. There are particular standard statements that encourage reaching out to disadvantaged groups, encourage making special effort to help communication with disadvantaged groups. So I think there are various statements that are embedded through that, and they build on the work done by the working group on equity. And of course, an overall challenge is that if we count all the standards developed by the different working groups, there are about 648 in total standard statements. So for the umbrella standard set, we need to be, to some extent, selective and prioritize. We have currently 96 standards. The other point that was mentioned, should there be specific standards on elderly and adolescent? Again, based on the mapping done by Antonia Cerenza, the key standards addressing the needs of elderly patients and children and adolescents have been incorporated in the current standard set. So there were various statements that address the needs of children, adolescents, the needs of elderly, and they are not in a elderly or children standard, but they are addressing the general domains because there were so many overlaps in these different standard sets. And then the final issue on the person-centered care, I couldn't agree more. That's extremely important, and I'm very glad that we've been able to incorporate many new aspects in the current international standards. We have strengthened standards on respect, dignity, and communication. We've included for the first time standards on shared decision-making. We've included for the first time standards on self-management support. And of course, we have incorporated various standards on health-related organizations. So I think I don't want to reject the statement by no means, but if it's a comment on the international standards, please do send us your feedback. And I'm sure that maybe sometimes it's a matter of making things more visible through phraseology. But I think we have made a huge step forward in the current version of the standards.
Margareta, if I may comment, I do agree that we have we are a huge step forward. But of course, I think it's Shuti who is asking the question. Of course, this will not be perfect the first time, but it is really a big step forward. And actually, when I read through the outline, which is now, many of the items from grasped from the elderly and the children are so elegantly phrased on the need of a holistic approach that they should be used for everybody. It's not only important for children to have a holistic approach as written, but for all of us. I think also that we must have a reasonable amount of items because it will be too difficult otherwise. But if these principles are in place, then the details can also be defined in when needed. I don't know if you want to comment on that, Oliver, that in the area of digital possibilities, there can be possibilities to dig deeper.
Yes. As you all know, we are running on very tight deadlines to produce the document for the General Assembly, and we will. And as we've just discussed with our expert groups and governance board, we are confident that this is a high quality document reflecting a major step forward. However, we anticipate that it's not a final. In fact, various speakers have referred to the original standards, which were produced between 2005 and 2007. That's a very long time to consider updates at the international level. And we want to avoid that there's another gap so long before we get to the next updates. So there hasn't been a decision yet, but there have been suggestions to establish a standards review panel at the international level, which takes yearly decisions on updates of the standards. So we would have a much more agile process to review standards and incorporate new information. And there have also been proposals to establish an interactive based platform where we can support standard statements through further information. If I take the example of the children's standards, there are a long list of standards and also children's rights. Somehow that's a little bit mixed up in some of the background documents. But of course, in an online format, we can easily refer to all the background information so that those that want to engage in particular on, say, the implementation of standards, strengthening children's rights, can have access to that easily without the need that we do incorporate all of those standards in what would be our common standard set. So I think there, and some of these discussions will in fact take place at the General Assembly about the way forward, because as said, I hope clearly that these are points for discussion with the national coordinators, and we want to involve them in determining the roadmap for the update of the standards in the next couple of years.
My opinion is that every year there's the International Health Exchange Conference. There are a section about the standards, and there are a lot of debate for many years. It seems that it's difficult to come to final consensus properly. It's because, as you mentioned, there are a lot of different kind of network, especially Asia. We noticed that Japan, Korea, Taiwan growing very fast, and they are different culture and different maybe health system. So I think that in the future, how to incorporate different culture or different health system into your so-called standards or definition should be still a long way to go. my opinion.
If I just take on a comment on that statement, I think where particularly the work in Taiwan was very strong is on developing these standards on environmental aspects and climate change. So that's a clear output reflecting your leadership in that area. And if you look at the current draft being circulated, these 8 standards addressing the environment and climate change have found their way almost completely into the new standard set. So I think that's an indication that from the perspective of the standard development, we have tried to be as inclusive as possible, and certainly not being biased by an overly focus on the Western health systems. At least that's what I hope. Again, any feedback is still possible until next week, and I'm sure we'll have very good discussions at the GA to develop the roadmap for further development. But what the discussion with other networks has also shown, and I've had the chance to talk to the Baltic networks and France, we do need to move forward. We do need to have the next iteration of this document, because we can't afford to have another year of discussing the scope of the standards without actually putting anything on paper as a network. And I think that's very important for the network globally.
If I may comment briefly, I certainly respect your comments that we have different cultures and we certainly have different systems and different accreditation systems, etc. But having been part of this network for 20 years, and also by listening to your presentations today, both of you from Taiwan, I do believe that we share the same values when it comes to health services. I share every word you said about the basic values and the need of patient-centeredness, the need of health literacy, environment, all of this. We have the same basic idea of what it's about. But then when it comes to implementing concretely in governments, because we listen to that may differ. But the important thing here is that we, and Oliver can complement, but this is not planned to be a benchmarking system. This is planned to be a self-evaluation standard aimed at giving possibilities for dialogues and reflections. And then we have different ways of putting that into our government systems for quality assurance, etc. But the basic values are, to me, very much the same. Will you comment, Oliver?
Yeah, I agree with you, Margareta. I think both the health system challenges are very similar, and the values are very similar. So I don't see a big gap there. And maybe if I just add the point that you raised about the accreditation, the way the standards are designed are normative statements on what should be done in line with the HPH strategy. Whether a network or a country decides to use that as part of an external assessment process, I think is foremost a decision of the network and not so much of the international network. The international network has to ensure that we do have these normative statements in place that reflect the overall vision of what HPH stands for. And I think that has been one of the discussion points in the past. And I certainly wouldn't exclude the possibility that some countries incorporate elements or the whole set into an external assessment mechanism, but it's not what they have been designed for at international level. Also because that's a point that is different between the countries. Some countries do have accreditation systems, others haven't. Others work more by professional self-regulation and not by formal accreditation. So if we were to present that as accreditation standards, we would probably be only reflecting on the needs of a handful of networks, really. But I think it's really inspiring to see the work that you've done in the last couple of years on the existing standard set and adding those domains that you felt of particular importance and lacking in those standards. And in my view, these elements that you did add because they were missing are now incorporated maybe not fully to the extent to which that you have developed your manuals, but certainly at the level of the dimension, addressing the environment, assessing the person, addressing climate, and all the other issues that we mentioned.
Okay. Yeah, ladies and gentlemen, although it leaves too much to be desired, but time is limited, so we have to adjourn this section. Yeah, thank you very much, and appreciate your attendance, and we want to thank you all the speakers again. Thank you very much. Yeah.
Put your hands together for Dr. Huang, Director General Wang, Dr. Lin, and thank you, Margareta, and also Oliver, for your time. Thank you so much. Thank you. Ladies and gentlemen, we'll take a break right now. Please come back before 3:40, before the final plenary session. Thank you again. 各位现场贵宾，接下来呢是我们中场休息的时间。那请各位贵宾呢在3点40分回到会场哦。那我们场外有这个茶点，那如果大家呢想要享用茶点的话，可以带进来享用，这样我们比较不会延误到我们等一下最后一个场次开始的时间。谢谢大家，谢谢。 Everybody, please take your seats right now. We'll begin in 1 minute. Thank you so much. 请各位贵宾现在就坐，我们最后一个场次要开始了，谢谢您。Welcome back, ladies and gentlemen. Very soon, we have come to the final plenary session of 2020 Global Health Forum in Taiwan. Our speakers are going to shed some light for us in terms of where we should really go, what adjustments to be made, and what action to be taken in the future. Ladies and gentlemen, for that, we'd like to firstly welcome our moderator for this very important session. Please join me in welcoming Dr. Hui-Jen Jenny Su, President of National Cheng Kung University, to the stage. 各位现场贵宾，让我们掌声欢迎我们最后大会场次的主持人，国立成功大学苏慧珍校长。校长有请。
Do I have it? Good.
Yes.
Okay. Thank you and welcome back. And with great privilege and pleasure, let me begin by saying that the gravity of this pandemic certainly has given us a renewed recognition to the interactions between the vulnerability of our health system and the preparedness of our society in terms of responding to the non-conventional scenarios laying in our future. From the way we generate our wealth, to the way we live, move, and eat, we must shift to a new paradigm that will continue to sustain the best we can our fundamental quest for health and well-being for all. So it is particularly meaningful for our last plenary session of this year's Taiwan Global Health Forum to entertain the very concern of post-COVID-19 and beyond, with 3 prominent speakers that will project their perspectives on what to expect for the future. For the very reason also, I cannot think of anyone more qualified than Professor Martin McKee from the London School of Hygiene and Tropical Medicine, who established the WHO Collaborating Center on European Center on Health of Societies in Transition, to speak on the topic of preparing for the next pandemic, health systems fit for the future. Ladies and gentlemen, please join me in welcoming Professor McKee.
Good afternoon, everyone. Thank you again for inviting me to talk to you in Taipei. Obviously, this year is very different, and I'm very sorry that I can't be with you in person. My annual trips to Taiwan are a highlight of the year, but obviously we have a very different set of circumstances now. And of course, that's what I'm going to be talking about over the next 25 minutes. I want to remind you that the current events were both predictable and predicted. Laurie Garrett and others have been warning us for many years that it was only a matter of time before we had another pandemic. They drew attention to the risk of zoonotic infections, infections coming from animals. Yet for all of this time, their warnings have tragically been ignored. Or should I say, ignored in many parts of the world. That's not the case in Taiwan, where you had a high level of preparedness, nor is it the case in some of your neighboring countries, but unfortunately, in much of the rest of the world, it is the case. We were simply not prepared. I want to remind you that as I'm talking to you today, we have over 37 million cases of COVID infection worldwide. We have over 1 million deaths. All of this in the course of less than 1 year. This is an absolute tragedy. Could we have predicted it? Well, last year, a group of researchers came together to develop a global health security index. They looked at the preparedness plans of different countries and they scored them. The top-ranking country was the United States. The second-ranking country was the United Kingdom. These countries should have been well prepared, but tragically they were not. In fact, these are two of the countries that have had some of the highest death rates, the highest infection rates anywhere in the world. What went wrong? I want to refresh our memories with a bit of basic mathematics. Infectious diseases in a susceptible population and without any preventative measures will grow exponentially. This means that the rate of growth will be faster the higher the number of cases. Now, often we overlook this because we plot the figures on a logarithmic scale, as I've done on the right here. What I've done in this example is to look at the impact on the growth of cases in three different scenarios. One, in the top line in gray, is if the reproduction number is 2. In other words, if every person who's infected then passes it on to 2 other people. The natural reproductive number for COVID seems to be about 2.5 to 3. If we can bring this down to 1.2, then the growth rate is dramatically smaller. It doesn't look so much smaller on the log scale. And if we can bring it down to below 1, I've used an example of 0.7, then ultimately the disease will die out, as happened with SARS. But when we look at this on a linear scale on the left-hand side, you can see that that difference between 1.2 and 2 is absolutely enormous. In fact, on this graph, the orange line representing 1.2 is almost on the at the bottom on the x-axis. Now, the message from all of this is that it is incredibly important to respond rapidly, as Taiwan did, but as many other countries unfortunately did not. We obviously need to respond by stopping the spread of the virus. We can do that, in theory, by isolating everyone from one another. But there are consequences. This is from a paper we published in the British Medical Journal at the very beginning of the pandemic. And it looks at the direct effect of infection, but it also looks at the consequences arising from, for example, isolation at home, restrictions on non-essential services, transport restrictions, and closures of educational facilities. What this means is that a comprehensive response must look not just at reducing the spread of the virus, but it must look at all of what we might call the collateral damage. The challenge is to make sure that you do both. So, to summarize, we need to stop the transmission. We could do that, but then we have to ask, at what price? Isolating everybody would have huge economic and health costs, job losses. It would mean abandoning people in need of care, and it would make it difficult to keep the country running, keeping the electricity system running, keeping the internet running. So what can we learn? We've tried to identify which countries did well and which countries didn't. This is a paper that we published in Nature Medicine a short while ago. We looked at excess all-cause mortality. The advantage of that is it overcomes some of the problems of coding of causes of death. It also takes account not only of those people who died directly from the infection, from viral pneumonia and the other complications of COVID, but also those who died from the policies that were put in place to curb the pandemic. Social isolation, which unfortunately for some people led to mental health problems and even suicides. Delayed access to health care whenever people needed it. So we can see from that that there is a big difference in how countries did. We had very high excess death rates, which is comparing what had happened during the pandemic with what would have been expected given the death rates over the preceding 5 years. We could see the high death rates in England and Wales, in Spain and Italy, Belgium, the Netherlands, but much lower death rates in Australia, the Czech Republic, Slovakia, New Zealand, Hungary, and Bulgaria. The key message from this is that some countries did worse than others, and many of these deaths could have been prevented if the countries doing worst had performed at the level of the best. So what explains all of this? Well, as you will have read from the abstract, we have a number of factors that we need to consider. And the first is political leadership. That is very clear, and particularly when we look at why it was that the countries that did so well in the Global Health Security Index did so badly when they were really tested. So let's look at the leaders of the countries that unfortunately have done the worst. These are the leaders of the countries that had the highest number of deaths by the end of June 2020. This is a reference to a paper where we looked at why that might be. You can see a number of similarities. They're all men, but they're also politicians who have pursued a nakedly populist agenda, who have challenged the science, who have challenged the public health authorities, who have believed that they knew better. On the other hand, when we look at countries that have done particularly well, we also see some similarities, but also some significant differences with these groups. So here we have one politician that you know very well, along with others from countries that have performed especially well during the COVID pandemic. And of course, you can see the difference again from the last slide. What I'm now going to do is to draw some lessons from a paper that we published in The Lancet recently, in which we looked at 4 countries in Europe and 5 in the Asia-Pacific region. We looked at the United Kingdom, Germany, Norway, and Spain in Europe. And in the Asia-Pacific region, we had Hong Kong, Japan, Singapore, New Zealand, and South Korea. I would refer you to the paper for more detail. But in summary, what did we find? Well, the first thing that came across as extremely important was establishing and maintaining trust. You cannot expect people to follow advice if they don't believe you. Another overall approach was to have a clearly and easily understood strategy. It's crucial that everybody knows what they're doing and why, and it's also important that data should flow seamlessly through the system. Then it's important to set out your goals and ensure that your policies reflect them. If people don't know what you're trying to achieve, then how can they help to do that? As we'll see, that wasn't always the case. I'm going to draw a number of examples from the country with which I'm most familiar and where I live, the United Kingdom, which has performed particularly badly, but also I'll look at a few examples from elsewhere as we go through. Trust is absolutely essential. At the beginning of the pandemic, there was a high level of trust in the British government. People were scared, they didn't know what to do. The chief medical officer and the chief scientific officer gave clear authoritative messages. However, this was seriously compromised. The Prime Minister's closest advisor was exposed to COVID, and then he drove 240 kilometers to stay with his family at a time when everyone else was told not to. He was seen at a local beauty spot on his wife's birthday, and he made the ludicrous claim that he made the 40-kilometer trip to check his eyesight before driving back. As you see in this picture, this was the subject of widespread satire. Frankly, people were completely unconvinced, and the polling data demonstrates very clearly that this rapidly eroded trust in the government in London. Fortunately, there was still a very high level of trust in the governments in Scotland and Wales and Northern Ireland. It was just Boris Johnson's trust that was lost. We need a strategy. Testing and tracing is complex. This picture is from a paper we published where we tried to make some sense of the challenges that are involved in developing testing and tracing systems. Essentially, it's a bit like playing a game of snakes and ladders. There are lots of obstacles to overcome and situations where you can fall right back to the beginning if you get it wrong, the snakes. But there are some things that can help, the ladders. And you win the battle to get a sound testing and tracing system by avoiding the snakes and climbing the ladder. Unfortunately, not everybody has done that. You also need to have somebody in charge. And this is where the United Kingdom has done particularly badly. Initially, the 4 parts of the United Kingdom, England, Scotland, Northern Ireland, and Wales, coordinated their responses. But over time, they diverged. And one of the reasons for this was a lack of confidence in Scotland, Wales, and Northern Ireland in what was happening in England. Frankly, people did not trust the Prime Minister, partly for the reasons I just said, but for many others. It wasn't helped when the Prime Minister, the Chief Medical Officer, and the Cabinet Secretary all became ill with COVID at the same time. And this was in a government that had imposed an unprecedented degree of control from the Prime Minister's office. So essentially, this was a government that was sailing blind. It was like sailing through the sea without a rudder. It was essentially out of control. And as one of the newspapers said, it's chaos. That was very problematic at a critical time. It was also problematic because this was a time when the British government was struggling to work out how to leave the European Union and was effectively paralysed even before the crisis. Another problem was a failure to take a whole systems approach. We argued that it was necessary to have a coordinated system to find cases, to test people, to trace their contacts, to isolate them and support them. However, what was put in place was anything but coordinated. There was no coherent system for finding cases. Eventually, they put together some testing in hospitals and long-term care homes, but other groups at risk, like taxi drivers, were essentially ignored. There were 5 different pillars for testing, with none communicating with one another. There were multiple contract tracing systems. The government established a centralized system which never worked. And in response, local governments and some employers put together their own systems, none of which communicated with each other. People were asked to isolate, but they were given no support to do so, and there was no monitoring. They had to get any support they could find from friends or families or charities or others. So no overall strategy, no systems approach. There was fragmentation. There was no communication between any of those involved. And there were attempts to increase testing, but that fell through because of problems with getting reagents, with getting the laboratories up and running. They made no use of the existing facilities. The whole thing really was a dreadful mess. The messaging began by being good. At the beginning, people were told to stay home, to protect the NHS, and to save lives. The government's main concern was that the health service would be overwhelmed. People had seen the images from Italy. Stay home is a clear message, to save lives. But then the government wanted to open up the economy. It wanted people to go back to the shops, back to the restaurants and the bars. So it changed that to stay alert. People said, stay alert when we can't see the virus, when we don't know who's infected. How can we stay alert with an invisible virus? And people just got confused. And remember, by this time, they had lost trust in the government. It is absolutely crucial, from what we have seen in all of our research, that you have knowledge of the pandemic. Ideally, you have a near real-time data system collecting test data by age, by location, what part of the country, and by sector. We need to know the number of cases among healthcare workers, care workers, other frontline workers, workers in food processing plants, and others that are known to be at high risk. We need mortality data, and this may mean a separate system, recognizing that the vital registration system that we normally use takes time, particularly where there are legal questions over the cause of death. And we desperately need all data to be linked to measures of inequality among individuals, knowing if people are rich or poor, whether they are highly educated or poorly educated, what type of jobs they're in. And we need to know the differences between geographical areas and between different sectors. Crucially, the data should be published in a format that allows analysis not just by government statisticians, but by researchers, by civil society organizations, and by others. You need scientific advice. The British government has a scientific advisory group on emergencies. It has a variable membership. People are brought together depending on the threat. So it will be different if there is a pandemic compared to what there would be if there was, for example, a chemical weapons attack, as we had on 2 Russian exiles in England a few years ago. The membership of this group is confidential and their evidence to government is not published. This was undermining trust. So a group of us, myself and other colleagues, came together to form an independent scientific advisory group on emergencies, INDI SAGE as we called it. Our chair is a former government chief scientific advisor. We have a mix of disciplines and expertise, much broader disciplinary mix than the official group, and we hold all of our meetings in public. In response to our creation, the government did publish the names of the advisors and also the evidence they were given. In fact, the 2 groups almost always agree. The big difference is that our group can decide what questions to answer. We're not limited by the questions that the government asks. A crucial element in success is community engagement. We need to bring people with us. We cannot ask people to do things that it's impossible for them to do. One of the problems with the government's advice in the UK was that they sent out instructions to schools and universities and others that were simply unfeasible, or they left people with more questions than answers. Now, in health systems research, we talk about this as co-production or co-creation. This is where we design interventions working with the people who are affected. We recently published a cluster randomized controlled trial of hypertension management in Malaysia and Colombia. We spent a year developing the interventions. They were broadly similar in each country, but they were tailored to the different circumstances. So if you work with people, you can develop safe policies, for example, for physical distancing and mask wearing that are appropriate to the different circumstances. You can put in workable measures for schools and workplaces. The process of doing this generates trust. And also, we can try to identify who the particularly vulnerable groups are, such as minority ethnic populations living in homes where there are multiple generations, or who are in the informal economy. And we can tailor our support for them, the socioeconomic support in particular. So, for example, we might be looking at particular forms of retraining. We might be looking at developing community networks or something else. We need public health capacity. It is absolutely essential to have strong public health teams at local level. The countries that have done well have engaged in backwards contact tracing to identify and address the sources of outbreaks. Many countries that have done poorly have engaged in what we call forward contact tracing. This is where you identify cases and you ask them to isolate and their immediate contacts to isolate. This may stop things going forward in the future, may break onward transmission, but it does nothing to tell you about where the problems are in the first place. It doesn't tell you if you're having a lot of super spreading events, for example, in places of religion or in hospitality venues like bars or restaurants or in universities. You're flying blind once again. It is essential to have a well-resourced laboratory network, and that means a good transport system to get samples to the laboratory, good logistical systems to make sure you have reagents and supplies, and good data systems to make sure you can communicate the results. You need national leadership of the public health program to coordinate and develop standards and procedures, to undertake the sophisticated modeling that is needed to track the pandemic and to test out ideas about policies. And you need strong research capacity. I've been very critical of the United Kingdom, but there is one area that it has done very well. It has been extremely successful in ensuring that as many COVID-19 patients as possible are entered into clinical trials. It demonstrated the benefits of dexamethasone, a low-cost, routinely available drug. They showed that it was able to reduce death by up to 1/3 in hospitalized patients with severe respiratory complications of COVID. It was the first study to demonstrate that hydroxychloroquine had no benefit. Unfortunately, in far too many countries, we don't know what would work because patients have not been entered into clinical trials the way they should have been. We need health system capacity. We need to recognize that COVID-19 is a complex multi-system disease. We need to get different specialties to work together. We need to be able to ensure that health facilities are able to expand in response to a surge of cases. That may mean including new facilities, building new facilities if needed, as happened in China and in a number of other countries. We need to ensure that staff can adapt to new roles when needed, and that may mean overcoming professional barriers. It may mean challenging views about what nurses and pharmacists can do. They can do much more than we often allow them to. And it means establishing open, transparent procurement systems. Unfortunately, in many countries, including the United Kingdom, we have seen corruption on a large scale in the emergency procurement of the laboratory equipment, protective equipment, and so on. This is an example of expanding capacity in England, the so-called Nightingale hospitals, named after Florence Nightingale. These were created in an exhibition centre. Fortunately, they have not been required so far, but tragically, cases are going up again. So in summary, what do we need to do? We need to build trust. Politicians need to be trusted. And once they lose it, it's very difficult to regain it. Senior public health officials need to be trusted. We all need to listen to those in the front line. We need to be sure that the measures we're putting in place can actually be acted on. We need a plan that is logical, that relates to what we're trying to achieve, and is fully interconnected, and which is communicated to people. We need to invest in public health. We should have done this a long time ago. Countries in Asia that were exposed to SARS and MERS did this. Many other countries allowed their public health systems to run down. We need to take a whole systems approach, and we need to monitor and evaluate. We need to integrate research with what we're doing. We need to evaluate the non-pharmaceutical interventions that we're putting in place. We need to track the progress of the pandemic, and ultimately we need to make sure that everything is driven by the science. I want to close by referring you to our COVID-19 Health Systems Response Monitor, something that we've developed in the European Observatory. It has data from mainly European countries, and it will allow you to look at what different countries are doing with in response to different aspects of the pandemic. And with that, I'd like to say thank you very much indeed. I'm sorry I can't be with you. I hope to be with you in future years. Goodbye.
I'm sure it's clear to you all that Dr. McKee cannot join us online real-time today due to some important family matters. But the organizer wishes to thank him for all the support in connecting, stay connecting with the forum in the past and for the time to come. On the other hand, our second talk will be kindly delivered by Professor Ilona Kibush, I'm sure. To deliver, is it all connected now? You sure? Is there? What's that? She's online. Great. Thank you. Who is the chair of International Advisory Board of the Global Health Center at the Graduate Institute of International and Development Studies, Geneva, Switzerland. Professor Kibush is no stranger to many of us, has an eminent career in global health governance and international health diplomacy. And for that, I wish to keep all the time for her, and thank you. Thank you so much in making your presence in this forum. We very much look forward to your insightful information. Thank you. What's that?
Thank you very much. I'm delighted to be with you, and just as Martin said, I would have loved to be there in person. It's always such a great experience hearing of all the great progress that is made in Taiwan in relation not only to health services, the health system, but also the whole health promotion system. And of course, now we have also learned what the world can learn from Taiwan and a group of other Asian countries in how to deal with COVID-19. You've seen the figures from Martin, how the situation has gone worse in the last couple of weeks in Europe. And this also is an example that we have not learned lessons, and it is one of the issues I will come back to in my presentation. Martin has focused on the national actions that need to be taken. I want to share with you some larger scale global governance issues that we need to think about. And I will move to my PowerPoints. Just 1 minute. Here, you have asked me to speak about the governing global health, what needs to change. And it's very clear that a lot needs to change, and we have change movements all over the world. And one of the important things, I believe, as we discuss all the issues around COVID-19, is that it's not the only area that needs to change. We have a whole range of larger political, environmental, economic issues at stake. And one of the key issues is the one I would like to quote here, a leading economist, Mariana Mazzucato, who said, or asked the question, will we continue to fly blind, or will we accept that our societies must share both the risks and rewards of wealth and value creation and directing economic growth so that all citizens benefit? So our first lesson at the global level, I believe, is that we need to be very aware that we are looking at a pattern of risk. The nature and the scale of risks has changed. And you will know that a whole group of scientists is saying that we actually live in a new era that is called the Anthropocene. This Anthropocene is actually defined by the accumulation of risks, and I've listed some of them here: pandemic, what we are living through; ecological, what we are living through; financial, as you know, since 2008, many people are still suffering; the social inequalities, the terrorist challenges, and in particular now also the challenges through the infodemic. And all of these are connected to each other and feed off each other. And I actually use these two pictures because I thought it was quite extraordinary. On the top, of course, you see the coronavirus. On the bottom, you see a picture that uses the development of urbanization to exemplify the pressure on our world. And you can see the close similarity between these two pictures. We are realizing that all these risks are global, that we cannot exit from this risk. And also in global health and global health governance, we've developed a range of concepts that aim to help us explain this. The very important One Health concept, the planetary health approach, and more recently from Richard Horton, the editor of The Lancet, the challenge to actually look at the pandemic as a syndemic because of all these risks that come together. One of the things we must do, and you've heard from Martin about, the many predictive preparedness measures we must take. I believe that at the level of the United Nations, and remember today we celebrate 75 years of the United Nations, is that we need multi-hazard early warning systems. We need early warning systems that show us the interdependence of these risks and allow us to act. The second lesson is about the interface of risk and power. We do have a tendency in global health and global health governance to avoid questions of power, to avoid questions of politics. We very frequently are afraid of a politicization of issues, but we have seen that with this virus, many of the issues that we have otherwise not discussed have come to the fore. We've talked a lot about evidence-based policies or evidence-informed policies, but we have seen that that system in many countries has broken down, that the interface between science and political decision makers has not worked as well as it should, and Martin gave us one such example. So in being prepared, we need to be better aware of how we want to organize in future that relationship between science and politics. And in health, of course, we are not only talking about the medical sciences, about virology, epidemiology, and all of that. We are talking of the behavioral sciences. We need to understand why people act as they do. We need to include psychologists. We need to understand the impact lockdowns have on people. We need to understand the political decision making, so we need to include political scientists. So we need to work before a pandemic on the interface between science and politics. And of course here too we need to work with others, because if you think about the interface of science and politics in the environmental area, in the climate change area, we see that many of them are similar to what we are experiencing in the pandemic right now. And we even see that initiatives to discredit science around the pandemic are being financed by exactly the same people who are financing the discrediting of climate change science. So you can see even in this area, there is an interfacing of the risks. We need to understand much better the role of democratic processes in times of emergency rule. And here, particularly the Western democracies were not really prepared for that interface. You know, I live in Switzerland. Actually, Parliament closed down for a while. In Germany, there is a push to have Parliament more involved in emergency decisions. So we do need to have a very intensive debate also about the rights of individual citizens and citizens as groups. And that, of course, relates to the third point, that we need to work before on the level of trust in our societies. We have just published a compilation of articles on the interface between democracy and health in the British Medical Journal. Some of you might want to look at that. And what we're saying is actually we need to make our societies, our democracies, pandemic proof. We need to have a high level of democratic debate, of interchange, that then also engenders trust in a period of emergency. But of course, the really major challenge is that the fundamental disparities within a society or at the global level are one of the strongest political dimensions, one of the strongest power dimensions we need to look at. Now, frequently, you know, people from health will be saying viruses do not discriminate. For a political scientist, they do discriminate. They feed on the political, economic, and social flaws in our societies. And so they take on the features of those societies. And as we analyze responses, that political dimension will be critical. The third lesson is we cannot afford magical thinking. This is a term that Helen Branswell created, and I think it's very important. You see at the back something that Martin already mentioned, the Global Health Security Index score. And we saw that countries that featured very high on that score did not do very well. Actually, if you look at the Netherlands right now, the infection rates have soared up as well. Australia has suffered very much in specific cities, for example. And we saw that some of the countries that are further down on the list actually did very well. But the magical thinking, as Helen understood it, was that particularly the democracies of the West in Europe and elsewhere thought that they were immune to this virus. They had the magical thinking it would not come to us because all these other awful viruses stayed in Asia, stayed in Africa. We are safe. And we need to move away from that magical thinking, and we need to also move into a thinking of solidarity that, of course, no one is safe until everyone is safe. So we have to deal with the failures. We have to deal with the fact that the first call in the international arena, particularly of the Western countries, was to save ourselves, to have, for example, America first, to start destroying multilateral bodies that stand for solidarity. We saw that some of the global instruments and institutions did not function anymore. The G20 did not function. The UN Security Council did not function again and again because certain countries did not want to reach a common approach. We saw that the international health regulations were not sufficient. The World Health Organization did not have enough financing for its initiatives. And we saw, and this is really important for the next steps, we saw that the multilateral trading system is playing an ever more important role in pandemic preparedness and response. Think of all the major supply chains on the one hand, but on the other hand, think about the necessity to deal with intellectual property and with the implications of the Doha Declaration that we need to address as we're confronted with vaccine nationalism. So actually, we also see in the multilateral system that we need to define very clearly a set of global commons in global health. This discussion of health as a global public good has always surfaced but disappeared again. This time, particularly around COVID responses, vaccines, therapeutics, and diagnostics, we need to reach an agreement of global commons. We need to counteract vaccine nationalism. We need to counteract the ability of major companies to make tremendous profits from a pandemic. And that is why the support of an approach around a people's vaccine is absolutely essential. And that is why the new developments we have to look at common goods, at global public goods, is absolutely critical. We have some new initiatives, you've heard about it, the COVAX initiative that 180 countries have now joined. We need to have a different financial approach, and development banks are playing an incredibly important role. We need to look at debt service, we need to look at relief packages, we need to revise some of the international agreements that we have. We do have a positive push to actually address these things. There are new bodies that are analyzing WHO, that are analyzing the international health regulations. We have better scientific collaboration, and we have a move, as we say, of middle powers to counteract the attack on the multilateral system by the United States. And we see that regional organizations like the European Union and the African Union are trying to move the global health agenda forward and support the United Nations and WHO. And again, if you think at the interface of risks, COVAX, said Seth Berkley, who heads the Global Vaccine Alliance, he said this is the biggest multilateral effort since the Paris Climate Agreement. And if you look at these two maps and you see who is part of the climate agreement and who is or who is not part of the climate agreement and who is not part of COVAX, that gives you an indication how important it is that countries really come together to address these common problems jointly. And we will see if after the 3rd of November in the United States, we are actually able to really work as a global community and develop key common goods in climate, in finance, and in health at a minimum. Lesson 5 is many people speak about build back better. I actually like to speak about building forward, and that if we accept that our world is confronted with this interaction of risks, we also need to think about an economic and social development model that takes that into account. This, what you see here, is the famous donut model that has been developed by Kate Renworth. And I believe that many organizations, many countries should be looking at these models. Also in the European Union, you might have heard that Finland during its presidency said, we need a new economic model. We need what Finland has called a well-being economy. That means we need to highlight other indicators than just the usual financial indicators for having better societies. These circular thinking relates very much also to the thinking we have developed around the SDGs, and you can see that symbol here. But what you see in the background is that there are actually entities that are starting to reorganize around the donut model. And this is the city of Amsterdam. The city of Amsterdam is reorganizing the way it takes decisions in the city on economy, on housing, on welfare in relation to the donut model. And I believe that is the kind of thinking we will need to move forward in the global sphere. We will need to take that into development organizations, into the World Bank, into the International Monetary Fund, and the many development funds. If we think to the past, many of these funds actually forced countries to reduce their spending on health and environmental safety. We need to change that move. We need to change that move because we have to counteract the blowback that we have. There is an enormous amount of people who are now falling into poverty because of the COVID-19 measures in rich countries and in poor countries. You can see that 40 million Americans have filed for unemployment. At the same time, the wealth of the richest Americans increased in just an extraordinary manner. And this is crazy to look at. If we are desperate to find the 35 billion for COVAX to vaccinate the whole, the key number of people around the world against this virus, and we have this kind of inequality and wealth creation that is going on. My 6th lesson relates back to these politics. We must learn to see that the greatest risk lies not with the virus, because we will get more such viruses. The greatest risk lies with the lack of preparedness, with nationalism, in this case vaccine nationalism, and the unwillingness to cooperate. That is why we must take every single measure possible to cooperate. And this, of course, also relates to the situation of Taiwan in relation to the global international UN system. and there must be every opportunity for Taiwan to also cooperate within and with this system. Lesson 7 is we need transformation. We need the transformation that protects and reforms multilateralism, and we need a way to also protect our democratic way of life. We must not be tempted to say that, oh, if our societies were more authoritarian, then we could deal with pandemics better. We have seen that many of the authoritarian societies do not do that. And we need to also develop, as part of this transformation, a sense of mutual responsibility, that we are responsible for one another and for the planet. So it means that global health diplomacy is becoming very, very important. We need to create new systems of global cooperation. We need to fight vaccine nationalism, as I've said. We need to revise the international health regulations. We need to ensure that WHO is properly financed, that it has greater independence and authority, that its funding model is changed so that we can really work together in new ways in global health. I think global health diplomacy must prioritize the reform of WHO to make it a truly independent and authoritative organization. In the context of that, we also need to really deal with one new issue that we have not tackled enough in the past. That is what WHO has called the infodemic. We will need to have new forms, not only of health literacy and digital literacy, we need to have new forms of civil literacy, how we deal with each other and how we can identify reliable and scientifically based information. And if I can end with this, if anything, we need to apply a new form of diplomacy in order to be able to deal with the really big geopolitical challenges that we are facing: technological competition, environmental dangers, the economic shifts, the breakdown of institutions and alliances, the domestic political pressures, and the need to really have a new mindset, a new multipolar and multi-conceptual mindset that brings the whole world together, that decolonizes global health and global institutions, has a strong voice for the global south, and where finally the global north or the global west is willing to learn from others. Thank you very much. Thank you.
Well, Professor Kibush, I do wish that you have heard the big applause from here, from the audience here. But anyway, we have had Professor McKee to give us some detailed accounts, mostly from the UK experiences. We then follow by Professor Kibush, a detailed illustration from a more global, multifaceted analytics in the framework of 7 lessons learned. But how likely is it for us to really build and establish a pandemic-proof society in the time to come? We will invite our third speaker, our very own Professor Kung-Yee, Liang Yuanzhang, formerly the president of National Yang-Ming University, the very first medical university in Taiwan, and is currently now the president of National Health Research Institute. Professor Liang.
Okay, many thanks to President Su for your kind introduction. I'm honored to be part of this section which discuss an issue drawn a great deal of attention for everyone in the world. Before I touch the three topics, let me just, maybe we should time to remind ourselves the current situation in terms of the impact of COVID-19. As of 5 days ago, the number of the cases have really risen to more than 41 million, and the number of deaths exceeds 1 million people. And if you look at the figure on the right, and there's no sign that the things are slowing down. It shows the number of daily cases and also the number of deaths. So first issue I'd like to talk about is the how to embracing the past COVID-19. Let's be optimistic that things will become normal to the extent possible. How are we facing the new normal? But before we do so, I think that we should talk about the impact of COVID-19 on healthcare. Taking cancer as an example, and the report shows that the pandemic has hindered the surgery and the testing on the biopsy tissue. And for oncologists, many oncologists are expecting a wave of more advanced cancers diagnosed due to the delayed biopsies and the postponed preventive screening. And also the healthcare provider have tried to ensure the safe environment possible for patients by adjusting how they operate, which in a way will delay the process as well. Meanwhile, I think one issue, can you hear me in the back? Okay. That hasn't drawn as much attention, which I think is equally important, is the issue of mental health. In the UK, the Office for National Statistics has shown that almost half of the adults consider that their well-being has been affected by the pandemic. Nearly 2/3 said that they are feeling stressed or anxious. And 1/3 said the pandemic has made their mental health worse. And also the Times warned that the tsunami may be coming, and there's more than 1,300 psychiatrists back in early May, and it said that the 40% of them said that they have seen issues, an increase in the urgent referral to see people with severe mental health problems as well. In the meantime, for the young people, the issue how to provide support, I think that need to be addressed as well. So, with that, I think that on the other hand, I think it's good to have something positive to share with. I think that we're also seeing that in Taiwan, the decreasing influenza activity in Taiwan because of the common practice, the frequency of hand washing and wearing a mask. Also, the EV71, the number of cases has going down as well compared to the previous 4 years. So the issue about the new normal, the post COVID-19, I think that following the COVID-19 pandemic crisis, I think we're facing the so-called new normal. First, I think it's worth to remind ourselves that the fight against COVID-19 is far from over. Until there's an effective vaccine and a treatment, everyone remains at risk. And meanwhile, we should continue to practice protective measures such as social distance, wearing facial mask, and frequent hand washings. Someone from public health, I think that this is what I call public health in action. Talking about the hand washing, the impact of the hand washing, our colleagues at NHI has shown using the Google Trend to conduct the ecological study, which shows that there's an inverse relationship between the number of new cases in log scale and the number of days wash hands. Okay. And meanwhile, I think that so I think it's important. It's fair to say that the normal is changing. And because uncertainty and managing risk are the reality of the foreseeable future. We're talking about health. But I think that something that hasn't drawn much attention is about the educational systems. The infrastructure may be changed, teaching methods, but also the skill to generate the social interactions, especially for the elementary kids, that I think need to be addressed. And from the economic and the societal point of view, because of the COVID-19, I think that the employment rates has gone up, and the report of child abuse, suicides also increased as well, as reported in this month, The Economist. So this is the new normal we're facing. That means we probably need to rethink what the current infrastructure, not from the health, but also from the economical and educational as well. The second topic I want to talk about is in preparing for the new waves or new pandemic. What can we learn from this episode strategically? So I want to say something about the experience and challenge in Taiwan. Some humble experience. I think that the past experience, especially during the SARS in 2003, has helped us a great deal. Because of that, I think that in the last almost 20 years, the infrastructure reorganization has taken place. So, for example, we have the negative pressure at the isolation ward put in place, and we activate sufficient and instantaneously across the island. And we have effective new laws and the regulations, which permits the vertical communication between central and the local governments. And of course, because the experience we've gone through in the past, SARS, pandemic, influenza, and the public health practice is more in place. Also, you've seen from our first speaker, the photo of President Tsai, who actually shown her leadership by trusting the experts, and also that the issue about transparency. And our Minister Chen of Health Welfare, and from day one, he has held the press conference explaining the current situation. So such transparency really had earned the trust from the citizen, which actually embrace any instruction that we may have. And our second speaker mentioned about the interface between science and politics. So if the time permit, maybe in the general discussion, I can share some of the experience in Taiwan as well. Back in August, the Minister of Health from the United States visited Taiwan, and one question he asked is, if just give one term that might explain the current success of Taiwan's situation. And the unanimous answer from our official is that the tight border control policy. And I think this is probably too small to read, but let me just say that we have 3 different criteria. Depends on the contact with the confirmed cases, travel to the endemic areas, so on and so forth. We're 3 different interventions: 14 days, home isolation, or quarantines, or self-health examinations. And for each situation, there's a very, I think that well-explained SOP, including the responsible official, and the restrictions, health check, and what if symptoms appear, what should be followed. So with this, I think that that really had led to the current situation with a very limited number of the new cases. Here's a study done by my colleagues at NHI. Through mathematical modeling, they consider 5 different situations. It's from the 0, 40, 60, 80 to 100% in terms of assuming there's a 40% subclinical cases after testing. And so this is the percentage of those cases were isolated. And you can, under different situation, you can see the outbreak control is the best when you have total isolation. And this slide just shows that through the collaborative effort across the agents in the central government, I think that the innovative technology and that facilitate case identification, epidemiological investigation, and quarantine in Taiwan has been taking place. Okay. Now, in terms of a challenge, given what we have, I think still more work can be done in terms of establishing precision control measures in decision-making system. For example, that how can we integrate the national health insurance data, CDC database, and others, okay, which will lead to speed up the decision-making in terms of COVID-19 controls. Okay. Also, that addressing the issue of a potential breakdown of the healthcare workers and the issue about the mental health crisis for the citizens, I think we have better system to actually alert the government and the individual as well. Also, that how to take the advantage of the digital surveillance and in terms of to have a better social distance control, things like that. This can be done, and it should be done, and actually it's currently being in place as well. But I think important, regardless the type of control, I think it's important to keep in mind is that regardless of the socioeconomic status, I think everyone should have the same chance to be benefit from such arrangement. The last topic I want to talk about is the precision health ecosystem establishment, which then seem to similarly have to do with the current topic. But I want to argue that the notion of precision health is the trend for the future. And it's a little bit unfortunate because of the COVID-19, the progress being made has been slowed down. So I think it's time for us to draw its attention and also talk about how our procedure may be modified because of the COVID-19. So let me say a few words about this, the precision health of all ages. It's a relatively new concept, born out of precision medicine initiated 2010, for example, 2012 of England, and 2015 launched by President Obama about precision medicine initiatives. And it really expand the spectrum from empowerment, prevention, diagnosis, treatment to long-term care, and really embracing the idea of public-private partnership, so-called PPP, and taking advantage of big data and available high technology, including AI, machine learning, etc., and mean to reaching out to citizens of all ages. If I can elaborate a little bit more, really reimagine medicine to focus on prediction, prevention, and curing disease precisely, and representing a fundamental shift to more proactive and personalized care that empower people to lead healthy lives, and taking into account difference in people's gene, environments, and lifestyle, and forming treatment and prevention strategy based on patient's unique background. In other words, hoping we can provide the right treatment to the right patient at the right time. On the prevention point of view, provide the right intervention to the right population at the right time. If I show that in diagram, and this is, we're talking about all ages from children, adults, elderly, and we're dealing with a situation starting healthy becomes sub-healthy to become disease. And so what we're talking about, the utility of the digital system technology, and also different places, different field to actually provide a more precise prevention, diagnosis, treatment, and care. Imaging data, so on and so forth. And this pretty much in place, but the different situations, so the question how we integrate them together, provide a so-called big data set, which is one of the main challenges. And Taiwan is in place to do so because we have pretty good AI system that actually has been built in the last 5-10 years. So last year, I think that initiated by the Board of Science Technology, the Executive Yuan, in accordance with the recommendation made by the Bio-Taiwan Committee in 2009, and the National Precision Health Program was initiated. It's the collaboration among 3 governmental departments in science, technology, economic affairs, and health and welfare. And it cut across basic public health and clinical research with regulatory cooperation from TFDA and active involvement from the industry. If I can show here that this actually, from the administration of the health welfare point of view, really we have a huge variety data set that could be put in place. And we can target, we can utilize the biobank consortium, we'll say in a second, to focus on originally on cancer. But now with the COVID-19, I think we're going to include the emerging infectious disease as well for precision health. And National Biobank Consortium was started last year. Again, the idea is to bring more 30 biobanks in Taiwan all together with the unified clinical format and tissue data in virtual, which hopefully will be provided for academic and also industry as well. So there are two major components, as I mentioned, is the big health data integrations, using the AI and such as the natural language processing. And also there's one precision medicine initiative. Basically, said in words, is we're going to hopefully, with the effort through the biobank, we're going to identify hopefully the 6 to 10,000 cancer patients. We're going to provide a genetic profiling, and cooperating with the industry, we can answer a variety of questions, such as with the target therapy, we have whether this new target therapy is effective. Can the approval process be speed up through the notion of a real-world data, real-world evidence concept. So this is kind of our new program in a nutshell. I just want to say one word. I think that now with the COVID-19, we really, I think that's, we are alert that, for example, research estimate that more than 20% of all medical visits will be conducted given the telemedicine in 2020, and up to 72% could be visualized by 2023. So that means we really need to employ more intelligent-based health system to deal with a situation which is unprecedented. So in summary, I believe that the new normal is becoming a reality. This maybe to some people displeasure. I think that the hand washing frequency and the keeping social distance, wearing a mask when the social distance cannot be kept, will become part of our life. And I believe the fight against COVID-19 is far from over. But preparing for the new pandemics by learning from the past is equally important, and which I share some experience today in Taiwan. And also believe that once the impact of COVID-19 begins to minimize and activity settle into a so-called new normal, and the efforts to expand precision health across many diseases will resume. Thank you very much.
Professor Liang, would you please remain on the stage and join us for the panel discussion? And also, we'd like to welcome our moderator, Professor Su, again back to the stage. Please join us on the stage for the panel discussion. And also online, we have Professor Kickbush. 接下来呢，就是我们这个场次的综合论坛，我们把时间交给校长。
Okay. Is it on? Okay, thank you, and thank you, Professor Kip, still there. So for your information, thanks to the wonderful and very considerate time control by our three speakers, we now have a very comfortable 20-some minutes for the discussion. And so the floor is open. I have the agreement from Professor Liang. Maybe we will leave this opportunity for our audience first. Any of you would like to be the first to raise either questions, comments, inquiries, either for Professor Kibush or Professor Liang here? Anyone? Okay, if not, I'm gonna give this opportunity for Professor Liang to complete. You thought about, you mentioned there may be a couple lines you like to address in responding to Professor Kibush's comment about the connection between political science, political comments, political environment or situation with the science. So with that, then we will have Professor Kibush to come back for you to respond to that.
Okay. I think that my colleague and I actually have been involved in this fight against the COVID-19 in the last few months. I think a lot of thoughts come up to us, new to us, but also make us think a little bit harder, something that we never thought about before. One of the issues is Dr. Kickbush mentioned about the interface between science and politics. And it's not a new issue, but this COVID-19 actually makes it more critical, more crucial. And I just want to share with you some of the things that we have done in Taiwan. The Minister Chen of Health and Welfare is also the so-called leading the national NHCC, National Health Control Centers. And back in the February, in the center, there's about 10 different divisions. And the newest one that he created is research and development, which I had. So we have a weekly meeting. We bring scholars, but also the governmental officials from 3 different agencies, including the science, technology, economic affairs, and health and welfare. And we have weekly meeting, and there's 5 different divisions, including rapid testing, vaccinations, medicine, the epidemiology forecasting, and also a platform providing the resource for research, such as the testing, the preclinical and clinical testing of the effectiveness of the rapid testing kit. And we have, so a weekly meeting, we have each division to report, to review current situation and the development and worldwide, not just Taiwan, worldwide, and including treatments and vaccine. And with that, we, when necessary, I will report back to to Mr. Chen for any recommendation we might come up with. One example is that we're talking about development of rapid testing. So in case is things getting worse, so we're going to have more comprehensive rapid testing. How can be done? How should be done? Where should be done? Things like that. So we have created an expertise group through discussion, will make recommendation to to Mr. Chen. And the discussion is very much scientifically based. So that's just one example suggesting that it's critical in this stage when Minister and the National Health Control Center when they're making decision to the extent possible should be a scientific basis. And that our group is in the position to provide those recommendations. So it's just one example we want to share with Dr. Kickbush and the audience as well.
Dr. Kickbush, you have a quick comments or your observation from other side of the world? I think hers is muted. Okay, it's back.
Okay.
It's on.
All
yes.
right, it's unmuted. Okay. Thank you very much for that. And I listened with great interest because some elements of what you described are similar to what's been happening in Germany. You know that Chancellor Merkel herself is a physicist and is very committed to science. She has, from the start, involved scientists in the process, also most recently at one of the crisis meetings with all the decentralized premiers, which is turning out to be actually one of our major problems in Germany, the decentralization of health. But the ministers actually had to sit there, the premiers, and listen to her chief scientific advisor trying to outline to them what the evidence base was at that very point in time. Sadly, not everyone acted on it. I think what I was trying to say is that as was said by the professor, that we have been, at least in some countries, quite creative about how to involve science and scientists, and have moved also slowly to a more interdisciplinary approach, as you have also indicated. What I was also trying to say, let's gather those experiences and in the pandemic plans of countries and in the risk preparedness plans to make sure that we actually have a system in place that we can call upon straight away, that we don't need to reinvent it. And of course, to ensure that interdisciplinarity so that, you know, if it's an environmental risk, we ensure that the health people are part of those scientific panels, etc. So I think it's really a very, very important thing and a new dimension of what we've been discussing so long as evidence-based health policies, because in situations of crises, dealing with evidence gets to have quite a different dimension than if you have months or even years to digest certain evidence and respond to it. So I've been very, very interested what Professor Liang has said. And then, of course, if you have an integrated system like the precision health ecosystem that he has described, you also, you know, have an organizational system that to some extent interfaces with those scientific dimensions as well. And so, you know, it's both a question of the scientific advisory bodies, but also how science-driven is your overall health and public health system. And if you've established that culture of science-driven, if I can call it that, then I think on the whole, your system will be more pandemic-proof. Thank you.
Yes, I think we've been always proud of that quote-unquote science-driven culture here that is well transmitted and transplanted in the way we curate or orchestrate our policy. And hopefully in the future, we have a better way and more effective way in contributing those experiences and culture to other parts of the world with your input and support. Anyone from the audience or online, can our colleagues support whether you have identified inquiries from online or in here on the venue side? Okay, otherwise I'm going to take advantage of raising one if Professor Kibush will kindly respond some as well. One of this, you quote transformation as one of the lessons you addressed just now in your talk. And I remember in the recent report UN related in the overall sort of landscape analysis as to how the global society will be responding or how global society is impacted by the COVID and in the framework or in the structure of SDG goals. And with that, they have highlighted a few transformation, different type of transformation. And the survey tried to capture how different countries or regions of different economic or socioeconomic status or power is responding to those transformations. What is very intriguing to me is one of this particular digital transmission is almost positively appreciated and responded in this survey. And I was wondering, in your observation so far, how this particular type of technology advantage and support or transformation will be better facilitating our battle now with not this current pandemic, but the future pandemic, or even to support building a pandemic-proof society, as you mentioned, across the world, not just for a specific sector or specific sort of a cluster of countries who is more qualified or capable of doing that. Share some of your wisdom with us.
Well, thank you for that question. You might know that at present we are engaged in running a Lancet Commission on governing health futures growing up in a digital world. together with my co-chair, Anurag Agarwal from India. And we have many distinguished colleagues helping us look at the digital transformation. I mean, one of the things we do see, of course, is how uneven it is. First of all, how particularly many European countries are totally lagging behind in relation to digitalization of the health system. And of course, you cannot have an evidence and data-driven health system, particularly with access to, let me say, real live, in a way, health data, without a very, very high level of digitalization. Of course, at the same time, and I think there's a difference maybe to your society, there is a much higher skepticism within the population towards digital means. And it's very ambiguous and controversial because on the one hand, you know, people use the internet all the time. They shop and they exchange social media. But the minute, you know, in quotes, the state comes in and says, you know, would you please download a Corona app? People become very restrained, and there is great fear about, you know, citizens' freedom and surveillance, and, you know, there is a lot of fear also in some European quarters about what we call surveillance capitalism. And the question is, you know, who are you more afraid of, the state or the big tech companies? So I would say there are three levels on which we need to catch up. I mean, first of all, globally, because the Sustainable Development Goals did not take the digital transformation into account. There's practically nothing about digital transformation in the Sustainable Development Goals. Actually, there are some voices who said we should rework the Sustainable Development Goals because they do not include this major transformation, which affects every single one of the SDGs. There's no question about it. So, you know, that's the one thing. The other thing is, of course, that we need to address the digitalization of our health services, and particularly the public health services. I'm glad to say that, you know, Germany has now said that they would invest 4 billion euro into updating the public health infrastructure, including the digitalization. I mean, we are in the Middle Ages compared to Taiwan. There is no question about that. And we live with fax machines. Do you know what a fax machine is? I mean, come on. And the third thing is the population. I think we need a much better debate in our part of the world, and I hope we can learn from you there, because you're a democracy and still these digital tools work and people accept them. We need to learn to understand in our democratic debate how the digital can support us in health, both in crises and in normal health. Because, you know, there's so many dimensions that have now been pushed through COVID-19. I mean, nobody in Germany or in Switzerland wanted telemedicine, you know, particularly the physicians. And, you know, now it's sort of become matter of fact. And so we're sort of seeing that a crisis also pushes innovation. But we're really far behind, both globally. We have no rules. We have no rules whatsoever. And we must ask who should set those rules, the World Health Organization, a new organization, the World Trade Organization. We have not addressed this issue. And that is really important as the internet splinters. You know, there's sort of a US internet, a Chinese internet. Europe is building sovereign digital sovereignty. So how do we bring that together? Thank you.
Well, thank you. Anyone from here or online? I just want to make sure that I properly exercise my duty as the mother. Okay, there's one gray. Okay, 那个 邱署长吗？是，不好意思。
Yeah, I only ask when no one asked.
Good, thank you for being
Hi,
supportive.
Ilona, I'm Shuti. There are two questions I'd like to ask. You mentioned the initiative of economy of well-being developed by OECD and now supported by Finland. But in the other hand, some people worried that even within the field of public health, people worried, where will the money go after COVID-19? Will we place more money in health care or in public health? And will we place more money in communicable disease control or non-communicable disease control? Where will the money go, and how do we make the right thing happen? The second question is regarding the realization of economy of well-being. Whom would be the target audience for public health training or education? Who are our target audience to engage, to make economy of well-being realized? Thank you.
You have both questions, right? Clearly announced. Professor Burkish, can you push? You got it?
Yes, thank you very much. I will try and give a response. I think where will the money go? It's partly depends on the political decision makers in the countries, as you've indicated. And we're seeing different shifts. I've already mentioned what is happening in Germany, which, you know, has a very developed, very expensive health system. I think it's the third most expensive in the world. But with an enormous number of doctors' visits and whatnot. And also OECD severely criticized Germany because of its high number of hospital beds. For a moment during COVID-19, this is actually helping Germany, and Germany can take in patients from other European countries who do not have the space anymore. So what we've seen is this first move to actually strengthen the public health system. We've been pushing for this for 20 years. It was COVID that has now made it possible. And, you know, in crises, there's always this, the possibility for something bad happening or for a push for innovation. So at least in Germany, we're seeing a very, very strong innovation push, both for digitalization and for strengthening public health, and actually for revisiting the organization of hospitals. You know, think of the supplies that are necessary, and you know, those kind of things. Strangely enough, also the COVID-19 has led to higher attention for non-communicable diseases, because initially, you know, people spoke about preconditions. Nobody quite knew what preconditions were. And then people said it's people with diabetes, with cancer, with heart disease. And the concern is now very high that on the one hand, these people are not being treated because of COVID. On the other hand, the attention that we cannot afford to have such a population with such high rates of NCDs in view of pandemics is becoming part of the political debate. So we are hoping at least that this moves forward. And also we can see on by the WHO, the NCD debate has actually increased significantly since COVID-19 than before. So we must actually use that to take that forward. But the key thing, you know, and that relates to your second question, is how do we deal with the inequalities? How do we deal with the social determinants of health? And, you know, despite high infection rates, some of the European welfare states were able to deal better with some of the social impact because of the welfare state system. So I think, you know, an economy of well-being can actually be part of this, you know, making our democracies pandemic-proof. Because if we include infrastructures that keep people healthier, that improve their well-being, then and improve the democratic debate, then in a way we are all better prepared for any kind of crisis that comes along. So in my mind, that must be a focus.
Great. Just for your information, our Deputy Minister from the Ministry has been here with us since the very beginning of the plenary session. But it is out of my capacity to know whether he would be interested in addressing or responding to those inquiries later. That is very much policy and linked. But I was told by the by our staff that it's only 2 minutes. There are 2 minutes left for the session. So we'll be looking for the last. Okay, is there one? No. Yes, in the back, please. Okay, you have the opportunity for the very, very precious last questions to be asked on this session.
Thank you. That's my pleasure. Hello. My name is Lin Pingham. I'm a student from Taipei Medical University. We all know that each country has its own expertise, and in addition to the development of scientific knowledge, what other anti-epidemic measures are more suitable for international cooperation than the development of each country? Thank you.
And right, international opportunity for international collaborations, right? 对不对？您的问题对不对？
对，就是我想，需要我再用中文复述一次吗？
不用。I think it's probably okay. I think we got the idea. So the focus. 好，
谢谢。
梁院长来一下。
Make sure I understand the questions. So what's the opportunity for, in the midst of COVID-19, for international collaboration in terms of research? Is that the question? 还是你用中？
就是我想要问的部分是
What I would like to know is what countermeasures we can adopt internationally, jointly, which will work better than measures developed by respective countries.
这个是不是应该是Director General Wang?
Yeah. Do you want to have the feedback? We'll leave this for yes, maybe for Dr. Kibush to comment. There's a graduate student from a medical school, so we appreciate her courage and enthusiasm on this. I think she was wondering.
Very nice.
Yeah, she was wondering. Maybe you have a much more fresh perspective than we are sitting here. Among all the sort of quarantine or anti-pandemic measures that we have taken, there are many, many different measures are involved in this battle. Which one of them or which type of this measure would be most ideal for international collaboration rather than country taking on their own sort of agenda or efforts or putting on their momentum? Yeah.
Well, you know, a priority is obviously to work together in all the international fora, to work together in the World Health Organization, to, you know, share knowledge as we are doing here at this forum. I think one of the really great things that has developed during COVID is a significant increase in scientific cooperation. That has really gone up like that. It is also partly related to a push through a new science advisor, chief scientist that the WHO created, a very important move. And you know, there are three big pillars of scientific cooperation, one on vaccines, one on diagnostics, and one on therapeutics. This has never happened before. And I think one of the things we will need to do is, first of all, keep those pillars very open for many different partners. You know, it's not only states, it's scientists, it's foundations, it's private sector, really pushing all the intellectual capacity that the world has together here. And if we can institutionalize that kind of scientific cooperation more strongly, we will move forward. Thank you very much.
Okay, thank you. I think we are over time. And with that, I want to particularly thank Dr. Kibush, joining us real-time online from far away. And there are already many lessons learned. So let's not lose the opportunity to change for the better and motivated by a new innovation, and so that we would have a much better prepared future. Thank you.
A big round of applause to our moderator, Professor Su, to our panel speaker, Professor Liang, and also Professor Kibush. Thank you very much for your time. Thank you again, and have a good day there. Thank you so much. Thank you. All right, ladies and gentlemen, 2020 Global Health Forum in Taiwan is coming to an end, and we are very happy that the Deputy Minister of Health and Welfare, Dr. Huey-Herng Sheu, is here with us, and he's going to give us a closing remark. And also just then, he had have to answer a few questions also on the stage, right? Left by Professor Su and also our audience. All right, ladies and gentlemen, right now, please join me in welcoming Dr. Sheu to the stage. 各位现场贵宾，接下来呢，让我们掌声有请会议主办单位卫生福利部学位员次长为我们致闭幕词。次长有请。 再次掌声欢迎次长。
Distinguished guests, ladies and gentlemen, good afternoon. On behalf of the Ministry of Health and Welfare, I would like to thank our invited guests, speakers, colleagues, and all audience for your participation and support. And, and for exploring together how innovation, inclusion, and partnership have achieved the sustainable developmental goals in the post-pandemic era. I would like to thank for the support from the Ministry of Foreign Affairs and Health Promotion Administration for organizing this event, and our department and administrations for planning the events to make this forum happen when the world is still facing the threat of COVID-19. This is also the first time that this forum featuring virtual presentation by experts from regions like Europe, the United States, Australia, and Japan, which showcased how everyone can work together to combat COVID-19. The two-day forum discussed how SDGs can be achieved, and also how resilience and humanity in healthcare systems, society, and economy plays a role in the ongoing COVID-19 pandemic. The forum also featured discussions over issues including non-communicable disease, environmental health, and health equity, and international collaborations. Moreover, the parallel sessions examine in-depth specific issues of sustainable development, such as innovative technology for active aging, integrated age-friendly healthcare, childcare environment, patient-centered care, health promotion hospitals, and the health promotion of estimated the more than 500 participants from government agencies, medical institutions and associations, civil societies and academic institutions, as well as local and international students have attended the forum. There was totally about 1,000 participants from 26 countries join us online. So we are grateful for all your support and participations. Lastly, I wish everyone to stay healthy and safe. Thank you, and hope to see you again, especially next year. Thank you very much.
Thank you once again to Deputy Minister of Health and Welfare, Huey-Herng Sheu, for his closing remark. Ladies and gentlemen, 2020 Global Health Forum in Taiwan closes right now. We'd like to thank all the speakers on site or online for their valuable inputs. Let's give them another big round of applause. 我们再次掌声谢谢我们2020年台湾全球健康论坛所有讲师精彩的简报以及分享哦。Most importantly, we thank you very much for your participation. We hope to see you next year. Thank you again. 再次谢谢大家，我们明年再见，谢谢。And a reminder for everybody, please don't forget to return your headsets back to the front desk. And don't forget to bring your personal belongings with you. Thank you again. 提醒各位现场贵宾，如果您有借口译设备的话呢，请记得归还，同时随身物品也不要忘记了。See you next year.